जब तक जिए हम, जिंदा रहे हम, धूप हो शाम हो चलते रहे हम। जब तक जिए हम, जिंदा रहे हम, धूप हो शाम हो चलते रहे हम।
जिंदगी की राहों में फूल हो या हो कांटे, कदम कभी रुके नहीं, चलते रहे, बढ़ते जाए हम।
छोटी सी मुस्काने गाने दो चेहरे पे इस दिन को, खुल के तू जी लेना ओ यारा, कल की तो बातें हाँ कल की है, इस दिन को खुल के तू जी लेना ओ यारा मेरे यारा। जिंदगी क्या है कोई सपना या एक जुनू, जब छाए गम के बादल।
ओ जिंदगी वो है जो है हर पल में, हंसते तू बस थामे इसका हाथ चल।
चलेगी फिर हवाएं, बदलेगा मौसम, रास्ते लंबे हैं रुकेंगे ना कदम। मुश्किलें आती है जाती भी है, इनसे झुकेंगे ना हम। उम्मीद के साथ आगे बढ़े, जीने के लिए ही है हम। जब तक जिए हम, जिंदा रहे हम, धूप हो शाम हो चलते रहे हम। जब तक जिए हम, जिंदा रहे हम, धूप हो शाम हो चलते रहे हम।
जिंदगी की राहों में फूल हो या हो कांटे, कदम कभी रुके नहीं, चलते रहे, बढ़ते जाए हम।
छोटी सी मुस्काने गाने दो चेहरे पे इस दिन को, खुल के तू जी लेना ओ यारा, कल की तो बातें हाँ कल की है, इस दिन को खुल के तू जी लेना ओ यारा मेरे यारा। छोटी सी मुस्काने गाने दो चेहरे पे इस दिन को, खुल के तू जी लेना ओ यारा, कल की तो बातें हाँ कल की है, इस दिन को खुल के तू जी लेना ओ यारा मेरे यारा।
नमस्कार और बहुत बहुत स्वागत है आपका दी कैंसर कॉन्क्लेव 2025, जो कि तीसरा एडिशन है। यहाँ हम बात करते हैं कैंसर से जुड़े तमाम पहलुओं की, और ये एक ऐसा अनोखा प्लेटफॉर्म है जहाँ पर हम बात करते हैं पेशेंट्स के भले के लिए। और ये जो प्लेटफॉर्म है वो रन किया जाता है पेशेंट्स के द्वारा, पेशेंट्स के लिए, कैंसर पेशेंट्स और केयर गिवर्स सभी को, और जितने भी सारे हमारे स्टेक होल्डर्स हैं कैंसर में, हम उन सबको साथ लेकर चलते हैं और बात करते हैं कैंसर की। मेरा नाम है विवेक शर्मा, मैं एक सोशल एंटरप्रेन्योर हूं और काम करता हूं कैंसर और मेंटल हेल्थ डोमेन में। और जैसा कि आप सब जानते हैं कि आज वर्ल्ड कैंसर डे है। बहुत ही अहम दिन है उन सभी लोगों के लिए जो कहीं ना कहीं किसी न किसी तरीके से कैंसर से जुड़े हुए हैं। हमारे साथ एक बहुत अनूठी आई वुड से टीम है जो आज डिस्कशन करेगी। हम बातें करेंगे कैंसर की, और जो बातें हैं, अगर हम शुरुआत करते हैं किसी ऐसी चीज़ की जो इतने इमोशनल, इतने कॉम्प्लेक्स पहलुओं से जुड़ी हुई है, तो सबसे ज़रूरी होता है उसके बारे में समझना। और वो समझ हम तब समझ पाते हैं जब कोई ऐसा व्यक्ति बात करे, या तो हम कभी उस रास्ते से गुजरे हों, या किसी ऐसे व्यक्ति के साथ हम बात करें जो उस रास्ते से गुजरे हों, तो क्लैरिटी जो है थोड़ी बेहतर हो जाती है। और जैसा कि आपने एजेंडा में देखा होगा कि जो पहला सेशन है वो इनागुरल सेशन होना था डॉक्टर स्वस्ति चरण का, जो कि डायरेक्टरेट ऑफ गवर्नमेंट हेल्थ सर्विसेज से आते हैं नई दिल्ली से, बट सर इज़ बिजी, सो हमने एक सेशन जो है स्वैप किया हुआ है। तो आज हम शुरुआत करेंगे। एक्चुअली ये शुरुआत बहुत अनूठी है, बिकॉज आज हम शुरुआत करेंगे संगीता रवि प्रकाश जी से। और मुझे वो दिन याद आता है कि जब 2 साल पहले हमने ये शुरू करा था। ये आज ये हमारा तीसरा एडिशन है। पहले एडिशन में जो इनागुरेशन था वो रवि प्रकाश जी ने ही करा था, एंड ही वाज वेरी डिलाइटेड, बहुत गौरवान्वित थे रवि। उन्होंने ये बताया कि लाइक एक ऐसा अनूठा प्लेटफॉर्म है जो पेशेंट्स लोग जो हैं वो शुरुआत करते हैं। एंड मैं थे इसलिए बोल रहा हूँ क्योंकि अनफॉर्चुनेटली रवि आज हमारे बीच नहीं है, लेकिन रवि अपनी परछाई, अपने सिद्धांतों को हमारे बीच भली भांति प्लांट करके गए हैं। संगीता जी नमस्कार और बहुत बहुत स्वागत है आपका। और
नमस्ते सर।
मैं चाहूँगा कि आप हमें बताइए कि कैसे जो है ये जर्नी रही है और क्या चीज़ें जो है हमको समझनी चाहिए बिफोर वी एक्चुअली गेट इनटू द कॉन्क्लेव मोड।
सबसे पहले आप सभी को मेरा प्रणाम। सर, मेरा नाम संगीता है। मैं एक हाउसवाइफ हूँ। मेरे हस्बैंड रवि प्रकाश झारखंड रांची से बीबीसी के लिए काम करते थे। 30 जनवरी 2021 में उनको लंग कैंसर हुआ। आज वो हमारे बीच नहीं है। मेरा एक बेटा है, उसका नाम प्रतीक है। वो अभी बेंगलोर में जॉब कर रहे हैं। मैं अभी उन्हीं के साथ रह रही हूँ। सर, 30 जनवरी 2021 यानी आज वर्ल्ड लंग कैंसर डे है। आज से 5 रोज पहले की बात होगी जब कैंसर डिटेक्ट हुआ होगा। 30 जनवरी 2021 में मेरे बीमारी का पता चला। सर, उस समय कुछ समझ में नहीं आ रहा था, क्योंकि उनकी कोई ऐसी हैबिट भी नहीं थी कि कैंसर हो जाए। वो भी 4th स्टेज में पता चला। कैंसर सुनना सर, केयर गिवर, ये सब कैंसर होने के बाद ही सारी चीजों का अनुभव हुआ। उस समय सब कुछ जानने के बाद एकदम से डार्क था। कुछ समझ में नहीं आ रहा था कि ये बीमारी है तो इसका इलाज कैसे होगा, कहाँ होगा, कितना खर्चा होगा। क्योंकि एक बेटा है, उनका एडमिशन जो है आईआईटी दिल्ली में हाल ही में हुआ था। तो हम लोगों के मन में थोड़ी सी खुशी थी। बस एक बेटा था, उनका आईआईटी क्रैक था, एडमिशन हो गया था। बस फी देना था और पढ़ाना था। तभी बीमारी का पता चला और उस वक्त सर कुछ समझ में नहीं आ रहा था कि ये इलाज कैसे होगा, कहाँ होगा, कितना खर्चा होगा। सब कुछ शून्य था। धीरे धीरे सर एक फरवरी को बातचीत फैमिली से करके 1 फरवरी को वो मुंबई आए। हम लोग उस समय, हम और हमारे बेटा जो है रांची में ही रह गए थे। मेरे भाई जो हैं डॉक्टर हैं, डॉक्टर पुष्पराज, वो, और मेरी सिस्टर इन लॉ पुणे में रहती हैं, वो मुंबई उनके साथ थी। मेरी बात फोन से होती थी। जब वो रांची में डॉक्टर नीतीश कुमार बताए कि इन्हें 4th स्टेज का लंग कैंसर हो सकता था, उस वक्त ऐसा लग रहा था कि हो सकता है कि कैंसर नहीं भी हो, क्योंकि क्लियर नहीं था। लेकिन मुंबई आने के बाद जब टेस्ट हुआ तो पता चला कि नहीं, क्लियर है, इन्हें 4th स्टेज का कैंसर है। और उस वक्त सर पैसा भी उस हिसाब से, हम लोग चूंकि मिडिल क्लास फैमिली है, कैंसर एक इतनी खराब बीमारी है कि अगर वो किसी को भी हो जाए तो सबसे पहले इंसान को यही लगता है कि अब लाइफ बचेगा नहीं। चाहे जिनके पास पैसा हो भी नहीं हो तो भी एक ही फीलिंग्स रहती है, एक डर कि कैंसर है तो अब लाइफ नहीं है। भले बाद में ही पता चलता है कि ये क्योर हो सकता है, चाहे इसका सर्वाइवल इतना है, इसमें इतनी खर्च है, ये सारी चीजें बाद में होती है क्लियर टाइम के अनुसार। लेकिन सडनली जब पता चलता है तो ये इतना दुख और इतना डर पैदा होता है कि कुछ समझ में नहीं होता है। धीरे 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 सर ये समय के अनुसार क्लियर होता है। सर 1 महीने लगभग वो मुंबई में रहे, हम रांची में रहे, फोन से बात होती थी। उनके लिए जो मेडिसिन तय हुआ डॉक्टर के हिसाब से, वो सिनेटेनिक था, जेप्टेनिक प्लस कीमो था, जिसमें वो सिनेटेनिक हम लोग अफोर्ड नहीं कर सकते थे, क्योंकि 5 लाख की दवा जो है, बच्चे को पढ़ाना, घर की जिम्मेदारी, कमाने वाले सिर्फ मेरे हस्बैंड ही थे, उनको बीमारी भी देखना था, जिम्मेदारी भी संभालना था, सब कुछ उन्हीं के ऊपर था। वो 5 लाख की दवा हम लोग अफोर्ड नहीं कर पाए, वो जेप्टेनिक प्लस कीमो पर को चुने और उस मेडिसिन से वो 3.5 साल सरवाइव किए। हर 3 महीने पर हमें मुंबई जाना होता था, मुंबई जाते थे, 4 या 5 कीमो का साइकिल बनता था, फिर आते थे, हर 21 दिन पर उनका कीमोथेरेपी होता था। इस तरह करते करते सब 3.5 साल तक मतलब उस दवा पर अच्छे से रहे। कुछ साइड इफेक्ट होते थे जिसको मैनेज किया जा सकता था, लाइफ अच्छी चल रही थी, ऐसा नहीं था कि नथिंग से समथिंग वाला, कुछ न रहने से कुछ होना वाला। कम से कम इतना टाइम तो मिला जिसमें वो हर चीज को एक सिस्टेमेटिक तरीके से प्लान कर दिए, जो कि मेरे लिए आज के डेट में बहुत इजी हो गया है। इतना टाइम भगवान जरूर दिए, और डॉक्टर्स लोगों को बहुत बहुत धन्यवाद अपने टाइम के लिए, कि इतना में मेरा जितना होना चाहिए उतना आज के डेट में हर चीज प्लान करके उतना समय मिल गया, जो कि मिल गया है। आज बेटा जो है जॉब कर रहा है, तो जितना जैसे चाहिए वैसा हो गया। हो सकता था कि उनकी डेथ 6 महीने में ही हो जाती, ये भी बात है, लेकिन 6 महीने के बजाय अगर 3.5 साल टाइम मिला और हमारी सारी चीजें अगर प्लान के थ्रू सही हो जा रही है, तो हम इसके लिए डॉक्टर्स और ईश्वर का बहुत 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 धन्यवाद करती हूँ। तो 3.5 साल के जर्नी में हम लोग बहुत एक दूसरे को टाइम दिए, बहुत इजी तरीके से लाइफ को रखे। बेटा की पढ़ाई भी चल रहा था, उसके ऊपर किसी तरह का कोई कोई स्ट्रेस उसको नहीं था। बस हम दोनों अपना मिलकर घर की जिम्मेदारी, बीमारी को संभालना, सही टाइम से मेडिसिन लेना, डॉक्टर के फॉलो अप और सही तरीके से जाना आना, ये सब करते रहे। सच्ची सर, कभी कभी ऐसा होता है कि मानसिक रूप से आदमी शारीरिक रूप से फिट रहता है, लेकिन मानसिक रूप से वो फिट नहीं हो पाता है। जैसे अचानक से अगर पता चले कि तबीयत खराब हो गई, चाहे उसका मेन लक्षण था कि बीमारी का खांसी आना, इंसान को कभी कभी डर लगने लगता था कि बीमारी प्रोग्रेस तो नहीं हो गया, तो जल्दी से आदमी इंतजार करता था कि कितनी जल्दी मतलब सिटी स्कैन का डेट आए, मुंबई जाए और सिटी स्कैन हो। स्कैन के बाद एक राहत महसूस होता कि चलो 3 महीने अब कुछ नहीं होगा, क्योंकि बीमारी जो है स्टेबल है। इसी तरह करते करते सर जून 2024 में 4 या 5 जून को सिटी स्कैन हुआ, तो पाया गया कि उनका ट्यूमर जो है प्रोग्रेस कर गया है, मतलब बीमारी प्रोग्रेस कर गया। और जो पुराना वाला प्रोटोकॉल था उसको जो है रोक दिए डॉक्टर। बोले कि फिर से बायोप्सी होगा, फिर से मॉलिक्यूलर टेस्ट होगा। उस समय उनकी तकलीफ यही थी कि खांसी बहुत ज्यादा हो रही थी, तो खांसी के लिए वहीं फॉरेक्स एक मेडिसिन था, सिरप था, वहीं उनको दिया गया। उनका ब्लड ले लिया गया सैंपल, क्योंकि पहली बार डॉक्टर्स बोले कि ब्लड से ही हम बायोप्सी करेंगे, कुछ अगर मिल जाए तो फिर से प्रोटोकॉल, फिर से मेडिसिन नया चलेगा। दोबारा 20 जून को सर दोबारा हमने एक बेटे के साथ हुआ है, उससे कुछ नहीं हुआ। फिर डॉक्टर कुमार प्रभास सर बोले कि नहीं, चेस्ट बायोप्सी होना चाहिए, चेस्ट बायोप्सी होगा। उनका फिर से बायोप्सी होगा। खांसी सर उनको बहुत ज्यादा थी, तो उनको जो है एक कीमो, चूंकि 12 या 13 घंटा उनको कीमो चढ़ा खांसी को रोकने के लिए। फिलहाल उनको वही कीमोथेरेपी चलाया गया, तो थोड़ा राहत उनको हुआ। और हम लोग बायोप्सी का इंतजार कर रहे थे कि कब, मतलब कुछ बायोप्सी में कुछ निकले, कुछ मॉलिक्यूलर टेस्ट में निकले, फिर से मेडिसिन बने। अभी ये सब चीज का वेट हो ही रहा है। तब तक सर 30 जून को उनको ब्रेन में बीमारी चला गया। मतलब प्रोग्रेस में था, जब प्रोग्रेस हुआ तो प्रोग्रेस होता रहा। फिर 2 3 4 5 6 5 साइकिल उनको रेडिएशन हुआ। इस बीच में सर पता चला कि कैंसर जो है नॉन स्मॉल सेल से स्मॉल सेल में बदल गया है, जिसका कोई मेडिसिन नहीं है। ये रेयर है, डॉक्टर के हिसाब से ये रेयर है, ऐसा होता नहीं है। तो मेरे हक में तो सर देखा जाए तो सब सब चीज रेयर ही था। कुछ खाते पीते नहीं थे तो कैंसर हो गया, हुआ तो 4th स्टेज में पता चला। कैंसर नहीं बदलता है, फिर भी हुआ तो स्मॉल सेल, नॉन स्मॉल सेल से स्मॉल सेल में हो गया, जिसका कोई मेडिसिन नहीं था। मेरे पास कोई ऑप्शन नहीं था सर। उसके लिए सिर्फ एक ही था कि वहीं 12 घंटा कीमोथेरेपी किया जाए। हम देखे सर कि एक कीमो चढ़ने के बाद उनकी स्थिति बहुत, मतलब शारीरिक रूप से वो डाउन हो गए। जो चलने फिरने में उनको दिक्कत होने लगी, उनका हाथ पैर कांपने लगा, डाइट चला गया। यही थी कि खांसी जो है, खांसी में बहुत आराम मिला, तकलीफें कम हो गई, लेकिन सब कुछ ठीक नहीं था। तभी लोग कार्टी सेल के थेरेपी के लिए, चूंकि वही था, किसी को उसमें एक उम्मीद सा था कि नहीं, इसमें लाइफ है, ट्रीटमेंट होना चाहिए। इसमें चूंकि ऑप्शन वही था, कोई मेडिसिन नहीं था, वो कार्टी सेल में ही था, तो डॉक्टर्स लोग किराए से वो कार्टी सेल के लिए फिर हम लोग तैयार हुए। सर कार्टी सेल के लिए भी तैयार होना बहुत मुश्किल था, क्योंकि इतना आसान नहीं था उसकी उस चीज के लिए तैयार होना। लेकिन एक होप उसमें दिख रहा था कि इसमें पेशेंट अच्छे हो जाते हैं, कुछ न रहने से कुछ कराना उचित हम लोग समझे। फिर हम लोग मुंबई आए पार्टी सेल के लिए। जून 22 को आए, 24 जून को थाने में टाइटन मेडिसिटी में कार्टी सेल के लिए एडमिट हुए। 2 सेल चढ़ने के बाद फिर से उनका थेरेपी हुआ, सीटी स्कैन हुआ, फिर से बीमारी प्रोग्रेस था। ये उनका तीसरा प्रोग्रेशन था। उम्मीद सर बहुत लास्ट समय वाला ठीक वैसे ही था जो स्टार्टिंग में था। जो सीन स्टार्टिंग में था कि कुछ समझ में नहीं आ रहा था कि क्या करे ना करे, बीच का तो सब ठीक था। एक प्रोटोकॉल बन गया था, कीमोथेरेपी हो रहा था, उसमें लाइफ आदमी मन ही मन अपना संतोष कर लिया था कि यही है, इसी में जीना है, इसी में अच्छे से रहना है। अब कैंसर हो गया तो क्या कर सकता है। ये 3.5 साल का जर्नी उतार चढ़ाव के साथ ही ठीक था, लेकिन लास्ट वाला फिर से बहुत ज्यादा चुनौतीपूर्ण हो गया, क्योंकि जब सेल चढ़ने के बाद भी बीमारी प्रोग्रेस हो गया। फिर से डॉक्टर्स लोग बोले कि एक बार कीमो और कार्टिसेल लेकर देखते हैं कि क्या होता है। फिर उनको कीमो प्लस कार्टिसेल चढ़ाया गया। ये कीमो के साथ कार्टिसेल दोनों मेडिसिन चढ़ाया गया। 2 सेल वो भी चढ़ा सर। 2 सेल चढ़ने के बाद उनको पेशेंट एडवोकेसी के अवार्ड के लिए यूएस जाना था, तो डॉक्टर उसके लिए तैयार करके उनको वहां जाने के लिए भी तैयार किए। वो गए, अवार्ड लेकर आए। 13 सितंबर को हम लोग मुंबई आए। 16 सितंबर को हम लोग एडमिट हुए। 17 को उनको फिर से सेल प्लस कीमोथेरेपी चढ़ा और सिटी स्कैन हुआ। सिटी स्कैन में फिर से बीमारी से प्रोग्रेस पाएगा। मतलब जब प्रोग्रेस हुआ तो प्रोग्रेस जून से जो हॉस्पिटल का चक्कर लगा और प्रोग्रेस जब हुआ उनका, तो प्रोग्रेस बीमारी होते चला गया। और 18 तारीख को उनकी तबीयत बहुत खराब हो गई। 19 को वेंटिलेटर पर है और 20 को वो हम लोग के बीच से चले गए। सर यही 3.5 साल का जर्नी था, जो कि जब ट्रेनिंग प्लस कीमो में जो 3.5 साल जब तक बीमारी रुकी हुई थी, तब तक एक होप के साथ, एक हंसी खुशी के साथ स्वीकारते हुए लाइफ चल रही थी। स्टार्टिंग में जो था वही लास्ट पीरियड में हुआ, क्योंकि जून के बाद जब प्रोग्रेस हुआ बीमारी तो सब रुका नहीं। अगर कैंसर स्मॉल सेल में नहीं बदलता डॉक्टर के अनुसार, तो फर्स्ट लाइन, सेकेंड लाइन, थर्ड लाइन, फोर्थ लाइन भी कीमोथेरेपी होता है उन लोगों के हिसाब से, तो उसमें 1-1.5 साल तक लाइफ बचाया जा सकता था। लेकिन दुर्भाग्यवश वो कैंसर स्मॉल सेल में हो गया, जो कि हमारे किस्मत में नहीं दिन का साथ था, तो हमारे बीच से चले गए। यही सब था सर।
थैंक यू सो मच संगीता जी। इट वाज लाइक कैसा होता है कि कई बार हम चीज़ों को जो है एक डिफरेंट एंगल से देखते हैं, लेकिन एक ही चीज़ को देखने के कई सारे नज़रिए होते हैं। आपने वो नज़रिया दिया जो एक एज अ केयर गिवर आपने फील किया। और आई अंडरस्टैंड कि किसी के जाने के बाद बहुत सारा वॉइड हमारे जीवन में रह जाता है, लेकिन हमारे कंट्रोल में इतना ही होता है कि हम उन चीज़ों में से क्या चीज़ें चुन सकें और उन संदेश के साथ में या उन चीज़ों के साथ हम आगे बढ़ सकें। धन्यवाद आपका, बहुत बहुत शुक्रिया। आप कहीं जाइएगा नहीं, बने रहिएगा हमारे साथ, क्योंकि और भी पैनल्स हैं आगे और संयुक्ता जी भी हैं जो कि एक सेशन में शायद आपसे मुखातिब होंगी। हमारे साथ नेक्स्ट पैनलिस्ट, हमारे साथ जो नेक्स्ट स्पीकर हैं डॉक्टर प्रशांत माथुर हैं। डॉक्टर प्रशांत माथुर डायरेक्टर हैं ICMR के। डॉक्टर साहब नमस्कार और बहुत बहुत स्वागत है आपका। आई वुड रिक्वेस्ट यू टू टेक ओवर।
Namaskar and thank you very much for this invitation. Truly, this program is tuned to a World Cancer Day and such a diversity. So, I'll share my presentation I have. Just a minute. Yeah. ये देख पा रहे हैं?
जी डॉक्टर साहब।
Okay. So, the topic which I had given was to address gaps in cancer care in India, and using the National Cancer Registry and other epidemiological data sets to identify what kind of gaps are we experiencing. So this is an overview. This may not be the entire list of everything, but just to give a starter to these discussions. This is a picture we should all keep in mind, that the cancer care continuum starts from prevention, screening, early detection, and moves on to diagnosis, treatment, survivorship, and end of life care. And we need partners and collaborations in all these sectors so that the journey of cancer does not become painful. And this continuum of care offers us several opportunities where we can intervene and make a difference in the lives of patients with cancer. The National Cancer Registry Program has been running for the last 44 years and collects data on cancers from across the country. And if you see this data set, this slide, you will realize that there is a huge difference in the occurrence of cancer across the country, both in men and in women. And this is a picture that we should keep in mind that India is a diverse country wherein every part of the country does not experience the same levels of cancer. Some are very high, especially regions in the northeastern part of the country. And there are regions where cancer is still at a lower level. But if we look at the distribution between males and females, it appears to be more or less similar. This is a picture to show the incidence and rise of cancer which occurs. So this is from the black bars are for males and the blue bars are for females. And if you look at the age specific rates, there is a sudden rise in the incidence of cancer. Incidence of cancer means when new cancers occur, when new diagnoses are made. There is a rise in the incidence of cancer around the age of 25 and 30, and it peaks between 55 to 65. And thereafter, in the women, equivalence happens around 60 years, and then the male cancers predominate, probably driven by the reproductive organs and other female-oriented cancers. This understanding is important for us to understand why and what are we dealing with. This is a table to show how our cancers increase with age. If you start, there are childhood cancers which occur in children who are below 14 years of age. And there are adolescent cancers which occur in children who are between 15 to 39, young adults, and senior citizens. It is very clear that the incidence of cancer rises sharply when people become adults and continues to rise as they increase in age. And at extremes of age, the cancer incidence goes down. But this is the age between 40 to 65 when we are most productive and most useful to our families and our society and productivity in the country that we should be concerned about. This is a picture, a publication which we brought out looking at cancers occurring in the age group of 15 to 39 years of age. If you see that the transition happens between childhood cancers of leukemia, lymphoma versus those cancers which occur in adults. Between the age of 30-39, there is a rise in the incidence of breast, thyroid, mouth, and tongue cancers. Now, these are cancers which occur typically in the adults, but the onset happens while in adolescent age groups. The elderly population of our country above 60 constitutes 11.2% of the population, but yet they contribute to around 48.2% of the total cancer incidence. Some of our activities and programs tend to ignore the senior citizens of our country. And this is a message which I would like to give across, that we need to continually focus on higher age groups so that we can tackle the cancer burden at that age group. Now, what are the cancers which are causing in males the highest numbers? This is mouth cancer, followed by lung cancer, tongue cancer, prostate, esophageal, and many others. Whereas the reasons for mortality or death are lung cancer, mouth, tongue, liver, esophagus. And we just heard the description given for lung cancer. And yes, lung cancer is rising very rapidly in our country and has to do something with not just tobacco use, but also with pollution, air pollution, particularly indoor air pollution. When you look at females, the number of cases of are highest because of breast cancer, which causes 31% of the burden, then cancer of the cervix, ovary, corpus uteri, and lung also. Whereas in mortality also, the same pattern is nearly seen, with breast cancer being the largest cause of deaths in women. So, what are we heading for? We are heading for a large number of cancers if we do not act now. In 2020, we estimated that there will be around 14 lakh new cancer cases, but if we don't do something, this year we should be experiencing more than 15.6 lakh cases, new cancer cases occurring in the country. And if you see, the major distribution will be around tobacco related cancer, whether it is smoking tobacco or use of smokeless tobacco related cancers constitute the highest proportion of cancers, then followed by gastrointestinal tract, cervix, breast, etc., etc. Over the last few decades, if we look at the overall picture of cancer, only two or three cancers are declining. One of them is cervix cancer, followed by esophageal and stomach cancer. But large number of cancers are increasing, and we should be aware that we will be facing a lot of more burden of cancer across the country if we do not act now. When we look at survival of patients in the community, for the left one is for cervical cancer, the 5-year survival after diagnosis in cervical cancer is around 52%. That means 52% of women diagnosed with cervical cancer survive for at least 5 years. And similar picture for breast cancer is 66%. This is far, far away from what many developed countries of the world experience, around 80 to 90% survival for these two cancers. We looked at our registry data, and one of the things which appears very prominently is the number of localized cancers are few. So if you look at the right chart, we realize that large number of cancers are in the purple or the red bar, which includes advanced stages of cancer. So roughly 60 to 70% of our cancers are diagnosed in advanced stages. This is a stage where treatments are complicated, expensive, needs better centers to go to, and in spite of best efforts, outcomes are not very good. It is also disturbing to know that 35% of patients who were diagnosed with cancer did not receive cancer directed treatment. So there is a lot to be done for bringing patients early to hospitals and starting treatment. When we look at survival of breast cancer, this is a figure to show that if patients who are diagnosed in stage 1 of breast cancer have a 5-year survival of 87.8%. As the stage of breast cancer increases from stage 2 to stage 3, and finally at stage 4, nearly 40% survive 5 years. So one can see how much stage dependent survival happens in breast cancer patients. There is another cancer which is very rampant in the northern part and northeastern part of the country, which is again a women cancer, gallbladder cancer. And if you see, compare it with the previous figure, you will see that This is a very, very aggressive cancer. So in stage 1, nearly 84% patients survive for 3 years, whereas in stage 4, only 3.5% patients survived for 3 years, not even 5 years. And this is a cancer for which we still do not know how to diagnose it early and how to bring patients to a treatment. So, what are the major reasons for delay in cancer care? There are four major broad headings. One, patient determinants, disease determinants, practitioner or doctor related, and system, that means the health system which provides. Now, this is not a blame game exercise that I am going to start, but rather we should learn and pick up matters which can be improved further. And this needs the whole of a society approach in addressing most of these problems. One problem is interconnected with another. These are not standalone problems. If you look at the patient awareness, uh, and this, because of the lack of the awareness in patients, health seeking is delayed and we see delayed diagnosis. The picture on the right shows that how delayed cancers are being diagnosed in our hospitals, and majority of them are in loco-regional stage. Half of the lung cancers are diagnosed when they have already spread to distant parts of the body. And a study showed that only 17% could identify signs of oral cancer. So this is a little disturbing figure. And reasons are many. I won't go into all of them, and I'm sure you all aware and would also add to this list. But these are determinants. If we act together, this will help us to understand where we can act for bringing patients uh, to the hospitals early and offering better diagnosis. There are disease-related delays. So most cancers start with complaints which are very common, loss of weight, loss of appetite, not feeling well, fatigue. And these are such indistinguishable symptoms from many other, like common fevers, diarrhea, and other cough and all, that people are not able to understand that they need to seek care. And this mimicking of disease symptoms in cancer is one of the major reasons why delayed care is sought. And then you have comorbidities, so pre-existing diabetes or a stroke or other diseases, they complicate this delayed diagnosis. And according to this study, there was a delay of almost 456 days in ovarian cancer, 321 for lung cancer, intestinal cancer, and so on. So before a appropriate treatment of cancer could be started. So patients are moving from left to right and are not able to discern where to go, how to go, and whom to rely on for a diagnosis. The practitioner also faces a problem, particularly those doctors and practitioners who are in the periphery, who are not well trained in picking up cancer symptoms and making a diagnosis. They overlook some of these symptoms because they mimic common diseases and common treatments are first offered. And then the referral system, which goes from one hospital to the other before a specific diagnosis can be established. These are some of the reasons why the practitioner related delays and systems. If our hospitals are not well equipped with diagnostic and treatment facilities, there is a lot of referral, and each referral there is a dropout. Patients do not have the strength and conviction to go to higher hospitals, and everybody cannot come to the 7 8 hospitals, big hospitals in the country. It is not easy. There are issues of economic constraints, family issues, how to handle them. So we must provide cancer diagnosis and care which is nearer to the residents of patients, particularly those living in rural areas, and then have very strong referral systems, not only for forward referral, but even for back referrals, because There is a lot of shared care which needs to be offered to these patients. Uh, for There are three cancers which the government of India has been screening: oral cancer for both men and women, but breast and cervical cancer for women who are aged 30 years and above. And we also did a survey in 2017 and 18, where only 1.7% of eligible people had undergone screening for oral cancer, 1.6 for breast, and 2.2 for cervical cancer. Very recently, the National Family Health Survey fifth round has also shown very dismal figure. So we need very strong and robust community-based cancer educational activities to encourage people to go ahead for screening of these cancers so that they can be picked up early. The system-led gaps, because we have shortage of comprehensive cancer centers. We have around 175 districts, which covers 40 to 45% of the population. And most important, since we are seeing a lot of late stage cancers, our palliative care is extremely dismal as compared to the Western world. We do not have enough medical trained doctors if you compare with the US and other developed countries. And even equipment wise, one of the benchmarks which is used is the number of radiotherapy machines per million individuals. We need to have one per million, at least one per million, but we have something around zero point 0.6 per million. So there is a shortage of equipment also. And the affordability of cancer treatment gets delayed because of high out of pocket expenditure. So a patient in a family who develops cancer, particularly if it is an adult, an earning member, there is a lot of out of pocket expenditure, due to which families go into distress financing and into poverty. This figure shows breast cancer and cervical cancer. The blue bar is for early stages. The brown bar is for the late stages. The cost of treatment is almost 1.6 to 1.8 times with advanced diseases. So affordability for treatment is a big issue faced by everyone. So a lot of cancer awareness programs and implementation of preventive strategies is required, particularly educating our population around the use of tobacco, alcohol, obesity, infectious environmental factors, and also air pollution, which is a new risk factor which is increasing day by day. For cervical cancer, we do have now the HPV vaccination, which, when rolled out as a part of public health program, would be available to all girls between age of 9 and 13. But then we need to take enough steps to encourage families to come forward to vaccinate their girls. Capacity building is something which will require a lot of efforts so that our peripheral health workers are trained enough to pick up early signs of cancer, early symptoms of cancer, and help in referring. And also, ICMR has been involved in creating and developing a lot of guidelines for treatment of common cancers. These guidelines are now available on an app so that any doctor can download the app. And when you have difficulty not being able to understand how to go ahead with the diagnosis and treatment of a cancer patient, you can please refer to these standard treatment guidelines. Basically, we would really like that the referral pathways across all cares should be strengthened so that there is a forward and backward flow of patients from one hand to the other. We are also strengthening the diagnostic services, particularly molecular markers for breast and lung cancer, so that to make them affordable, those patients who cannot afford, many hospitals, we are now part of the network which provides free molecular testing for these two cancers. We may add more. And then the use of technology like telemedicine, the ECO project, is a very good example of how we can communicate and engage with large number of people online, sitting at home, so that we could increase the penetrance of our awareness and education programs, even in remote areas. Making cancer drugs and cancer also need to spread the message that those who are eligible for any insurance or beneficiary scheme should come forward and avail those schemes so that they can be treated appropriately and in a timely manner. So, what is the way forward? I would summarize only three ways. We need to make cancer diagnosis early, help patients to navigate the pathways to reach the right doctor, the right hospital, and to increase the penetrance of treatment closer to home, especially for the rural areas, bring about cancer behavior change related to the risk factors, and encourage general practitioners of medicine to pick up cancer at much earlier stages. Till we reach that stage, we need to strengthen our palliative care and end of life care for those who are still with us and surviving the consequences of cancer and the treatment. We still need to get them together and create such wonderful coalitions of cancer survivors who not only encourage patients to come forward, but also give a lot of support to families who are experiencing a cancer patient in their with their immediate ones. So thank you very much for your kind attention and invitation, and I would be very happy to receive any feedback or your inputs so that we can strengthen our cancer prevention and control efforts. Thank you very much.
Thank you so much, Dr. Saab. I can't express my gratitude in words because, probably what you were talking and what we are facing is the same thing, or probably quite interlinked. But the good thing is that now I know that who I should go to for my mentorship, and who is the person to look forward. I'll stay in touch with you, and because we looking at the positive of the time today for such small session or kind of conclave for half a day. But there is a lot to learn from you, a lot to work together, and we being a patient support organization, we have a lot of we need a lot of guidance, we need a lot of support and ideas. We do have some. We'll brainstorm and we'll come together and we'll try to move this mountain in whichever way possible. Thank you so much, Doctor. Thank you so much. So grateful.
Thank you very much.
Now, may I request Sanjukta Sharma to be on the panel and invite her, panelists. Sanjukta ji herself is a cancer survivor, and she is a renowned journalist and has been advocating for cancer, rights. संयुक्ता जी नमस्कार और बहुत-बहुत स्वागत है आपका.
Thank you, namaskar everyone. Can everybody hear me?
Loud and clear.
Okay. Yes. Thank you, Vivek ji, and congratulations on this conclave, this very important conclave, and thank you for doing it for all of us in the cancer ecosystem today. First, I would like to welcome the esteemed experts we have on this panel today on, the role of advocacy in supporting newly diagnosed cancer patients. So first, Dr. Bhavna Sirohi, senior medical oncologist who's based in Raipur. Welcome, Dr. Sirohi. Thank you for joining us. Ms. Rashi Kapoor, she's the president of the Sachin Sarcoma Society. Thank you, Rashi ji. Welcome. Then we have Mr. Jose Peter. He's the founder of Arogya Finance. Thank you, Mr. Peter. And we have Dr. Minit Shah, medical oncologist at Tata Memorial Hospital. Thank you, doctor, for your time.
Thank you.
So, yeah, before I come to each of you with, our specific questions for you, a little bit of context, on the role of advocacy in this system. So as I was going through this presentation from Dr. Prashant Mathur, and it's so clear that, the solution that seems to be giving us the seems to be having the potential to give us real hope is prevention, screening, right? Awareness. So the role of the advocate, the consistent, articulate advocacy is so important in this ecosystem. So in my case, I'm a survivor of 8 years. I call myself a thriver. Grateful to God and all my support system. But I was lucky enough to, of course, have a lot of people support me, rallying around me, which is not the case, majority of the time, most of the time. And that's where the role of the advocate comes in. Even for myself, despite all the effort, I think my courage and hope really came from people who had gone through this journey and had turned, into advocacy. So that's where strength comes from for the patient, for the family. So let's, I think, first come to Dr. Sirohi. Doctor, you have been in this field, you've been an expert. So can you tell us how is cancer managed at the physician level across the globe, because you have experience abroad as well, and the difference or gaps you observe in the Indian healthcare system today? And, how far have we come in the last decade in sort of filling this gap, and how do you foresee the future in terms of accessibility to treatment?
Thank you, Sanjukta ji, and thank you, Vivek ji, for organizing this. And it's a pleasure to hear you talk about patient advocacy, because मैंने यूके में, लंदन में करीब 20 साल बिताए हैं, और इंडिया में मतलब टाटा हॉस्पिटल से हूँ, ट्रेनिंग वहां से 94 में शुरू करी और फिर वापस आई. तो पेशेंट एडवोकेसी जो है वो बहुत नेसेंट स्टेज पे है इंडिया में. और आप लोग हैं जैसे विवेक जी हैं, एंड आई हैव लॉट ऑफ कॉलीग्स अराउंड द कंट्री, तो हर मीटिंग में हम एक पेशेंट एडवोकेसी का सेशन हमेशा करते हैं. ये शहरों में तो आ रही है, और पर लेकिन गांवों में अभी भी पेशेंट्स एक्चुअली they, and because if they are on a universal health coverage scheme like Ayushman, they are so just grateful to be treated that they don't have any questions. They are like, jo karna hai aap karo. So this is what I lack compared to having worked in UK and India. So that is a big difference between globe and here, especially the Western countries and India. We lack robust patient advocacy and what we call shared decision making. When you have a treatment option that is given to a patient, तो बहुत जरूरी है कि एक informed choice ले patient, कि whether you want to prioritize risk with benefit, quality of life, quantity of life, all of these discussions are very, very important. So that is a big stark difference that we have between UK, let us say, and India. The patient financial decision making, financial toxicity is another thing. So in UK, we have a system of universal health coverage where I worked. So, finances never came into the discussion, very rarely. In India, yes, I mean, we are very lucky to have Ayushman Bharat scheme. And we're extremely grateful that, we have universal health coverage. But a lot of things are not covered in Ayushman Bharat. The diagnostics are not covered. There are huge gaps. Like, let's say the surgery for a head and neck cancer patient is covered, but the plastic surgery bit is not covered. So how is the patient going to go back into the society, if the plastic surgery is not done? So these are the stark differences. And of course, Dr. Mathur very eloquently spoke about, the cancer screening, which is like, I was in London. So the minute I turned 50, I got a letter saying that, you are due for a mammogram. When I went to UK in 98, I was sent a letter to have my pap smear done. Until I got the test done, I was hounded by the GP's surgery. कि आपने अपना टेस्ट नहीं कराया है, आके टेस्ट कराइए. सो द गवर्नमेंट आपका ध्यान रखता है. इंडिया में हमको क्या है कि हमें अपना ध्यान खुद रखना है, खुद ही जाके जो है स्क्रीनिंग करना है. जो आप ये सेशन आज कर रहे हो, आई एम होपिंग कि जितने ज्यादा लोग देखें और वो अवेयर हों कि क्यों आपको अपनी हेल्थ का चार्ज खुद ही लेना है. So these are the main differences, I think.
Thank you so much, Dr. Zoe. Such important points there. And especially those points where you said, lot is not covered. It's so true. In fact, I'm coming to Ms. Rashi Kapoor now. And I'd like to sort of start this with a recent survey that Uhapo itself has done on a patient survey. They found that more than 70% of patients that they talked to and they surveyed, they lack adequate insurance anyway. It's very obvious. So, Dr. Rashi Kapoor, I first want to ask you something basic, like how structured do you think, in your view, is cancer navigation today in our country? And why is it important? And what steps can we take to expand and improve this process of navigation? And do keep in mind about the lack of enough adequate insurance. And your first thoughts on this, please.
Thank you so much, Sanjukta. Thank you so much, Vivek ji, for inviting me. So first of all, I want to mention that I am a cancer survivor. I'm not a doctor. And my journey began in 2012 when I was diagnosed with first cancer, molar pregnancy. Then in 2016, I was diagnosed with another cancer, synovial sarcoma, very rare type of cancer. And I got to know at that time that this is a very rare cancer which happens to 1 in a million. So there was no awareness at that time because बहुत rare disease था, millions में किसी एक को होता था. I happened to go and meet Dr. Rastogi in AIIMS Hospital. And उस समय कोई ऐसा नहीं था कि कोई सपोर्ट ग्रुप नहीं था, कोई जानकारी नहीं थी. कैंसर इतना रेयर था, कोई नॉलेज नहीं था. खुद को बहुत लोनली फील होता था, एंजाइटी बहुत ज्यादा होती थी, लगता नहीं था कि किससे बात करें क्योंकि किसी को पता ही नहीं है कि बीमारी किस तरह की है. पेशेंट नेविगेटर कौन थे, ऐसे इसके बारे में कोई जानकारी नहीं थी. 2023 में मेरा एम्पुटेशन भी हुआ, बट इसके बाद हमने अपना ये सपोर्ट ग्रुप बनाया, सचिन सार्कोमा सोसाइटी, और इसमें हम काम करते हैं बहुत ज्यादा अवेयरनेस फैलाने में. सार्कोमा जो रेयर कैंसर है उसके अवेयरनेस के बारे में फैलाने में. एक पेशेंट जो ठीक हो जाते हैं, जब वो और लोगों से बात करते हैं तो काफी हिम्मत मिलती है, सपोर्ट मिलता है. जैसे आपने भी बताया कि जब आप और लोगों से मिली तो आपको काफी हिम्मत और सपोर्ट हुआ. मुझे याद है जब मैं कीमोथेरेपी मेरा हो रहा था और मैं किसी से मिली, मेरे बाल चले गए थे और मैंने किसी को देखा, एक बहुत स्मार्ट लेडी वेल ड्रेस्ड अप होकर आई, उनके सिर पे अच्छे बाल थे, तो मुझे बड़ी खुशी हुई कि ओके, she can get back to normal, I can also get back to normal. So navigation एक बड़ा important चीज है. टाटा मेमोरियल हॉस्पिटल मुंबई में केवट का एक प्रोग्राम चलता है जहां नेविगेशन होता है, वहां बताया जाता है. बट आई थिंक ओवरऑल कैंसर में नेविगेशन बहुत इंपॉर्टेंट है. तो जो भी सर्वाइवर्स हैं उनको बताना चाहिए, अवेयरनेस फैलाना चाहिए और जानकारी देना चाहिए. पेशेंट्स के साथ एक कंपेनियनशिप बिल्डअप करना चाहिए. जहां तक इंश्योरेंस की बात है, बहुत कई चीजें हैं जो इंश्योरेंस में चल रही हैं, लेकिन कुछ गैप्स हैं और आज मैं बात करना चाहूंगी उन गैप्स के बारे में. जैसे कि कैंसर जो है एक एक्सक्लूजन क्राइटेरिया है, मतलब कई चीजों में, कई जो हेल्थ इंश्योरेंस पॉलिसीज है उसमें कैंसर इज नॉट कवर्ड. सो ये एक बहुत बड़ा गैप है. सो जो भी इंश्योरेंस कंपनीज हैं, दे शुड टेक इट इनटू अकाउंट कि किसी को बीमारी हुई है, ये किसी की गलती की वजह से नहीं हुई है. रिफॉर्म्स शुड बी डन, शुड बी मेड इन अ वे के ताकि कैंसर जो है उसको इंक्लूड किया जाए और पेशेंट को सही मायनों में मदद किया जाए. क्योंकि जब पेशेंट डायग्नोज होता है तो उसको इमोशनली, मेंटली, फाइनेंशियली, हर तरीके से वो बहुत ज्यादा दुखी होता है, पीड़ित होता है, उसको बोझ होता है.
बोल सकते हैं, मेरा आवाज नहीं जाएगा.
एंड कई चीजें हैं जैसे कि डायग्नोसिस कवर्ड नहीं है, बायोप्सी जो है लेट डायग्नोसिस होता है, जानकारी उतनी नहीं होती, बायोप्सी कवर्ड नहीं है. ट्रीटमेंट के दौरान जो चीजें हैं वो भी कवर्ड नहीं होती. पोस्ट फॉलो अप है, दैट इज ऑल्सो not
Can I
covered.
interrupt for 1 second? Rupa ji, kindly mute yourself because getting disturbed. Mute कर लीजिए please. Thank you. Can you kindly mute पे रखिए please? Thank you. Please continue. Sorry for the interruption. Yes.
सो जो इंश्योरेंस के जो प्लान हैं वो कवर्ड होने चाहिए, और जो डिडक्शंस हैं, जो डिडक्शन होती है इंश्योरेंस कंपनीज में, जैसे कीमोथेरेपी होता है, पोर्ट लगता है, पोर्ट के मेरे टाइम पर जो भी हमारा खर्चा आया उसमें पोर्ट वाज नॉट कवर्ड, तो उसके डिडक्शन बहुत ज़्यादा हुए. सो ये भी एक सजेशन है फ्रॉम आवर साइड दैट कवरेज ऑफ डिडक्शन शुड बी लेस. एंड द मोस्ट इम्पॉर्टेंट थिंग इज कि जो भी रीइंबर्समेंट प्रोसेस होता है वो बड़ा कॉम्प्लिकेटेड होता है, टीडियस होता है, टाइम कंज्यूमिंग होता है. सो ये थोड़ा सा स्पीड अप होना चाहिए, ताकि मरीज को ये नहीं लगना चाहिए कि अरे मेरा इलाज हुआ है, तकलीफ हुई है, तो कम से कम मेरे हाथ में इतना पैसा होना चाहिए कि मैं उससे अपना इलाज जो है करवा सकूं. जहां तक गवर्नमेंट की बात है, गवर्नमेंट में भी जो पॉलिसी होल्डर्स हैं जिन्होंने स्कीम्स बनाई हैं, उन्हें भी कई चीजों पे काम करना चाहिए कि कैंसर जो है इस पे यूनिवर्सल कैंसर इंश्योरेंस सब सिटीजन्स को मिलनी चाहिए, चाहे जो मर्जी एज हो, जो मर्जी आपकी इनकम हो. अगर मान लीजिए कोई पेशेंट है जो कि ओनली ब्रेड अर्नर है ऑफ द फैमिली, तो ऐसा नहीं होना चाहिए कि उसकी जॉब चली गई, उसका कीमोथेरेपी हो रहा है तो उसकी जॉब चली गई. सो बेसिकली जैसे मैटरनिटी लीव होती है, बट लेडी को ये पता होता है कि हाँ मेरी जॉब सुरक्षित है, मुझे सैलरी मिलती रहेगी. इसी तरीके से कैंसर पेशेंट को भी ये एक आश्वासन होना चाहिए, एश्योरेंस होना चाहिए दैट द जॉब वुड बी सिक्योर्ड एंड सैलरी वुड बी गिवन. सो ये सब कुछ तभी पॉसिबल है जब हॉस्पिटल, डॉक्टर्स, सारे पेशेंट एडवोकेट्स जो एनजीओ के हैं, जो इंश्योरेंस पॉलिसीज हैं, अगर अपने अपने जो एग्जिस्टिंग पॉलिसीज है उसमें रिफॉर्म्स लाएं, गवर्नमेंट अपनी पॉलिसीज में रिफॉर्म्स लाएंगे, और सब जब मिलकर काम करेंगे, कोलैबोरेशन के साथ काम होगा, तभी आई थिंक इट वुड मेक अ बिग डिफरेंस. एंड जहां तक नेविगेशन की बात है, यस, मोर एंड मोर survivors should come forward and they should work on spreading awareness. They should spread on doing meetings where the doctors can come, they can give educational sessions. ये चाहे in person हो सकता है, और आजकल जैसे online है ऐसा भी हो सकता है. So जितना awareness होता है, जितना information लोगों को दिया जाता है कि early diagnosis is very important. एंड अगर आपको लंप या बम्प कैंसर का कहीं पर भी दिखाई देता है, कुछ भी एबनॉर्मल दिखता है, तो प्लीज डू कंसल्ट द डॉक्टर, गो टू द राइट डॉक्टर. पेशेंट को सही जानकारी देना कि आपको किस डॉक्टर के पास जाना है, क्या इलाज करवाना है, एंड पेशेंट को एम्पावर करना टू टेक द राइट डिसीजन आफ्टर टॉकिंग टू द डॉक्टर. ये चीजें बहुत इंपॉर्टेंट है.
Absolutely, very, very important points, Rashid ji. In terms of insurance, I want to just share one little thing. So after finishing my frontline, treatment, उसके बाद मुझे एक targeted therapy drug मिला था for 2.5 years. It was a very expensive drug for ovarian cancer. After my genetic test, it was called Linparza. It's a PARP inhibitor drug. So, I had a good insurance policy. I consider myself privileged. I have a good insurance policy. Even I had to deal with stuff like, a private insurance company, which charges good amount of premium from you. They refuse to cover that because it's a pill. There is no hospitalization for this. It is not an IV. It is a pill. I wrote to the health ministry. I went all over social media. Nothing came of it. So I think you're so absolutely right. People who have gone through the disease and have survived has to give back, has to do some advocacy. And nowadays it's so easy to amplify your voice, So absolutely. But here I would like to bring in Dr. Minit Shah from the clinician's perspective, which is also very, very important for us to understand, right? So Dr. Shah, thank you for your time. And could you please first tell us if you have seen real changes in cancer survival rates and access to treatment in our country? First basic point is that. And what barriers are you as a clinician still facing in this country? And are these challenges limited to, say, chemo-targeted therapy or also affect surgery and radiation? If you could just take over.
No, correct. So it's an absolutely valid question. And cancer survival rate improvement is actually directly proportional to the facilities and the access to care that we get. So even if we had a limited amount of care, if all the patients who were like suffering or having symptoms of disease, if all of them would actually visit the hospital and get treated, the survival rates would have improved right since like 10-15 years ago. But right now, the improvement in survival rates is because number one, there has been an improvement in the access to targeted therapies and immunotherapy. That is one. Although I would say it's not 100%, although many of these drugs are still costly, we need to import them. But there has been an improvement in the access to treatment. That is one. Secondly, we have a lot of support from NGOs, lot of support from Vivek ji, Sanjeev ji, all of our people who give social support and funding, and all of the NGOs who actually give money for these targeted therapies or immunotherapies. So I'll give you two examples, one from targeted and one from immunotherapy point of view. So the usage of immunotherapy from 2014 to 2018 was only 2%. That is, whether we give immunotherapy in full dose or in low dose, it was just 2 to 3%. When we analyzed our data over the last 5 years, that is 2019 to 2023, that number jumped to 23%. So definitely there is a shift or an improvement in the number of people who actually get access to this immunotherapy. That is one. So that directly translates to an improvement in survival. Secondly, look at simple drugs like ALK positive lung cancer and targeted therapy. Previously, only 50 to 60% of these patients actually could receive targeted therapy. But if we look at our data right now, roughly 80 to 85% of the patients are getting access to targeted therapy. We're getting even free access to patients to even higher drugs. Like previously, we used to get only crizotinib. Now we get the third generation ALK inhibitors also from NGO and social support funding, that is lorlatinib. So now almost 80 to 90% of patients do have. I'm sorry, audible? Am I still audible? Sorry.
Yes, you're audible now. Yeah.
Am I audible?
Yes. Yes.
Yeah, I'm really sorry. So in today's date, 80 to 90% of these patients do have access to ALK inhibitors. So one of the most important things that is translated to improve cancer survival is maintaining patient compliance, number one, encouraging them to visit to the hospital at first instance too. Yeah, that is the second one. Thirdly, when they come to the OPDs and they develop any side effects, it should not be that the patient stops the medicine or restarts the medicine at his own will. It should be that moment he develops a side effect, he should come to the doctor, get it explained, get the dosages corrected right, and then restart. So that in fact ensures continuity of care and compliance. That is very important. What are the challenges? So if we look at the first part is access to targeted therapy and access to immunotherapy. That is one challenge. And the government definitely has to step in because the prices of a number of these immunotherapy and targeted therapy agents are way beyond the per capita income of many of these patients. So if you look at the per capita income in 2023, it was roughly around 2 lakhs per year, means 16,000 per month. Most of these targeted therapies are around 40,000 to 50,000 per month. So that is way beyond the per capita income. What is the limit of an average Indian patient? That is one. Secondly, what are the other challenges? So one is access to care. Other challenges is attrition rates, or what do you say, loss to follow-up rates. So if we look at our center, even at Tata Memorial, if we start off with 100 patients who are diagnosed with lung cancer, if we follow them up at the end of 6 months, 40% patients are lost. If we look at the end of 1 year, nearly 50 to 60% of patients are lost, and you don't know where have they gone and what was the reason why they left. So patient motivation, that is one. Ensuring that they come to OPDs at regular intervals, that is two. Helping them meet with people who have suffered through the same disease really gives them motivation. Sometimes what happens is if they get one cycle of chemotherapy and there is so much of side effect that they stop taking further treatment. So they do not consult the doctor, they do not consult their other patients who are diagnosed with a similar condition. They don't do that. They just directly stop treatment. हमको बहुत side effect हुई, हमको आगे कीमो नहीं लेना है, हम घर जाते. So that is a universal mentality. Other, yeah. So other thing is, So the other thing is clinical trials. So many of these targeted and immunotherapy agents are provided in clinical trials. But what happens is patients have a mentality that clinical trial में जाएंगे तो उन लोग हम पे experiment करेंगे, हमको laboratory में लेके जाके कुछ अजीब और गरीब इंजेक्शन देंगे और हमको side effect होगा. But actually that's not the case. In oncology, the best form of clinical treatment is in a clinical trial. But this is something that the patients do not understand. They have myths, they have superstition. So that is something which is a problem. So I think these are all the challenges. And there are challenges which do extend even to the surgical and the radiation oncology colleagues as well. As Dr. Mathur highlighted, the number of radiation machines are very, very less. And there is a long waiting list for patients. So there is definitely an attrition from the radiation point of view as well. And there are long surgery dates, even at Tata Memorial or any other tertiary cancer care institute, because at private, the cost is very high for these surgical oncologists. So there are a number of challenges, both from medical, surgical, and the radiation oncology point of view.
Okay. Thank you, Dr. Shah. That was a sort of a really real perspective from your side.
Thank you.
I think, I have sort of attended a lot of support groups, including the ones at Tata. And in terms of advocacy, there too, I find the real scarcity of advocates who have been survivors, who have gone through that journey themselves.
Sure.
Not enough people are coming out. As you said, attrition rates, people don't come. मुझे बहुत side effects है, मैं नहीं आऊंगा. और that is when a person who has beaten cancer and come back to normal life comes in, because they're going to say that, yes, I have gone through it. You need to do this treatment and you can come out of it. That's where, even from a clinician's point of view, the advocacy role is so crucial. And I will come to Sangeeta ji thoda sa for the the caregiver's perspective,
Sangeeta ji,
challenges ke bare mein.
I'm sorry, I'm interrupting. Actually, Dr.
Sorry.
Swasti Charan has to leave. He's
Okay.
waiting for the inaugural talk that because of his meeting.
Okay.
So
Okay.
maybe we can quickly
Yeah.
take the question from Jose, and then we invite.
Yes, sure. I was coming to Mr. Jose. You're the founder of Arogya Finance, of course. If you could tell us, how effective is microfinancing in cancer treatment today, and what gaps do you see that exist in this model? Do you see this as a sustainable revenue model, and would policy level interventions help increase access to treatment? Those are my specific questions.
Yeah, thank you. Microfinance and especially medical loans can be a very effective tool for financing cancer care. As somebody already pointed out, the healthcare insurance penetration is so low. On an average, it's about 60%, and on cancer, it is specifically mentioned as 70%. So what do such patients do? A medical loan can provide quick and sizable financial support. And that can be used to cover expensive, time-sensitive treatments like immunotherapy, chemo, surgery, radiation therapy, hospitalization, any of those. So the advantage of or the way the medical loan fraternity is putting it out there is that it provides immediate access to funds. The loans can also be sizable, relatively. It can reach, a wider reach can be provided, long tenors can be provided, okay? And it can also supplement insurance. So for all these reasons, the medical loans can be very effective. Now, the gaps, of course, in this are that, many of the loans that are available carry high interest rates, especially if they're coming from NBFCs as compared to banks. Okay, accessibility is a problem. It's not available to everyone because it has to go through credit, screening, etc. And many of the loans that are available are insufficient for the needs that the patient has. Then even if you get a loan, now how do I have, as doctor pointed out, the average per capita income in India is so low that how do even I get a loan, how do I repay that? Okay, so all these are challenges, no doubt about those. Now, I can tell a little bit about what Arogya does here. Arogya Finance does here is we are very aggressive in providing medical loans for critical care. Yeah. Many financial institutions find lending for critical care challenging because we don't know what will happen to the patient, what will be the outcome of the therapy, and things like that. And then they don't get the courage to go out and lend money. At Arogya, we do not bother too much about any of those. Those are matters between the doctor and the patient, and they will deal with it the best way they can. We have no expertise there in any case. So our expertise is in providing finance to a large segment of the population, and we try to do that as best as we can. We can, so we have today the ability to, auto approve a loan by the system in less than 5 minutes. So, and with just a PAN card and Aadhaar card copy, an application can be completed in 3 to 5 minutes time, and the loan can be auto approved. No intervention required. Okay. And that gives the confidence to the patient and the families that, yes, I can go out and get treatment now. Okay. So that's what we are focusing on. Now, another thing that we do is we provide a socio-economic evaluation of an offering to many pharmaceutical companies. As you know, there are so many innovative therapies out there, but they are all very expensive. Most people in India cannot afford it. So now how do you reach this treatment to the patients? So what we do is in collaboration with a few pharmaceutical companies, what we do is we do a socio-economic evaluation, again system-driven. It gets completed in a matter of minutes. And then if they get qualified, these expensive treatments then become available for, say, 1/3 of the price. Okay, so 2/3 is absorbed by the pharma company, and the patient pays only 1/3 of the price, and that also in interest-free installments. So where is 100% an expensive 20-30 lakh therapy versus 8 to 10 lakhs, and that too paid over 12 months on interest-free installments. So that's what we try and do. We also create that we have another model where we similarly do socio-economic evaluation and then offer discounts to patients that could vary from 5% to 70%, 70. Okay. So there are treatments that we have financed like that, where the treatment cost is, let's say, close to 3 lakh rupees. And then depending upon the patient's ability to pay, the price can come down to as much as 70,000-80,000 rupees instead of 3 lakh rupees. So these are the models that we have tried to use and out there, so that it becomes universally available. The expensive and very hopefully very effective therapies become then available to patients at very affordable prices and in installments which they can afford to pay. Another thing that we do is that most of our loans are interest-free. Okay. So interest is a major burden. As such, it is a huge burden. The treatment itself is a burden. Now interest becomes even bigger burden. So we work with pharmaceutical companies to ensure that the interest gets subsidized, and therefore the patient do not pay those interests. We also take care to ensure that the price is not jacked up to take care of it. Okay. So
sorry, I'm interrupting.
So a patient who pays upfront and a patient who pays over a period of time, interest free, also pays the same price. Okay, that
All
we
right.
ensure.
Thank you so much.
Yeah.
Yeah. Thank you so much, Mr. Peter. That was really, really useful and hopeful. And I thank all the panelists for joining here today to talk about advocacy. There are lots of insights we can move forward from. Over to you, Vivek ji. Thank you so much.
Thank you so much, Sanjukta ji, for the well moderated. I know that this timeline is not sufficient to talk this kind of serious topics, but it's just like kind of a brainstorm, initial brainstorm, and we'll
Yes,
continue.
yes. The idea
Going
is to
forward.
take it forward.
Yes,
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 yes.
yes. Now,
Thank you.
may we request Dr. L. Swasti Charan, who is the additional DDG at non-communicable disease at Ministry of Health. Sir, बहुत बहुत स्वागत है आपका, and we would like to listen to you on the conclave.
Thank you, Vivek, and it's really wonderful that we are having a conclave today, and I could listen to the previous panel discussion, which was discussing on various areas of cancer care, which is as complex as the disease itself, and it is really heartening to see that many people are dwelling in that area. So congratulations to the organizers on this World Cancer Day that we are having such a discussion. Since morning we have been running from one event to another on World Cancer Day, and we have been speaking on various areas. In the morning, DGHS sir and myself, we were in an event where we are where we have a center in Lady Harding Medical College for the oral potential malignant disorders. These are lesions inside the oral cavity, inside the mouth, which is before cancer. If you are able to screen and catch that person when he is having OPMD, then the disease outcome is much better than when it is frank oral cancer. So that kind of activity is happening all across the country. In between, we had another webinar from our DGHS, our weekly fortnightly webinar, and today's theme was based on cancer. So we have been talking about cancer all day long, and I really wish that we continue to do that throughout the year, because at days even only one day we are aware that cancer is important and the risk factors are very important, and forget the rest of the year. It is not going to help us in any way. In India, to give you a burden, we have got a lot of studies coming in from various corners, and then we have the National Cancer Registry Program of the country telling us that about 4.6 lakh new cases are there, and out of which 8 lakh of them die in this country from various cancers of the body. And these cancers are, India is such a diverse country, and the diversity is also even exhibited in the type of cancers that we have in the country. So that the population base and the hospital base cancer registry points us to various different cancers across the country. And when we look at this data, why it is happening, then we link ourselves to many of the possible causes. Many of them are known causes like tobacco, alcohol, physical inactivity, etc. And it is reflected in the type of cancer that we have. So we need to work in a very holistic approach and a people-centric approach kind of thing. Every one of us should know that it is not the government alone or the society alone that to take care of our health, but it is first and foremost, it is the human being himself, is the person himself, that he should take health in his own hands first. So the people-centric approach, recognizing its person's health, is very important when he is healthy as well as when he is jeopardized with any disease, particularly cancer. And then and throughout the day, coincidentally, I was also trying to juggle some of the patients for treatment, in Tata Memorial Hospital, another in our IRCH in AIMS, and then we have to call so many people to get the kind of attention being given to some of the patients who has approached us. That kind of personalized care in an institute like AIMS and Tata Memorial is so difficult for some of us whom we can at least talk to somebody in AIM, then you can imagine the plight of the common citizens that we have in this country. That's why we need to increase the healthcare facilities that we have in this country, so that there is equity in terms of cancer care. But friends, let me tell you that even though we may try to provide some of the best cancer therapies, life is never the same when we have cancer. So it is always best to prevent them when you can prevent them by proper health promotion, and also by primary and secondary prevention. Government has taken a lot of initiatives under the national program for the NCDs. We have 718 NCD clinics, 372 daycare centers for chemotherapy, and we all know that we are engaging the entire machinery for population-based screening for common NCDs, including 3 common cancers: oral, breast, and cervical. And the screening statistics tells me that we have screened about 26 crore of individuals for oral cancer, 14 crore for breast cancer, and 9 crore for cervical cancer. So the hunt kind of thing goes on, but this is not enough unless the health-seeking behavior of that individual is woken up, and then he himself tries to take care of this. And for those patients who are diagnosed with cancer, apart from the Institute of National Importance, AIMS and PGI and JIPMER and Sanjay Gandhi PGI and many of these institutes, we also have 22 new AIMS and 75 upgraded government medical colleges providing cancer care. Under the program, we also have approved 19 what is known as state cancer institutes and 20 tertiary cancer care centers. So we are now trying to increase more of the daycare centers, provide linkages with the 3CCCs and the State Cancer Institute and any institute providing healthcare. The task is enormous. It is not possible to do alone from the ministry. We also have the PMJ packages. We are also making discounted cancer drugs being available for affordability through the Amrit pharmacies. We have got the Rashtriya Aroga Nidhi. There are several schemes there, but I must say that many of these are also common waterhole for many cancers and many NCDs. That's why we need to do these activities as a whole of government approach, and we need to take whoever is working in this area along with us. So today's team, United by Unique, is very, very important. And what we look forward to organizations like you or most of you who have joined here is you have to tell us your story. We are program people. We do learn. We do many programs during the day. We know how to run programs, but every program specialists, every program experts will have to tell us that where are those priority areas, which area we need to go, so that we have the best output. Resources will always be limited, but we should be able to use the right right use of that limited resources so that we have got optimum or maximum results. So with that, I want to thank each one of you for inviting me here, and I wish happy deliberations further on again. And at the end of the conclave, I think the organizers could give us a report so that we can have a look into it and then try to see where we can fit in from the government side. With this, thank you once again.
Thank you so much, sir. Again, it's we are very honored to have you today, and listening to people like you saying that you are ready to support and you are inviting the ideas and you are willing to kind of handhold or guide us. It is really heartwarming, and thank you so much, sir, with the bottom of our hearts. And surely I'll stay in touch with you. And the report that you mentioned, we do make the report every year, and this year report as well. I'll try and personally come and meet you and submit it. Thank you so much, sir. Now, may I request Dr. Shruti Kate to introduce herself first and then her panel, and we take the session ahead.
Yes, thank you, Mr. Vivek, and thank you. Good evening, everyone. I'm a medical oncologist. I'm practicing in Cancer Centers of America in Nashik. I'm a Tata Memorial Hospital alumnus, and I'm feeling extremely privileged to be given this chance of moderating this important session with some very renowned panelists. Let me welcome Mr. Murthy from MENCAM, Dr. Vandana Dhamankar from ICS, Dr. Geeta, breast surgeon from Delhi, and Dr. Sudha Chandrasekhar, who's a former director of NHA. I hope all the panelists are there. So the topic that we will be discussing is aligning the resources, joining the forces, and making cancer identifiable early and tackling timely. So over the last decade, I have personally seen a lot of increase in the number of cancer patients, number of people living with cancer. So as of we have more number of new cases, and also we have more number of people living with cancer in terms of improvement in the treatment that is available to them. So the incidence as well as the prevalence is rising. But at the same time, maybe I'm biased, but most of us will agree that we do have more number of patients who are diagnosed in an advanced or metastatic stage. So I am a medical oncologist, so I see more of the metastatic patients than the surgeons, but we will discuss with all our panelists and take this forward. So let me start with Dr. Geeta. She's a renowned surgeon from Delhi, ma'am. So as a surgeon, like I said, I'm biased, I'm a medical oncologist. What would you say? What is the distribution of patients that you see in your clinic? Early stage versus advanced stages, both locally advanced as well as metastatic. So for example, if we take in women, if we take breast cancer, and for men, if we take lung cancer, if you could just highlight it for us.
You asked me because I deal exclusively with breast and I work in a corporate setup. So here you would see that 60% of our patients are stage 1, stage 2. Not many stage 1s, but mostly stage 2s. And about 30-40% would be locally advanced and metastatic. But if you put the country into context, I would think that it reverses the other way, and about 60% of cancers would still be locally advanced and metastatic, and early stage would be 30%, which is what we have to change. And I think this meeting brings into sharp focus the fact that we are still struggling with these bits. We keep talking about prevention, but in the same breath, we should be talking early detection also, because the awareness, we all of us in our own capacities do a lot of awareness work. But, when we see another educated woman walking in with a locally advanced breast cancer, and you think, what have you done? Meaning, where have you reached? So I think, there is still a lack of awareness. And even if there is awareness, there is a strong sense of denial that it couldn't be happening to me. And I think, we have to fight on all these fronts to ensure that patients walk into your clinic earlier than later. And, it is all, it relates to economics, it relates to logistics, it relates to everything. The earlier you picked up, the chances that you would be cured with lesser treatment and get great outcomes is very, very high. And the reverse is true when you have a locally advanced or a metastatic situation. Although even for men, whether it is lung cancer, unfortunately, lung cancer, the operable cases are so few. Even today, I think that percentage hasn't changed when you can see about 10 to 15% of patients who would be operable upfront. The others would be, either locally advanced or metastatic. But fortunately, a lot of things have changed in the medical oncology front as far as lung cancer is concerned. And you see good survivals even in stage 4. But having said that, we still want to catch them early. And it is a hugely preventable disease. So I keep thinking, that is where advocates and advocates can play a big role in ensuring people get rid of bad habits like tobacco use.
Yeah, I totally agree, ma'am. You being in a corporate setup, I mean, the percentages may be different, but the overall picture is, largely the same if you talk about the entire country. But it's a very, very important and a valid point that in India, it's a country of disparity. I mean, there's a lot of cancer disparity as well, and that is something we cannot fight on our own, and that's where the stand of the advocates and wonderful people here in the panel, not just this panel discussion but others as well, can help, because unfortunately that bridging the disparity and ensuring all the patients get treated, even even I am in a corporate setup in Nashik, but even after diagnosis to the start of treatment, there's a hindrance. So we keep on focusing on early diagnosis, but I feel that majority of the patients, they have a file full of investigations, but the gap between each investigation is almost a month. There are many patients like that, maybe not all, but that is also, and there are many factors. Economics is one, but lot of issues from the community aspect of it. So I mean, at the individual, I mean, for an individual, I mean, it is different for each individual, but we should be focusing more at the community level than at a larger level. That has made a lot of difference in the early diagnosis and early treatment part of it. And many of the people working in these fields would agree with that. I'll take the next question with Dr. Sudha. Ma'am, both government as well as private insurance often falls short for treatment of coverage of the entire cancer care treatment. So how do you see the collaboration between the two, and what is your middle way, or how we can ensure that we cover the entire population and reduce the disparity as far as possible?
Thank you. And I would be speaking as part of my work, both in multiple governments in Karnataka and also as Executive Director NHA, implementing the PMJAY. I've been hearing a lot for past 1 hour that there are many things that's not covered under PMJY, and that's one grouse from all the clinicians. But if you look at where we started, let us say 2018 when PMJY was launched, it was only 56 treatment packages that were there. And currently we have 193 packages across medical, surgical, and radiation oncology. So there has been a lot of change that has come in. And also these treatments have become very site-specific, and most of the cost-effective treatments as per the National Cancer Grid guidelines have been incorporated. Yes, I understand the targeted therapies or the most innovative therapies are not yet there, but it will take some time, because when we are using public funds to treat, a vast number of patients, we need to be careful on where we put the money. So it has to be cost effective, it has to be prioritized. And for that, the health technology assessment forms a very critical part. So DHR, the Department of Health Research, which has the health technology board, and all the requests that we get from the clinicians, as and when we were there, we had routed it through a HEFTA portal in the NHA, wherein you can put in those treatment with the evidence, saying that these are because we, being in the policymaker as administrators, we are not up to date in terms of what are all the newer therapies that are coming in. But both the pharma sector and the clinicians are open to put their requirements into the HEFTA portal, so that is reviewed, and if it needs a health technology assessment, then we move it with the DHR and get it done and take a call whether it is in or out into the health benefit packages, because there needs to be a process. And the second thing I would like to say is also on the diagnostic side, because when we were reviewing the claims data, across the country, the pan-India data, nearly 30% of the claims were for palliative care. So we are hitting the patients, we are connecting with the patients when almost 30% have reached the terminal stages and nothing much can do. Whether you do 5 lakh coverage or 10 lakh coverage, there's not much that can be done. So early diagnostics is very important, and diagnostics per se are also part of the packages. If you look at biopsies, PET scans, CT scans, whatever the mandatory requirements for, maybe the, and also advanced diagnostics wherein you can have some immunomarkers. There are packages available. It's also the lack of awareness among the hospitals and the treating physicians that these packages are not there, because they want to just do it as part of the OPD services. And we do agree that, PMJY is for inpatient care. So most of these cases, when you need to have a full workup and when you're suspecting, they can get these tests done. And these are mandatory tests which are needed to access the treatment. So diagnostics are a part, but how do you unbundle it is a issue which many states are also looking at. And, we need to work up a little bit more on it, because that needs to be, so that unwanted, diagnostics are not done. So I just want to check out, do I need to answer the second part of the question here again in terms of the innovative models, or will you be coming back to it? Because especially in terms of drugs, some of the innovative ways that we are looking at to make it easily accessible to the patients is also promoting the strategic purchasing and collective bargaining. These are well-established models, and Tata Memorial Hospital is one of quite done a lot in that in terms of procuring drugs at the lowest cost. Nearly 80% less than what the market prices are for most of the drugs. So yes, there are ways to get the common drugs, but yes, the high-end therapies are again an issue. So we need to work with the industry for that. Look at patient assistance programs, look at ways in ensuring a little bit of confidential pricing with the government, because when we do the pooled purchasing at the government level, we can buy large volumes and bring the cost down, and assured payment, assured volumes to the pharma sector also, and then they are willing to reduce the prices. So that is one way of looking at how do we collaborate not only with the insurance providers, but also with the pharma industry. And one key thing I want to put it out before I close, I know it's time is minimal, is that not all hospitals who can provide cancer care are currently empaneled with the PMJY scheme. I think that is something which mandatorily, as a part of social responsibility, if we can get a wider number of hospitals, because otherwise the minimum hospitals are not able to take the load. The most of the public RRMCs, the regional cancer centers, are the ones who are actually providing free care, but whereas the high-end private hospitals are also not part of the system in many states. So that is a very key thing. Cancer being such a limited supply of physicians and the required infrastructure needed to deliver care, I think as a part of this, my call and my request to everyone here listening is, if your hospital is not empaneled with PMJY, please do so that we can provide access to patients who have the coverage. Up to 5 lakh they have. In some states, Rajasthan has 25 lakh, Odisha has 10 lakh coverages. They can have a broader additions of packages which can include the higher end therapies also. But please do be a part of the system. Thank you.
But what happens, ma'am, is that, like you said, Tata Hospital is in a position to negotiate with the companies. But when it comes to individual hospitals, especially the private hospitals, the packages are such that, service is almost free. So though service comes with a charge, the drugs, the cost of the drugs, it is at the mercy of the pharma companies.
That is why I said government should take the lead to think on behalf of private sector also.
Exactly.
How do we bring public and private together? Because the government has a role not only to provide through its public sector hospitals, but also on behalf of the private hospitals, they can take the responsibility and procure the drug and ensure that they are given free to the patients of PMJY or any other schemes that can be done. So that is something we have been working with some of the states who are willing to, and UP, nearly 17 hospitals have come up, private hospitals have come up and joined forces with Tata Memorial Hospital to do the collective bargaining. So it is not impossible, but it is just the willingness of the private sector. And also, maybe if it's not one government or state government, TMC, Tata Memorial Hospital, can take the responsibility, and they're willing to do so as part of the National Cancer Grid. And they can procure it for pan India. That's not a problem at all, because there are well-oiled systems in that pooled purchasing.
I guess that will be excellent, ma'am, because private, public, and trust me, many patients would not want to go to private government setup. So they want treatment in a private setup, but they are economically challenged. And we also know that we should be able to provide treatment, and the most essential treatment, especially when it comes to breast cancer and those who are non-metastatic. So thank you, ma'am. Your insights were very helpful. Coming to Mr. Murthy, sir, I just was going through the excellent work that you're doing, and especially working with the high volume center, sir. How do you feel coming back to early detection? How do you see your special in the patients that you are working with, early detections, and your experience in that regard, especially because you're working with men? Do you see the situation a little different, or is it the same?
Hi, first of all, good afternoon, and thanks Vivek ji for this opportunity. And let me just tell you that I myself is a cancer survivor, so I can talk, on both the sides. And right now, I am with Tata Memorial Center, heading an initiative called Men Can. So this is Men's Cancer Initiative. So my focused areas are basically the men's cancers. So one of the, we are all talking about early detection. So I think we talk a lot about early detection, but I would say early detection is the most critical part in any cancer care, that everybody would agree. But I feel the infrastructure at the primary center level should really increase and identify the cancers at the early stage. That is where in one of the area which we are working. And in our as you all know that TMC and Actrec, I am based out of Actrec, but of course I shuttle between Parel and Actrec. Yes, we see more than 60% of the cases which are at an advanced stage, at stage 3 or stage 4, as Dr. Geeta mentioned in when she was talking about. And the large proportion of the cases, because of this, at a later stages, so which will become difficult at on the both the ends, at the at the hospital level and also at the patient level, in terms of impact the significant treatment outcomes. So especially, see, I am dealing with men's cancer, so my focused areas are like prostate, testicular, and cancer. So these cancers, early detection can dramatically reduce the morbidity, improve survival rates, and the lower treatment costs. So this is where is one of the major focus area which we are working on through many awareness programs at offline and online both, and also in collaborating with certain of the NGOs which are associated with us, like We Care, Gunwati Kapoor Foundation. As you know, many of these organizations are associated with us internally, so it is easy for us to in fact work with them. But I would definitely say the outside of the TMC, it is, I think, bit difficult for people to get into these programs and identify these cases at the early stage.
So is your organization also contributing to screening of prostate cancer? Like, have you done any projects in that line?
Yeah, we are primarily working at the, one of the major area which we wanted to work. In fact, we have not started any particular activity on that, but we started our awareness programs as such through digitally and physically. But our next step is to work with the primary, healthcare centers to identify these cases, because as I said, in prostate, penile, and testicular, we can have more than 90% curative cases if we can catch them at stage 1 or stage 2 before it becomes metastatic. So that is where is our next focused area, to work with the primary care healthcare centers to identify and do camps, and make sure, try and see that if we can catch them at an early stage, and of course then bring them to Tata and treat them.
Yeah. So, Dr. Vandana, how do you see a collaboration of resources as well as stakeholders when it comes to early detection, especially with your institution doing a wonderful work in this field?
Thank you, Dr. Kate. On behalf of Dr. Vandana Dhamankar, myself Shravani Koyande, representing the Indian Cancer Society. First of all, thank you very much for giving this opportunity, Dr. Vivek. Being in Indian Cancer Society, we focus on majorly on the 3 arms, that is awareness, screening, and training. And we believe that the partnership is the most important work for doing this great work. And we are doing the partnership with the hospitals, NGOs, government programs, with the local health workers, and along with the CSR donors. Because with this only we can do the majorly screening services closer to the people, especially in the remote areas where general help is not available and where the need of the assessment is high. So recently, I can give you one example. IST has joined the hands with the Wokards Foundation and Piramal Swasthava, wherein we have built in their capacities of their teams for the undertaking the screens and of the oral screening for the oral cancer in the mobile by using their mobile detection units. And I'm happy to say that we have done almost 3,000 screening camps with both the foundations, and we have screened more than 74,000 people, and we have trained their 42 nurses and 183 doctors. So this is the strength of the partnership with the partnership with the hospitals and NGOs, and I must say that we should go ahead with most of the hospitals and NGOs to train the people. And regarding the awareness, I will say that in awareness also we have our cancer awareness campaign where we do the we have launched the Satark program where we do the raising the awareness for the oral and cervical cancer among the frontline health workers. And one more thing I would like to point out that Dr. Mathur said in earlier his presentation that we should do the training of the trainers. So I'm happy to say that we also have the medical empowerment program for the general practitioners, where we give the training to the doctors for the to understand the early signs of the cancer and motivate the people to get screened. And our most important launch of the ICS is a Raho Cancer Do Kadam Aage. That is also to spread the awareness about the cancer in the masses. So these are the activities we do as an Indian Cancer Society.
Ma'am, what are your, if we can take it as a last question, Mr. Vivek, what are your limitations or what are the problems that you're currently tackling? I mean,
there are certainly there are huge challenges. We are doing a cancer screening. We are getting screened the people, but we are lacking behind the navigating. Navigation is the most important part which plays role over there, because we identify the person, there are certain problems, but we don't know how it has happened, what has happened with them after we have asked them to go to the doctors or go to the clinics, go to the hospitals. So strengthening the linkage between the screening center and the tertiary hospital is the most important thing we should do. And we want to leverage the technologies for this. We want AI-driven diagnosis, then mobile apps for the self-assessment also there. And with most important thing that we are looking for the sustainable funding models for the CSR support and the crowdfunding, because nowadays funding is the most important challenge for us as an NGO to work for do the screening of the masses. So we are looking forward for the most CSR support from the majorly CSR companies.
I agree, ma'am. And as in how more and more public as well as private hospitals or service providers will come in contact with you, with the wonderful work that you're doing, I guess patients will have more options and they will not get crowded in one place and get lost. So yes, maybe they have to be attended to at the highest priority, especially those who have been diagnosed with such great efforts.
Yeah.
So thank you so much, ma'am.
Thank you,
Dr.
ma'am.
Dr. Sudha, Murthy sir, Vandana ma'am, thank you. I'm so sorry, I forgot your name, ma'am.
It's Shravani, it's okay. No.
Shavni. Thank you, ma'am, so much for your contribution. And there were certain very essential points that we have taken, and hoping to bring a change in the patients living with cancer. Thank you.
Thank you so much, Dr. Shruti, for managing such a crucial conversation within the time limits. And meanwhile, I have an announcement to make. Anybody who's joining us online, and they can download a certificate. There's an option of downloading a certificate for the participation. And with this, may I request Dr. Vijay Patil to come on the center stage and introduce his panelist and run the panel discussion.
Okay. Thank you, Vivek. And let me introduce my panelists, Dr. Amit Joshi, sir, Dr. Vanindra Narona, madam, Dr. Siddharth Laskar, sir, Dr. Sudarshan Vyas, Dr. Indira Behra, Dr. Hardik, and Dr. Ashwin. Vivek, all of them are there?
सिर्फ लश्कर सर नहीं है, बाकी मेरे ख्याल से सारे लोग हैं.
Okay. So let me, without wasting time, let me start with the discussions. Ashwin, the first question is for you.
Yeah.
What is your take on access to the latest surgical interventions for cancer patients?
Yeah.
What is your take on access to the latest?
Yeah. So basically, currently the overall, as in, of course, the place where I belong to is more into urologic and cancer and a bit of robotic surgery. So I'll take 1 minute to quickly utilize that particular thing for discussion about this, that every cancer is a personalized treatment now. So gone are the days of open surgeries where you need to have a lot of recovery time, a lot of recovery related alterations. So with the cutting edge technologies or the robotic platforms, the overall recovery has become very, very smooth. The discharge process is quite earlier. The overall precision surgeries have given us an advancement in terms of minimization of the blood loss, the painless recovery which happens essentially, and ultimately the amalgamation between the functional outcomes and the cancer cutting-edge technological advanced surgeries. That's a precise answer to this.
Ashwin, do you feel that in low and middle income groups or patients of government schemes, you can offer them minimal access surgery?
Generally, yes, sir. Because if you ask me, a majority insurance will cover, and a standard middle class individual will definitely be in a position to be affording this kind of treatment. So let's not put the figures here for a perspective. It's an academic event, but I don't think that there is a lot of challenge because the advantages which we get out of the overall procedures is phenomenal. For example, in my field, urological cancer surgeries, the partial nephrectomies or bladder removals or even prostate surgeries, almost like I said, gone are the days of open surgery predominantly. Of course, there is a role of open surgeries in certain domains, but predominantly it is the high-end advanced surgeries which will give us functional, quick recovery, quicker convalescence. All these things will count. So we call it upstream and downstream cost. It's not just the cost of the procedure, but the upstream and downstream cost, which is very essential to take into algorithm for discussions. So in today's era where you have a basic insurance of certain limit, generally that concern is not a problem. So it's not going to be a challenge for an accessibility or a financial affordability is not a major concern on majority of the grounds.
Do you see any challenges for which you think advocacy for minimal access surgery would enable certain barriers from the government side or from patient side to overcome so that this access is improved?
Yeah. So yeah, sir. So essentially, of course, until now, the government policies are not in sync with adaptation of minimal invasive strategies. Slowly, there is a movement. For example, Sassoon Hospital in Pune, or for that matter, AIMS or PGI or HDPGI, definitely have these robotic surgeries in their domain. So certain Apex Institute where funding is not a concern, where the care is even affordable to the patients, even in a lower middle class category as well. So what I mean is, governance is putting definitely a good amount of efforts for getting that particular domain accessible to the patients. Mumbai, unfortunately, we are slightly lagging, but I think we will catch up soon at that particular time. But majority apex institutes in India, as government policies or government ministers, will have high-end technologies, especially the robotic surgeries. Yes.
Thank you, Ashwin. Dr. Indira, the next question is for you. From a public health perspective, what are the key policies you think are needed for you to access cutting-edge cancer therapies, especially for marginalized communities?
Thank you, Dr. Patil, and thank you, Vivek, and to your team and all the other panelists for actually having me here. That's I think that's a lot to unpack in a short amount of time. So I may not be able to cover everything, but and I'm sure a lot of us sitting here know some of this and have thought through some of this. But essentially, I think as has been coming out, there are while we have made progress, I do recognize with the introduction of PMJ funding and public health insurance coverage for cancer care, there is a long way that we still need to go, and there are of course demand side challenges that need to be addressed, from awareness to lack of access to infrastructure and facilities, to many other issues, including the feeling sometimes that I believe patients do get, that when they are diagnosed, if they get to that point also, and when they get to that point, that they find that it's going to be too expensive, or they think it's going to be too expensive to actually undertake treatment, and so decide to forego it altogether. We know that there are, due to many other systemic challenges, that diagnostics, as many of the oncologists and surgeons, surgical oncologists that have come up here have said, that there is, things are diagnosed pretty late. People are coming in the later stages, and it makes it, studies also say, and we know that it makes it harder to treat this and therefore more expensive. So I think if I were to summarize all of this, well, of course, we need to, before I get into investments and how, we need to mobilize some of those funds, I think it is important for the country to really, looking at our rising numbers and the kind of incidence and prevalence we're going to be seeing over the next few years, we need to be a little more aggressive in how we tackle funding for various aspects of our cancer care program. And it needs to focus on, of course, facing some of these and solving some of these demand side challenges, including awareness. But I think we do need to focus on prevention, that is screening. And I know we've been talking, for example, in cervical cancer about the vaccine, but I think beyond just, the oral and breast cancers, we need to be, and cervical cancer, we need to be looking at screening for larger populations. This is obviously going to help us catch changes earlier on. Invest in awareness programs, of course. We also do need to start looking at the supply side. What is our insurance actually covering, right? Because there is, while I admit it has increased, there is still, I think there needs to be a larger or a higher ceiling on the kind of coverage that we have at this point in time through public health insurance for cancer treatment. There needs to be more that is covered in terms of pre-treatment, post-treatment, and even corollary expenses. Simple things like logistics, for example, can be quite complicated. And I understand that, the government can't take all of this on its own. And I'm cognizant of that, which is why it can't only be, it has to be spearheaded by the government. But of course, you need contributions from the private sector. And there are many examples around the world that we can look to see how we do this, and I'll get to that in one point. I do think that, of course, we also need to keep pace with the kind of changes and innovation that are coming about. I understand that we have to look at things and make sure that they are cost effective, but we're also talking about human lives. First of all, the fact is that we don't really know, given the size of our country and our access to data, I don't know whether we have, and looking at other programs, public health programs, I'm not sure that we have the kind of that much clarity as we should perhaps on the numbers. We have projections, but I'm sure that we are missing the magnitude of the problem, especially when it comes to the less diagnosed or the rarer kinds of cancers, or if you're looking at hard to reach places. So we're going to have to get a better handle of the numbers if we want to start talking about cost effectiveness. I think that, when it comes to looking at targeted treatments or targeted therapies and, other anti-neoplastic agents, we have to move beyond chemotherapy and, keep with the times. And we have to therefore make our processes a little more efficient and well-funded. You can look to, for example, the Cancer Drug Fund in the UK and see how that even before there are certain innovative therapies that are proven to be safe and somewhat effective that get funding and, get funded even before they have completed their HTA requirements. If you want to talk about mobilizing funds for some of these programs, it's worth looking at Taiwan, for example, and their tobacco tax funded program, or the UAE and, the kind of, contributions that they are looking for, small contributions that they are looking for, and perhaps having people pay into, a specific cancer care or, a cancer focused coverage system within their public health insurance. But essentially what our solution has to be focused on as a country, like I said, it cannot be only done alone by the government. And I think, there is a way to mobilize funds from, we have the CSR Act. We've got examples from the Indian Cancer Society where they've worked with HDFC to actually mobilize funds from the capital markets. They have a mutual fund system where people can actually donate their funds. One of your other guests later on, Arogya Finance, we did a paper where, we covered some of these, and they have come up with some very interesting models on how to, leverage funds and be able to give people soft loans, for example. So I think there's a lot that can be done that can help with accessibility, affordability, and sustainability. But that will require everybody to actually come together and acknowledge the size of the problem, acknowledge that, we can do better. We've done well, but we can do a lot better. Given how, we've got how much our clinicians are doing, how much is going into research, although we can spend more there as well. There is a long way for us to go, and I'm sure that we can do it.
Thank you, Indira ji, to actually took care of the next few questions which I was going to ask. Thank you. Just one last question for you. How do you think drug pricing, which is an issue in cancer domain, can be controlled?
Yeah, I think that in itself probably requires a day-long discussion. I'll be very, honest. I'm not the absolute expert in pricing, and pricing itself, there is of course the pricing, drug pricing or therapy pricing, and then there is the actual cost of treatment, and these are two different things. So it's going to be complicated, and it's going to need a lot of dialogue between, the manufacturers that are, coming up with newer products, and of course the government, so that you're not, while, there isn't price gouging, you're also not making it unattractive for them to enter the markets. I'm happy to see some of the things that have been talked about in the budget of, slashing customs duty and helping with patient support or patient access programs, assistance programs. But that will get you just so far. If you look at the kind of savings that you get with the customs cuts, I think with the duty cuts, that is a small proportion. Sometimes it depends on the drug, of course, but it might not be as big. It might not have as much of an impact as perhaps you want it to. So maybe. We can look at this as I'd love to have this as another conversation. I'd love to have people come in and talk about this, but perhaps, you should also be looking at incentivizing and encouraging Indian manufacturers to see how they can actually get into this and cut costs, and, where you can cut costs in diagnostics and so on. But I'll stop there. I know we're running out of time.
Yeah, fantastic answers, Indiraji. Let me move to Mr. Sudarshan. Sudarshan, as a caregiver, how have you seen the cancer treatment evolving over the years, particularly with respect to the neotherapies, and any challenges you see implementing these neotherapies?
Well, first of all, thank you, Vivek and the team, to offer me the stage to speak about cancer and as a caregiver. So I would be exclusively talking about the brain cancer, because that is what or rather I would say my brother, I was doing a caregiving job there and I experienced. And although I know that there has been quite a lot of modernization which has happened within the cancer treatment, for example, immunotherapy, proton therapy, robotic surgery, and so on. But what I felt was brain cancer is somewhere the standard procedures are still being followed. I mean, it's exactly the same what it was 10 years ago. You still follow the same surgical procedure, then followed by temozolomide, and then accompanied by a radiotherapy. And that has been a standard treatment so far. The challenges which I feel is when I did certain research and I tried to figure out what could be the new treatment, or what could be how I can support my brother there. So what I felt was whatever kind of clinical trials or gene therapy or immunotherapy were happening, everything was happening in US, and nothing could have been implemented here in India. Irrespective, I went to Tata, I went to AIMS, I went to many other big institutions. However, everywhere the answer remained the same, that we don't have such clinical trials. And basis that, I felt that, okay, if someone who cannot afford to go to US and get the modern medicines done to their family or to their relatives, they lack this opportunity. And brain cancer being one of the most aggressive cancer, with a life median of just about 11 months to 15 months, you are left with no option there, and just to kind of sacrifice and just to kind of agree with the situation that yes, this is how it will be. The second complication which I feel is about processing the information. By that I mean, yes, you do know that, okay, you have been, or maybe one of your family member has been diagnosed, or maybe it's a glioblastoma, whatever tumor it is. However, the processing of that information takes some time, and that is where I feel that if the management of the hospital, or maybe the hospitals or the institutions, could really support the family in absorbing that information slowly and gradually, so that the family can really kind of understand what they are going through and how the next set of actions would look like. So that is where I feel the second complication which I failed. And obviously, I mean, there is no set rule that, okay, you have to do certain things in a certain way. Every cancer is different, and every treatment is different. So I think there should be some customization offered around that. Most importantly, which I feel is about the financial burden which the individual goes through. I think people are not really aware. In fact, I myself was not aware that if I have to buy a temozolomide, which is a salt for a medicine which is very exclusively used for brain tumors, it is available at the cost of 90,000, and it is available at the cost of 9,000 both. So there are substitutes, or there are medicines which will cost you cheaper, and these are the informations you are not told upfront. All you are said is, okay, this is your chemo medicine, you have to buy it, and then you go to the medical shop, and then they kind of give you the most expensive ones. So there is a lack of literature available. One, I feel there is a lack of clinical trials which is available, I feel. And third is there is lack of alternatives which are kind of missing out here in the Indian system, which I felt. So that's my overall observation as a caregiver.
Thank you, Sudarshan, for that insight. Just to add to that, to overcome quite a few of this, what you told, not all, that alternative gene therapies, CAR-Ts, TCLs are not available in India. So me and my friends have started an advanced cancer therapy unit in India. And we are at present in solid tumor also have offering CAR-Ts and TCRs, which were till recently not available in India and which were restricted to US itself. But thank you for that insight, Sudarshan. So let me come to Vanita, ma'am. Ma'am, what are the... You have been actively involved in making guidelines. And do you think Indian cancer treatment guidelines suffices the inclusion of desired therapy, and how we can improve on Indian guidelines, ma'am?
Thank you, Vijay, and I think thank you, Vivek, for this invitation. So, Indian guidelines, there are many. Are they ideal? Definitely not. I think there are problems with our Indian guidelines on multiple levels. The first is that most of our Indian guidelines are static, so they are made and then they lie there. They are not updated on a regular basis. So the way that our that oncology medicine and oncology advances, research advances, there are newer therapies on a relatively frequent basis. And if that is not part of the guideline, if the guideline is going by something that was a standard of care maybe 2 years ago or even 1 year ago, then those guidelines are really of no value to patients for current day therapy. So that's the first issue, that they are not updated and they are not a living guideline, so which most of the global guidelines are. I think the second issue with our guidelines is that they are by and large cut paste of global guidelines, and there's a very obvious reason for that, because most of the research and most of the evidence that the guidelines are based on is not coming from India. They are not local studies. So having cut paste of global guidelines in our setup, including drugs that are not even available in India, that really doesn't serve the purpose that the guidelines were made for. So yes, the guidelines are there. They do help accessing drugs, accessing some of the testing. However, there is a lot that needs to be improved upon, and much that we can do to help our patients in terms of that. How do we improve that? We need a group of people who can come together, who are willing to put an effort into this. And all of this, unfortunately, is something that we all talk about. There isn't a lot of infrastructure and a lot of funding to do this, right? This is all something that people come together and say, we want to do this. But for that to be successful in the long run, this needs to be incentivized. There needs to be funding and there needs to be infrastructure in place to get that done.
Ma'am, one more question, and that maybe not be a part of this discussion, but I think it's important. Now, for having Indian cancer guidelines, we need research from India. And what do you think are policy barriers which prevent investigator-initiated trials to be done in India?
So there were a lot of barriers, maybe 5 to 7 years ago. Some of those barriers have been surpassed. So a lot of those barriers have improved. So things like having placebo, having not being able to having to fund the arm that is standard of care, that requires funding even though it is standard in the clinic. A lot of those policy has improved. However, there are many policies that can improve and lead to more uptake of research and get more data for our Indian patients. Because ultimately, when we are treating our patients in the clinic and we are treating it based on a study that was done in the US or that was done in Europe, which did not include a single Indian patient, are we really doing the right thing for our patients? Cancer, of course, behaves similarly, but we know that there are multiple things in terms of the drug. There are some drugs that are distributed, the pharmacokinetics, the pharmacodynamics, which are different based on different ethnic populations. Our Indians we have a different life expectancy. There are multiple, our diet is different, our microbiome is different. So there are multiple reasons why we need to have our own data. There's no question about that. So sorry, I think I lost the trail of the question. What was your question, Vijay?
The question was, ma'am, what policy changes would you like to see so that the investigator-initiated trials become more easy to do?
So they are relatively easy now, Vijay. I think so the policies have changed. I mean, I think that we know. Our Indian government is required. They are more pro studies. However, again, research is not incentivized. It's not made compulsory. So our academic centers as well as the private centers, if it is, if ICMR, if the government makes it compulsory, that our academic centers need to answer a few basic questions, right? I mean, this is not something that is very difficult to do. It's something that we need to have a policy in place to have basic training for research to be done, as well as a policy to say that there is some basic funding that needs to be allocated, some basic infrastructure that needs to be allocated for research. I think that will go a long way.
Okay, ma'am. Thank you, ma'am. Let me move on to Vivek. Laskar sir has joined.
No, he could not.
No. Okay, so let me move to Dr. Hardik. Dr. Hardik, as a part of pharmaceutical industry, and we have discussion about accessible and affordable therapies. So, can you just brief how pharma therapy, pharma MNCs basically are helping out the patients with PAP programs and empowering them, and how these things are decided and how these things are done?
Sure. Thank you, Dr. Vijay, for having me here, and thank you to my panelists as well. Hope the audio is clear. Sorry, I'm traveling, so I'm just checking it out. Can you hear me?
Yes, we can hear you. We can hear you.
Yeah, we can.
Perfect. No, so thank you for this question as well, and I'll talk about this in few aspects. So one is creating access for the medicines, which is our primary goal, which that bringing these medicines faster to Indian patients. So we did like 13 regulatory approvals in last 15 months, and currently 50 plus global clinical trials are also ongoing. So the first step towards making medicines accessible and affordable to our patient is to have the medicine as an option in our country. And we are really working towards this to make sure that every new medicine which we develop at a global stage comes to the Indian patients. The second aspect of access is, and my panelists like Dr. Indira and Dr. Vanita touched upon, is like having the right awareness, which means that these patients are getting detected earlier in their journey for the cancer. Because everyone knows that if the cancer is detected late, the prognosis is poor, the costs are higher. Versus if you are able to do something to make sure that the patients gets detected early, then there are better therapies available, better prognosis is there, and the cost is also getting reduced. One such initiative which we are very proud of is we have active MOU with 2 state governments in Goa and Karnataka, where we are working with our partner Cure AI to implement their digital solutions and make sure that the lung cancer patients gets detected early. We do not have the evidence, but let's assume currently the ratio is 20 to 80, which means that 20% gets detected early, 80% are late diagnosis. And our aim is to reverse this kind of ratio to make sure more early diagnoses are happening. And of course, this cannot be done alone. So we are working with external partners, with state governments and other stakeholders to make sure that this becomes a way of screening and picking up the cancer patients early enough. We are also working on raising the mass awareness, which again, one of the panelists raised validly, that if we are able to, and this World Cancer Day itself is an example of doing this, if you are able to raise the awareness and make sure that the patients are well informed, then that will also make sure that we move into the right direction as well. One last thing I want to touch upon is, I think Dr. Vanita, you touched upon the need for RWs, because we rely on global data, we rely on global guidelines, and then we rely on our judgment that these are the problems we need to solve. But unless we have our own data and local evidences available, we'll keep going in the direction, but we would not know what exactly are the pain points and where, if we put our efforts, will give us the maximum benefit and the impact as well. So at AstraZeneca, we are making sure that we are working with the investigators and the healthcare community to generate the evidence, which gives us a clearer picture. And then we identify, okay, there are 10 problems maybe, but these two, if we address, it will give us the maximum benefit as well. So I think that's something which we are also working towards. And I think everyone listened to the budget very attentively, and we are thankful to the government also for a progressive access strategy and some good announcements which were made specifically for the cancer patients, also making the policies favorable for bringing these medicines faster to the patients. So I think these are all things which AstraZeneca is doing to make sure that the medicines are accessible. But again, as I said, the first aim is to bring the medicine to the country. And then second is to work with stakeholders and make sure that how we can make it accessible and affordable to the patients.
Thank you, Hardik, for that. Vivek, Amit sir is there on the call?
Yes,
sir. Yeah.
Hi,
yes,
sir.
I am there.
Yeah. Sir, my question to you is, in this era of accessibility, how do you think metronomic chemotherapy or low-dose immunotherapy helps out our patients?
So I think Vijay, need of a alternative treatment to the standard, and fortunately we at Tata have done a randomized study in terms of the benefit of the low dose immunotherapy in head and neck cancer, and I think for our Indian patient that is the way to go ahead, to look for the alternative treatment options which our common patient can afford. And in this aspect, I think metronomic therapy has come in a big way, and we all know that with the benefit of the with the availability and with the huge and definitely it need to be proven in a randomized way. And fortunately, in a head and neck cancer, we can say that the metronomic works. And now, as you must be aware, like the in breast, now we have another randomized data of a metronomic capacitabine in a which we are advocating for many years. But definitely that needs to be conducted in a trial and proven that low dose chemotherapy works. And we are in our mind we are convinced that a low dose approach may be a way to go ahead, a metronomic way to get. But definitely we need more randomized and robust data like we did in head and neck cancer, and for other side we definitely need to. And in this context, the government and the other agencies, because these trials will not be funded by any pharma, the trial will be funded by the institution or by the government agency. So in this regard, we need a support from the government organization like DST, DBT for giving or ICMR for giving a generous grant to conduct these sort of trial. Because it's our problem, so the solution should be also from Indian context. And fortunately, we have taken some step, but definitely massive work needs to be done on this in other disease other than the head.
Sir, one more thing. Do you think we should have some urgent fund for patients like testicular cancers, in whom sometimes the treatment has to be started very urgently, and such provisions need to be made?
Yes, so from that aspect, because the process for getting any government help in process for getting a help from government for all these highly curable cancer takes the same way for other normal patient. So in this, the patient who are going to get benefit or technically getting cured get delayed. So there should be some sort of a special funding process for these urgently needed patients. Similarly, like in a metastatic context, we multiple times discuss the ALK positive lung cancer. Although it turns even in a metastatic condition, the ALK positive lung cancer patients are doing much better with the newer therapies compared to the many locally advanced disease. So there should be some sort of allocation of a fund where some ballpark figure of a 5-year survival more than 50%, whether it's a metastatic or non-metastatic, that has to be come into the picture, and some sort of a emergency funds like where there will be minimal paperwork and needed. From that concept, we needed some sort of a early emergency fund which can be disbursed without much paperwork and other hassles. So definitely it is needed, but unfortunately at this point of time, even if we apply for any grant from the government, it takes at least 3 to 4 weeks for whatever help the various organizations give us. But at higher authorities, if they consider some sort of a what we call as a seed money or a basic money, like a per statute, they grant that this money can be in any patient who has a 5-year cure rate more than 50%. This money can be released without much work at the helpful in the long run.
Thank you, sir. And I think that's all from our panel discussion. Thank you, Vivek, for this opportunity, and I thank all my panelists for their time and the healthy discussion we had. Thank you.
Thank you so much, Dr. Saab. Yeah, thank you so much, Dr. Saab, for again addressing that's your specialty, like addressing the crucial points in timely manner. Now we have Dr. KV Ganpati, another efficient man in palliative care. And Dr. Saab, I would request you to introduce your panelists and take the session forward. That is about improving not only life, but quality of life. Sir.
So should I start?
Please, sir.
Am I audible?
Loud and clear. Yeah.
Shamli and Dr. Jeremy and Sharda Madam. Am I audible?
Very much. Sir.
Okay, so I'd like to call this session not just as palliative care, but this is a session that when you medical oncologists and other radiation oncologists induce all kinds of trouble on our patients, who's looking after their pain, their other symptoms, their distress, everything. So we have some noble souls over here who are looking at the quality of life of these patients. So I'd like to call this session as quality of life of these patients. And we have got 4 esteemed people who are looking at 3 people who are especially focused on looking at the physical symptoms, bringing relief to them, bringing peace to the family members. There is also another person who looks at the non-physical psychosocial dimension of a human being and what it means to go through this treatment and how to help them accept this and go along is what Madam Sharda is going to talk about. Okay, so the first question that I have is for my friend Dr. Shamli. Shamli, you can unmute yourself.
Yes, sir.
Okay, so the before I start, as we know that in Tata, when we talk about palliative care, it's an umbrella term. We have early palliative care, right? And then we come to best supportive care, and then we come to the end of life. So right here, all the participants who are here should take a pledge not to equate palliative care with end of life. We are far away from end of life. We are looking at the quality right from day 1 when the diagnosis is confirmed. So Shamli is going to take you through how do you identify early palliative care needs of the patient, and subsequently you cross the entire disease trajectory until the patient reaches end of life. Over to you, Shamli.
Right. So we all know cancer is usually diagnosed when the patient starts having a lot of symptoms. Before that, they are taking some medicines from outside. They do their treatment on home, sometimes home remedies. So when they have a lot of symptoms, they come to the doctor, they get investigated, and they are diagnosed with cancer. So by definition, early palliative care should start as early as within 8 weeks of diagnosis of any advanced illness. That means any metastatic cancer within 8 weeks of diagnosis ideally should be referred to a palliative care team to assess not just their physical symptoms, but if they have any psychological distress, how are they coping with the diagnosis, how are they managing things financially, how are things at home, do they have a supportive family member, do they have a job that needs any help from us. So all that psychosocial assessment, physical assessment, spiritual assessment should be done right at the beginning so that the family and the patient has a rapport with the palliative care team right from the beginning, and we are not a new team that comes into action when the patient is very sick or in a terminal stage or actively dying. So that is the concept of early palliative care. And luckily, we are able to do that and provide that care to many of our patients in Tata, thanks to our very supportive medical radiation and surgical oncologist team. So that really helps us building the rapport with the family. We provide them support in our outpatient setting. We do home visits while they are on active chemotherapies. We see them in the emergency department. We see them in the ward. We admit them to the respite care center if they need intermittent respite from being at home. The family members need support. The patient needs antibiotics, wound management, and empowerment. So that is the places where we provide palliative care. Now, once the treatment is not exactly working or there are many side effects, and unfortunately we have to stop the palliative chemotherapy also, or the radiation, we need to stop that. The patient is then referred to us for continuing only supportive care that we call as best supportive care. At that stage, we kind of, with the still being in contact with the medical and the radiation oncologist or the surgical oncologist, we take over that patient and then we kind of provide support till the patient dies. It can be again in outpatient setting, home setting, and then we have place called as hospice care, where we continue providing that end of life care.
our care does not really stop after the patient dies, because we continue providing support to the family member, which we call as bereavement support. So we usually try to support the family at least after till 12 months after the patient has died, in any ways possible. So be it social support, be it psychological help, sometimes financial, sometimes educational help for the family members. So that again becomes a big part of our team and role of our team. So that would be how palliative care actually supports patient throughout the disease trajectory.
Thank you so much. So, in other words, what Shamini told you just now is she is looking at the patient, the disease, and then she provides all the medical interventions. But concurrently, she also looks at the person behind the disease and finds out what the person actually would need and his family, right? So her intervention is definitely to bring relief to the patient of the symptom, but also along with that, we get into all areas of rehabilitation, family support, bereavement support, everything. Thank you so much. So now I'll come to the next stalwart, Dr. Shrikant Athreya here. Shrikant, you have done some fantastic work in West Bengal, like you did family physician, etc. How do you rate the acceptance of palliative care in West Bengal?
Yeah, that's a very tricky question to answer, but I would put forth this way, like when I started off, so I come from Mumbai, and I finished my fellowship from Mumbai and then came to Tata Medical Center in Kolkata. And when I began my journey with palliative care and also expanding palliative care to the outreach, where to the district hospitals, initially the acceptance was very poor, where people were not ready to accept palliative care as early palliative care. Even end of life care was becoming very difficult. But over years of that it was a task. Over years, people have now slowly started to understand what is early palliative care. District hospitals are now having OPDs, which have running OPDs for palliative care once or twice a week, and also they are soon to begin programs in the community where they're going to be empowering the community health workers under the supervision of the medical officers and the nurses, who are going to be then disseminating palliative care to patients in the community. So I feel over the last, I would say 12 years that of my, I would say stint in Kolkata, I've had a very good experience, at the same time bad experiences, but I always took those bad experiences as an opportunity, because there was always something to learn from and also is always something to, partake with. Yeah, that's about what my experience has been so far. Yeah.
All right. So hold on for the next question to come to you. But in the meantime, I'll go to the new player in the field, Dr. Jareen. Good evening to you. Dr. Jareen comes from a Baptist Christian Missionary Hospital that's at Tezpur. It's credit to be given to the hospital. It's a multi-speciality, and the way they take care of the patients, I've seen it myself when I've gone for the program. Now they have a distinction of coming up with a hospice within the hospital premises. I mean, they are working on it. They've got some funding. They're going to start about it. We'll hear more from Dr. Jareen of this. But what inspired you to? You're an emergency medicine person. You're a family medicine person. What inspired you to get into palliative care, ma'am?
Yes, good afternoon, sir. Am I audible?
Can you be a little louder?
Am I audible, sir?
Yes, you are. You are. Yeah. Go ahead.
So actually, what inspired me for starting this hospice care in our setting is because I have seen many life-limiting conditions, suffering. Like those in end-stage cardiac failure, not to mention cancer, COPD. They are in pain, distress, and repeated hospitalization. And especially, we come across also many of these patients when they come to casualty. Because ours is not a cancer hospital, ours is a general hospital. Actually, they are often been neglected. So to streamline and to make things more easily accessible, so we have started this program. And also ours is a setting in a semi urban areas where not many people are affordable. So our team, we are a team of about 10, out of which 3 or 4 of us are just a core member. When they go for a home visit, they see many people suffering at home, and because of their poverty, ignorance, they don't seek medical attentions. They suffer quietly. Also is a stigma actually in the community, you know, because of, again, poverty, ignorance and all. So our team, when they go for home visiting, they bring these patients, and sometimes these people don't even have, you know, they're just couple where husband and wife will be suffering, but there is no caregiver. So during the acute phase, they brought them to our hospital and they're being cared for. And so these are the whole the real reason why we felt that even though we have 4 dedicated beds for palliative care, we need to upscale, and by God's grace we have funders. We are expanding to 15 beds now, sir. We are just in the process of doing it.
All right, that's really very, very wonderful. I'll come back to you for the next question. But on the other side, Sharda madam, good evening to you. Am I audible?
Yes, sir. Good evening, sir.
Yeah. So I have been fortunate enough to do a program at Sparsh, and I'm going to do one more in the coming week. I don't know how many people over here are aware of Sparsh. So Sparsh is an institute which handles acute symptoms of palliative care, and also their main focus is on the hospice as well. So, ma'am, I will quickly ask you, what is your role, and whatever role that you play, whether it's a palliative care patient who's come for acute symptom treatment or it's the end of life, what is the role that you play? The reason being, I want people to be educated about the fact that how this is an interdisciplinary work of palliative care, and what is the role that you as a psychologist, as a counselor, you do, which is measurably, tangibly impacting the quality of life of the patients. If you can be briefly answer us.
Yes, sir. Thank you, sir. It's wonderful seeing you here on this platform.
Are you audible?
Am I audible?
Yeah, now it's better. Yeah.
Yes. So it's wonderful seeing you here on this platform, Dr. Ganapathy, and thank you, Mr. Vivek, for this opportunity. So I work in a platform or an NGO by name Sparsh Hospice. We have been in this field for the last 13 years, and we practice something called a psychosocial model of hospice care. When you work in a non-profit organization, especially in palliative care, we try to self-assign a bigger role for ourselves, wherein it blurs our roles and blurs our boundaries for ourselves. Like in the sense that we are more worried about the 96 or 90% of people who are not availing palliative care, along with the people who are availing the palliative care. So we just heard from Dr. Prashant that very few people, less percentage of people avail palliative care in India. So coming from that angle, if you take a bigger picture of what an NGO does or what I do personally is, we have to ensure that we need to correct the present scenario along with the work that we do for the patients that come to us for pain management or emotional well-being and things like that for their loved ones or for themselves. So when we talk about the patients who are not with us, or we are talking about a situation wherein we don't want to or we want to address a scenario where people have a chance of having a bad death in the community for lack of knowledge of palliative care, then we are personally into the field of advocacy, training, skill development, and awareness programs and all these things. But at the ground level, we are trying to normalize palliative care in the sense that, as my colleagues just now mentioned, very hardly few people know the difference between palliative care and hospice care. People still think that palliative care is equivalent to, end of life care, or people come to a center only to die. So when we talk about those sort of things, our work is very challenging in the sense that we need to talk to people and families in such a way that we make them, sustain that hope, but still not have any sort of, hope for care, but not hope for cure. That's the sentence that we use. And apart from that, I personally believe the special challenge that we have on the ground is, in India, people have access to multiple specialists. Once a person is diagnosed in the family, if I go to corporate hospital number 1. If the doctor says, okay, he cannot be cured, I run to 2, 3, 4. So it's I love to jump, probably because my insurance facilitates it or because I'm very rich. So when this attitude people have, and when they come to palliative care, they still try to find out if we can still do something for them. It's acceptance comes, very difficult for them. So it's pretty challenging, and I love it because that should be the way it is, right? We are talking about Indian context. We are not talking about some Western context where we work in the boundaries of reimbursement systems and all. So I love this kind of work. It's very challenging. So we practice a psychosocial model of hospice care, as my colleagues were mentioning. Like, not along with physical care, we look into emotional care and social care. We have a lot of networking with other NGOs working in the space of alternate livelihoods and children's education and things like that, and spiritual care for the patients. And we
I'll come to you a little later because I'll quickly go on to Dr. Shrikant here. My question is Dr. Shamli here. For the benefit of a lot of physicians who are here, who would probably equate palliative care as only pain management and morphine, etc. Can you take them through how do you taper your goals of care right from early palliative care, then best supportive care, then end of life? I mean, clinically, how do you handle these patients in terms of medication? So that will be in education for people who have this myth that it's only all about pain. Yeah. And they think pain is only from physical, it's only physical pain. Yeah. Go ahead.
So yes, that becomes a challenge for palliative care physicians, because either it's all about giving opioid. Sometimes we are asked to give opioid even when the patient is not requiring that opioid, but it's the concept that patient is metastatic cancer or not for any cancer directed treatment, so you have to sedate the patient now. So that is one of the misconception. And the second one would be like, if the patient is palliative, then the patient has to go to hospice. There is no other way out, or just go home even if the patient has a lot of symptom. You don't need to keep the patient in hospital because they are not planning for any treatment. So those three things are something that we struggle with almost every day. And it's not just physicians, it's sometimes the relatives also, because they Google everything. So that again becomes a challenge. So we have evidence-based symptom assessment form for every symptom that the patient presents with. So it's not limited to pain. We have breathlessness, cough, anxiety, depression, constipation, vomiting, nausea. We know we are in India, so food and constipation are big problem. So appetite. So we have multiple symptom assessment, and we have scales for that. And based on ladders, we manage the symptom. So not every pain requires morphine, and not every breathlessness requires sedation. So that is something that we kind of titrate based on patient's need. And we also need to understand that any of these symptoms that the patient is going through is not just physical. Most of the time, there is this biopsychosocial model of pain that we say, but that kind of applies to every symptom. So it applies to breathlessness also. Once the patient is breathless, the patient gets anxious, patient is more bedbound, not working, fatigued. Again, the cycle goes on. So that biopsychosocial model of every symptom is really important, and holistic addressal of these symptoms actually is meaningful for the patient and the family members. That is what we really focus on managing any of the symptoms. And sometimes it's medication, a lot of time it is communication. So even if you're giving paracetamol, but you're explaining entire thing why you're prescribing and what are the non-pharmacological measures that you have to use along with it, even paracetamol works wonders sometimes. So that is something to emphasize on, that it's not just morphine and it's not about shifting the patient to home or hospice. That is another thing I would like to talk about, is that sometimes patients are very symptomatic, and that's why there is this concept of inpatient palliative care and respite palliative care, where they need admission for certain period of time to titrate over the crisis of that symptom. And then the patient can be discussed in a joint way if the patient wants to go back home or go to their house in village or go to hospice. It would not be our decision to send the patient to hospice or send the patient to home. It has to be a collective decision with the family member and the patient, of course. That is how we proceed even in our setting, we talk to the family member, talk to the patient, assess them socially, financially, and then decide the best place of care for them.
Wonderful. That's very nice. Thank you so much for that very, very exhaustive and crisp explanation that you gave. So on the note, I come back to Shrikant, that you've done... Sorry?
Can I just add a point to Shamali's?
Please add.
Yeah.
Please add. Yeah.
So basically, when we talk about Spike's protocol for communication, and we are breaking bad news to the patients and the relatives, it's equally important that we use a Spike's protocol with our oncologists also, because they have a point. Sometimes they are also like inhibited by certain factors. They're also having, experiences of the past. I think we should not discount them and just, say that no, they're all wrong and we are the ones who are right, and we give morphine, we know what it is and what is right or wrong about it. I guess it's important that we are having an ongoing communication with our oncology colleagues, because they are equally important to us, and only then could we succeed in caring for our patients. Yeah, that's all that I wanted to say. Thank you.
Wonderful. I hope you're all hearing it loud and clear. Okay, Shrikant, now you have done a wonderful work on the front of advocacy, both in the family physician side and the government side. So we'd like to know from your experience, what was it like working with government to advocate for palliative care at a policy level?
At the policy level, so we always have this inhibition, So when we enter the government office, the first thing, when I entered the government office, the first thing I had in my mind was, okay, I'm going to have a bunch of people who are going to be always resistant. Second is when I entered the government office, I had a hunch that, no matter what I do, no matter how much I put in my effort, nothing is going to work. So these are the preconceived notions with which I went. And of course, a couple of times I had a reassurance of my thoughts that it never worked. But over time, it just needed a spark. And over time, it happened that things started to work. And over years, I have realized that people are now accepting palliative care. People are now accepting, palliative care as an integral component of their regular routine care. And when I work with the government, when I started working with the government, and today when I work with the government, there's a sea change in the way they look at it, their perspective towards palliative care. And they're more accepting of palliative care. And they're now they're looking at inviting people to talk about morphine, inviting people to talk about fentanyl. And, having, even today, just 2 days back, I had a conversation with one of the government officials, a DDHS, who works in Swasthya Bhavan. And he was in fact saying that there's a GR which has come in Karnataka where for patients who are being put on ventilators to withhold and withdraw, why don't we do something of that sort here? So I guess there is a sea change in their perspective. And I guess this sea change in the perspective can only happen if physicians and healthcare professionals like us kind of keep advocating for it on an ongoing basis and keep interacting with them, because not everyone is going to be resistive about what you want to do, but it's just about time that people start thinking, and it's just about time that we get off our comfort zone and start moving into zones where, your need is there. Yeah. Thank you.
Thank you so much. So quickly, Dr. Jarin, to you now. Now that you're, doing the baby steps towards establishing palliative care and now also hospice, are you doing something to ensure that your patients get a referral at the right time for palliative care? Any initiative towards that?
Yeah, so basically, to begin with, I try to, talk to the leadership for, early palliative care integration, and to make it a priority, first of all. And from our side, we started training as many staff as possible at all levels, like not only the doctors and nurses, the allied health professionals, on when and how they should, refer patient to palliative care. And you yourself had come and trained a lot of our volunteers. And so not only in the hospital, but many of our volunteers also now started identifying and referring patients, even a patient relative themselves. We every patient's relative, we try to educate them on palliative care. So now we have some few patients, referred by a patient's relative, whose patient had already died, but their relative only, like, referring back to us. So that is one way how we refer. And another thing is that we train all the in charge of every ward, the charge nurse. So in every department, the staff, the head of the head nurse are being trained so that they identify the patients, because sometimes doctors are so busy. And and ours is we don't have so many doctors in our hospital. Sometimes we find those delays, but actually our nurses are doing a really good job. When they identify such patients, they inform us. So we talk to the treating doctors, and then in that way we work together. Yes, so our main these things are our nurses, the nurses whom we have trained. So they inform us immediately after they identify them. And the other thing is that whenever our home care team goes in the community, they do a lot of awareness campaign and also sensitizations. We also have some brochure. Wherever they go, they started distributing, and so these are ways and means through which we get referrals from the community as well as from the hospital. Yes, sir.
Thank you so much, ma'am. Thank you so very much. Now, towards the last question, Sharda ma'am, we spoke about patients a bit. I mean, what is the kind of service that Sparsh gives to the caregivers while the patient is undergoing some procedure in the hospice and post-bereavement? How do you take care of caregivers?
So as you know, palliative care is incomplete without we talking about the caregivers.
A little loudly, please. Yeah.
As you know, sir, palliative care is incomplete without we addressing the issues concerning caregivers. When patients are going through, say, active treatment, say they come to us for palliative care, we have to ensure that their concerns or their issues are addressed in a way that the family feels supported and feels confident to continue that kind of a treatment for their loved one, so that they don't suspend and give up on it, either psychological support or physical support or any type of social support, any of those things. And apart from that, say, for example, if you talk about bereavement, so it is, even before the patient passes away, preemptively the family they start to grieve and things like that. When you are addressing these sort of issues, it's very essential to understand the social structure of the family or the patient, the structure of the family, and address the issues concerning that particular structure. Why I say this is, many a times we need to understand that not everybody is aware of concepts like quality of life or dignity or alternate livelihoods. All these things, many people are not aware, because we are coming from a society where majority are living below the poverty line. So when you're talking about the families, we need to assure them that some kind of support is available for them in terms of emotional support or any type of support post the passing away of the patient. That kind of support is added or given to these families.
Okay. So as we are concluding the session, thank you so very much, ma'am. I'd like to leave with one thought for definitely non-palliative care physicians to reflect on, that don't dig too much into the disease, when it's not required. Akhil, sorry for saying that. And the most important thing is, we are not looking at what disease does the person have. In fact, in palliative care, we look at what kind of a person has the disease. So we are focusing again and again on the human side, the people side, by, of course, not compromising on the medical aspect of it. Thank you very much, Uhapo, for this wonderful opportunity. Thank you, Srikant, Shamli, Dr. Jareen, and Sharda ma'am. And thanks a lot. And you can welcome our friend, Dr. Akhil Kapoor, who's all eager.
Thank you so much.
Thanks.
Thank you so much, everyone. Dr. Akhil Kapoor, I would request you, because so far the fortunate part of this conclave is that it's running exactly on time, 5 minutes here and there, which is considered to be the Indian standard time. Well, Dr. Saab, you want us to flash your slides on the screen?
Yes, please. Yes, please.
Okay, cool. So, Ramjit, please flash Dr. Akhil's slides on the screen. Yeah. Over to you, Dr. Saab.
Yes. Thank you. Thank you, Vivekji. Thank you to the entire team for this opportunity. And as today's World Cancer Day, we look at various features, various parts of the treatment. It is not only about the treatment, it is about the quality of life, it is the patient satisfaction, it is about the improvement in the overall quality of life of the patients. So I would request Dr. Madan Gopal for his first comment. So, what is the current level of patient advocacy in policy making? This is a very point which is very active and well discussed throughout the world. Actually, in US, patient advocacy groups have very important say in policy making. But I think this is somewhat lacking in our country. So I request your comments on this point. How do you think, and where are we heading with this patient advocacy in policy making?
Okay, thank you, Akhil. It's a very good thing because I've been into this policy space for quite some time now. So one of the important things which we encounter now, we have started increasingly thinking about involving the patient support groups and others in our policy dialogues. And this has been initiated. I think if you look at the past discourses which Niti is now carrying out, they are involving the patient support groups for their policy making. But nevertheless, in past also, we have been including patient support groups in our discourses for making treatment strategies and other things. Because at the national level, we can focus on the strategies. But based on the treatment experience, you see how the treatment, you take the example of tuberculosis. So it is based on the inputs received from the patients and the other groups that the nutrition component was introduced. Had it not been that case, then it would have been very difficult. You take the case of the cancer treatment also. We do have a national national non-communicable disease program, NP-NCD program is there, which includes cancer. In this, apart from promoting the awareness as well as advocating for screening of the cancer at the very peripheral most level, what we at peripheral most level means at the arm centers. The arm centers are the peripheral most health institutions catering to a population of 3,000 in tribal and difficult areas and 5,000 in normal areas. They are having a trained nurse who is known as the community health officer and supported by auxiliary nurse midwife, ANMs, male multi-purpose worker female, and the ASHAs in the. They are equipped and capacitated for doing the screening part. After the screening part has happened, that means we are trying to educate people to come forward through interpersonal communications, say that they come forward and screen based on the checklist which they are having. After they are screened and if they are found to be having some symptoms, they're immediately either through the teleconsultations, they are consulted to the hub, which is at the district hospital or the community health centers, and their referral happens. And side by side, you would be happy to know that in the recent current this budget speech, budget announcements, so there has been an increased support, augmented support for daycare cancer centers in the district hospitals. It's not a new thing, but we now all the district hospitals now currently they are having this daycare cancer centers in 394 district health institutions. Now we will be taking it to more than 780 district hospitals are there. We will be going towards that and simultaneously augmenting that. This is about the infrastructure, the capacities which we are trying to create. Now coming, because these daycare cancer centers, if you look, can go back into the genesis of this, how it has started. Because there was a request from the patient groups saying that they have to travel a far away place for the cancer treatment. If the cancer treatment can be made available on a daycare basis, that means if they go to a hub institution, a mother institution where the cancer treatment program is been designed for them, and they can continue the treatment at the district level and other places. That kind of model is now evolving. That means it is based on the inputs from the patient groups and the patient sites, which have been we are trying to cater to that. Other thing is, because once the treatment has been started, so the treatment can be continued. The continuum of care can happen at the place which is nearer to the patient. So this kind of hubs, this is a daycare cancer center, they would be acting as a centers for providing that kind of treatment. So You might have seen the National Cancer Grid, which has now extended from Assam to Jharkhand. So they are all playing a role in that. And in this, patient groups are already been represented. If you look at how the patients are now coming forward, the patient support groups and the patient advocacy groups, how they are coming forward and trying to influence the policies and the strategies and the treatment modalities which are very available. But in the public health system, we have to see that the affordability and the wider views that is being always factor rather than the precision and other things. So we have to always see that how we balance it out in nevertheless the idea of involving the patient support groups in not only in cancer but in the other disease specific programs also, it is increasing now. And increasingly they are contributing to the dialogues and they are contributing to the shaping of the policies and the strategies which we are thinking. Now, whenever we think of having a dialogue, we usually always think that which are the patient groups which can be factored in, who can at least contribute, not to just so not to give comments on an individual basis. That means I have faced this, so I should be having this. On a wider basis, which can have wider implication for many of the patients, we look forward to that kind of suggestions, which can impact a lot of lives and other things. This is all. I think a lot of things are now happening around this patient advocacy and patient support groups, and we see that how in future more and more such things are happening. This patient support and patient advocacy is now picking up. It has now getting into a movement. It has now becoming a movement. We see that how this movement can be capitalized, it can be brought into the system, and it can help in contributing to the cause of cancer and cancer patients. So I stop here. Thanks once again for this opportunity.
Thank you, sir, for highlighting the most important and relevant points. And yes, definitely, I think we see a lot of changes from the perspective of the policy making. A lot of points which are coming up from various fronts. We see now in the budgets and various forums, these things being discussed. Previously, these things were not discussed, but these things have not taken precedence. So this is becoming important. So I congratulate the entire team for bringing these important points, and these are making way to the government discussions, government policy making, which is a very welcome change for the entire country, actually, for the point of cancer. And in all the budgets, what we see, there are specific announcements which are related to cancer field improvement. So I think from the policy making point of view, as a doctor, I can see that there are things which are coming up from the government perspective directly for the benefit of the patients. There will be definitely more improvement will be required with time. But yes, this is a step-by-step pattern, and we cannot expect sudden changes. But yes, we are seeing very positive and welcome changes. So that is worth commendable. But this is worth commending, actually. And we are also in touch with Ayushman core committee of the country, and we have sent some recommendations from the point of view as a clinician. And through TMC director, we have sent some recommendations. Hopefully, this will bring more changes for the benefit of the patients, because today I think Ayushman is one of the most common utilized schemes throughout the country. Our hospital has consecutively got TMH Varanasi, Tata Memorial Center Varanasi, has consecutively for 3 years got the highest utilization of Ayushman for the field of oncology, highest utilizer award, actually. So we look forward for contributing to improvements in these schemes for the benefit of the patients. So thank you, sir. Thank you for your.
In fact, Dr. Akhil, when we were designing this PMJ 1.0, HBO 1.0 packages, the oncology, cancer care, and other things were there. They're only in the interest of the patient. We have told that the tumor boards would be a part of the treatment plan. It's not left to the institutions at all. That the tumor board concept also was promoted when the Ayushman PMJ program was launched. That means right from that time, we have been always thinking that in the interest of the patient, how we can deliver the best possible services through the government institutions. So this is an add what you have told about the PMJ program.
Thank you, sir, for these really relevant comments. So let's come to the second part. Can we have the screen flashed? So now we look at various other perspective as well apart from policy. This is a question to the Utsav Foundation person, Mr. Ratan. I have worked with Mr. Ratan Dekle very closely while I was at TMH Mumbai, and also we continue to trouble him from Varanasi as well for the benefit of various compassionate access programs in which he actively contributes. So I will request his comments. What are the accessibility to the government schemes like CM Relief Fund, Prime Minister Relief Fund, and what do you think? What are the most accessible ones, and what, as a doctor, we can do to improve the access to the of these funds, which are already available for the benefit of the patients?
Thank you very much for the opportunity. I'm very glad to present my presentation over here. And the PM, the whatever yojnas are available in India. So they are not a patient. They don't have the patient-friendly ecosystem. So whenever they don't have the online access program. They sometimes have the lot of patient get the benefited of it. But problem is that they are not accessible properly and they are not informed properly. They don't have the hierarchy structure. Okay, you have to do this, do this, do this. They don't have step-by-step guide. They have a lot of guidelines properly. But some point of time they stuck between them. Ke, aisa karna hai ya waisa karna hai. So there are very questionable guidelines are there. So then that's which I noticed that things. And the CM's various states CM's yojnas does not help patient to get the yojnas properly. I was searching the various state government funds and their guidelines. So their guidelines are not updated since 2018. They are following the same guidelines 2018. Even the MP structure, the MP government was introduces the Yojana, Mukhyamantri Fund Yojana, and the lung cancer patient, which 2018 was the very, they don't have the targeted therapy procedures and helping. But on that point, the MP government only sanctioned 50,000, which nowadays, if you go for a targeted therapy, you will get a lot of benefit for the patients, which I'm thinking. And the PM Yojana, it's a very sweet Yojana because every person, whomever is applying, they're getting funded. They does not count the patient via their curability, either their palliative care, either curative care. They does not mention anything. They just believe that this patient applied us, and we want to give something to them. So the PM Yojana is very sweet, and we have to access via. We have to go through the MP and a PM and member of parliament via member of parliament letters and all. But if you process further, it's really helpful and very engaging and easily to do the things. That's my thought.
So I think this is a very important point. What we see and understand, these schemes are available, but sometimes either the patients are unable to apply for the same due to some of the constraints, and they are unable to understand the process for the same, or sometimes the schemes have limited support. Sometimes, for example, in our state, what is a good thing that we get good support from the Chief Minister Relief Fund for our patients. Presently, what happens when we apply for 7 to 8 lakhs fund, most of the time patient get close to 3.5 to 4 lakh funds. And that gives a good seed money to start proper quality treatment. And most of the time, the treatment can be completed in this amount, considering the government hospital cost in our hospital. So that's a very important point. And apart from there are so many other schemes, for example, Indian Cancer Society funds, which we tend to utilize. In fact, to tap these funds and utilize these funds for the benefit of the patients, we have formed a special committee that is we held every week on Saturday. We discuss which patients are not able to start proper treatment due to cost constraints, and we try to find in which fund patient is fitting into. And our social worker team leads the same with definitely the help of our support team and our doctors as well. So that approach is very useful. And at our center, the benefit is that in all TMS centers now there is a cadre called KVATs. These KVATs help to transfer the correct information from the doctor to the patient and social workers as well, because sometimes social workers are also limited. Hand-holding is required to transfer the correct information and to make the patient apply for the funds at the correct time. Otherwise, what happens? The patients are unable to get the benefit of the so many schemes which are available. And besides, since we are one of the largest utilizers of Ayushman, we are trying to work upon on Rashtriya Arogya Nidhi scheme as well, RAN scheme. So that scheme is a very good scheme, and that increases the cap of the fund from 5 lakhs to 15 lakhs for the benefit of the patients with serious diseases like cancer. So hopefully we'll be able to reach and solve this issue and reach to the 15 lakh cap for Ayushman holders, so that these patients can get the benefit of other treatments like targeted therapies also. And this will be much useful, because as we were discussing initially during the panels, the treatments like targeted therapies, as Ratan was also trying to highlight, they are somewhat costlier, but they have very significant impact on the outcomes of the patient and improve the life of the patients. It is not only about the treatment, it is about improving the quality of life of the patients. And hopefully we'll be able to utilize more and more patients. Thank you, Ratan. And also Ratan helps us in various compassionate access programs. So I think all of the team might not be knowing about compassionate access program, but the compassionate access programs are for the drugs which are not available in the country commercially. But for example, there is a drug called larotrectinib for NTRK fusion. This is a rare fusion which can be found in pediatric cancers and some adult cancers as well. For that, we don't have a treatment available, but a drug is available in various parts of the world. And with help of Ratan and the pharma companies, we were able to get the drug free of cost, which is actually costing 7 lakhs per month if we import it. It was got free of cost to the patient. And we have around 4 patients running on that compassionate access program, and multiple other. We have total 72 patients who are in compassionate access programs at our center, which is very high. And this is a commendable effort from the entire team. And I congratulate Ratan, Utsav Foundation, and Uhapo for this commendable effort. And hopefully such efforts can improve the outcomes without adding cost to the entire healthcare system, at the same time benefiting the patients in a very significant way. Thank you.
Thank you.
Thank you, Ratan. Thank you. Let's move to the third question. So this is another very important part. This is directed to Miss Meena Ganesh ma'am. She is from Bangalore and founder of Uhapo Foundation. And I will request her for her comments on services which are in demand for cancer treatment in our country, and whether presently there is enough maintenance of whether we are actually able to supply what the patients are demanding. Requesting your comments on that, ma'am.
Thank you, Dr. Akhil, and thank you, Vivek, for calling me into this. So, as you rightly mentioned, I'm the founder of Portia. Portia is an outside of hospital healthcare company. So, we provide all kinds of services that patients may need at home or outside the hospital in any other location, maybe in their office or digitally or at their home. Now, as many of the esteemed panelists earlier in this panel and otherwise have mentioned that cancer care is not restricted in that neither the treatment nor the healing nor palliative or end of life care is restricted to a facility. There is a lot of care that is required outside of the facility, which could be typically at home in most cases, and sometimes you need a lot of support digitally as well. Now that is where Portia comes in, and what we have found is that across the entire spectrum of cancer patients ranging, and by the way, this experience, I even set up Portia actually because of my experience dealing with cancer in my own family. So from the experience, I realized that there is a lot of struggle to get all these other services that patient need, starting from regular labs, maybe supportive care, such as for pain management or wound management or physiotherapy or certain drug administration which can be done at home, nutritional, providing additional nutrition and so on. There is a lot of requirement across the whole spectrum for the patient and for the caregiver. Now, as far as our services are concerned, ranging from labs to physiotherapy to nursing to setting up an entire environment with medical equipment so that they can be treated at home in the way they need to be treated rather than necessarily have to go to the hospital. Can you
Dr. Prakash, you
mute
mute yourself.
Dr. Prakash?
No, no.
Yeah, sorry. So continuing on what I
Yeah,
was
please
saying, that
continue.
there are a number of different requirements, and that is what we've been servicing. Interestingly, we've also been called upon on occasion by the doctors to provide even chemotherapy services at home. Now, the advantage of doing that, of providing all these services, is that it helps in better recovery of the patient. It helps provide respite to the caregiver, because in some cases, you need a 24/7 caregiver to look after the patient so that the family member can go and do whatever else they need to do, which is including their own jobs that they need to follow up. So starting from starting from lower acuity cases to end of life, there's a whole bunch of services that patients do need. And we attempt to provide that to the best of our ability, but certain kind of skills are sometimes a little challenging. For instance, nursing care at very high end tends to be a little challenging. You may or may not get the right kind of nurses who do that. But that apart, for the most part, we are able to get the right kind of manpower and right kind of medical equipment to help people manage their loved ones' care at home.
So I think this is a field which is evolving, and I think tier 1 cities have already started on this, and this is a welcome change which is required for the benefit of the patients. And also, as Meena ma'am was highlighting, even doctors are now requesting for the same, because we want to give the patient the best possible care, even at home if it is feasible, for the comfort of the patient. Sometimes it is very difficult for the patients to travel to even nearby hospitals, because these might be frail enough not to travel to hospital, and these will actually be important. So definitely there's a lot of need, and this will gradually, it seems, will percolate to the entire country, and will be a very useful way to manage the patients, not only for cancer, but for all the advanced cancers, all the advanced diseases, including palliative care for various diseases. Not only cancer, includes chronic renal failures. There are so many diseases for which we don't have cure available. It is not only cancer. And I think that is an important goal which we should establish, that in next 5 years, we'll have more of such services which are more capable and able to give quality care at home, and they can consult the doctor on call or the specialist on call, so that the best possible care can be provided at home. Thank you, ma'am. Thank you.
May I just add one more element, which is probably worth discussing in this panel or otherwise, which is who funds for this care. So as of now, the problem is that this has to be funded out of pocket. There are very few insurance companies, even private, that are starting to fund home care, whether it is a continuum of care or in lieu of hospital care. And in both these circumstances, we have very few insurers that are providing this support. But this is something that the patient and the family needs very, very, they need it for sure. So there has to be some more work done to see how this can be either included in the government schemes for reimbursement, or in the private insurance companies providing the cover for this. This is something which is missing, and I think we need to see how this can be brought into the mainstream from a payer
perspective. So this is a very important point. As the field evolves, there is a problem of reimbursement, and this including in the routine care, because these are not yet mainstreamed into the cancer care or any medical care till now. That makes it difficult to get it reimbursed directly. But mainstreaming of these services into the healthcare system will definitely get the benefit transmitted to more number of patients. Thank you, ma'am. Thank you for that very important comment. So we move forward towards next speaker, Dr. S. Prakash. Can we change the slide? Yeah. So now Dr. Prakash has been a former FD of Star Health, and we know that Star Health is one of the most common health insurance which we see our patients also taking, and a lot of the doctors also have Star Health insurance actually. So if we see now how these private healthcare insurances are evolving, are there any schemes specifically for cancer patients, and how do we see there are always some limitations and problems which we see, that sometimes patients are told that if you don't get 24-hour admission, you won't be reimbursed. How are things improving in this field? Because from the insurance point of view, we want to understand the perspective from a health insurance company and as well as from the point of view of patient. Yes, Dr. Prakash.
Thank you, Doctor. As I appreciate the organizers for this initiative, I just want to clarify one thing. Any science that has not reached everyone in this country has no relevance. Every one of us are aware of it. But attributing the non-accessibility to private insurance is only conveys that people have not understood the fundamentals of insurance. Health insurance companies can pay for cancer only if someone has taken a policy when he is otherwise all right. And then if he is diagnosed with a cancer, naturally 100% it should be paid. Answering your specific question, whether you are choosing to give chemotherapy or immunotherapy, whether it is given as a daycare or as an inpatient, there should be no questions asked, because as long as the insurance customer is treated as per the opinion of the team or board in a comprehensive cancer care center, the insurance company cannot ask any question and they have to pay for the claim. But what problem comes, many of my own doctor friends, they call me, when someone is diagnosed with a cancer and they are already on treatment and they have exhausted whatever support or funds that are available, and then they ask for an insurance cover. There, they should understand when somebody is already suffering and there is a financial liability, insurance does not have a role, because insurance collects money from 100 people and pays for 15-20 people. That's how the concept works. And today in the health insurance claims, I could see that some 10 to 15% are related to cancer, and it is growing. So these are the people who have taken policy when they are otherwise all right and they have been diagnosed and they get the benefit of insurance coverage. But for people who are diagnosed with a cancer, actually there are policies available in the industry where it is given for a cancer survivor, provided post the cancer, if there is a recurrence or a double second malignancy or a metastasis and if there is a treatment required, 2 years after taking policy, this will be covered. Till the time, this coverage applies for non-cancer treatment. So there are identified cancers where health insurers are willing to offer cover, but the cover starts after 2 years for cancer-related problems. And the first 2 years, it is available for non-cancer also. For a fever or a fracture, it is available. So people have to understand these things, but always these covers are coming with a higher cost. Unless there is some subsidy given by government, cancer patients cannot have a cover at an affordable price. So my role here as a doctor in the insurance space, I don't want to take more time. My role here, I am willing to align with cancer advocacy groups, palliative care people, and I'm willing to take this initiative like National Cancer Care Guidelines. Why can't you create guidelines for insurance companies? Insurance companies who have been handling fire, marine, motor, and property insurance are now covering health. Their knowledge on the intricacies will be remote. We have to help them with the sufficient clinical material and an algorithm to say that these people can be covered These are the categories where you have to wait and watch. Some information given to them. Probably I can help you to take it to the insurance policyholders through the General Insurance Council and Insurance Regulatory and Development Authority of India. I want some of the senior people who are leading these initiatives to connect to me, and I am at your services to see that how we can extend cancer coverage. There is a lot of requirement and expectations from the public and from cancer patients with regard to cancer cover. But not even 10 to 15% of the requirements are fulfilled today at the industry level. And if it has to extend, we have to expand the knowledge and understanding of the executing people, policymakers and implementers in the insurance industry. Towards that initiative, I'm willing to be a bridge. And I wish that, because this cannot be addressed in a 5-minute talk like this, but an initiative can be taken, because courage is not in knowing the path, but in taking the first step. So instead of talking about individual reimbursement or claim issues, I would rather submit myself to work along with you to create a proper policy and guidelines, so that in a phased manner, your requirements on cancer cover can be addressed by the insurance authorities.
Thank you. Thank you, Dr. Prakash, for this important comment and taking giving an option of taking the lead and contributing to provide comprehensive guidelines for the insuring companies. Because as Dr. Amit also highlighted in the chat, that there are some issues relevant which we as a doctor face very regularly. For example, sometimes oral treatments are not reimbursed, sometimes scans are not reimbursed. I think as experts, we need to provide some guidelines to the insurances companies that this should be strictly followed, and IRDA and other agencies should take precedence, and we should be able to give some proper comments and proper guidelines to these insurance companies, because as you said, the insurance companies don't have expert people, and they are working on the same agenda as you told, for not related to health. So they may not have understanding of what is actually required for our patients. Dr. Amit, you wanted to add anything? You can unmute if you want.
No, that's the important thing. So because the cancer treatment is rapidly evolving and people are going for a less hospital-based treatment, it is mostly coming to an OPD-based care. So I think so the OPD reimbursement is not the next thing which should be there, rather than the cost increases once a patient gets admitted. So we like to go more for an oral or a subcutaneous therapy which is based only on an OPD basis. And diagnosis is one of the part that is the thing which everybody is suffering, because diagnosis has to be covered. What we see in most of the corporate hospital, what they do, they add a chemotherapy regime along with the diagnosis to get the patient reimbursed. But it should not be like that. It should be the patient is being evaluated after 3 or 4 cycles of chemotherapy for a diagnosis only, then it should get reimbursed for that also.
I think we need to come up with some solid guidelines which can be provided to IRDA, and IRDA can enforce it through the proper system that all insurance companies need to follow. Otherwise, these things will continue to happen, and we will be at some insurances will have various points which will not benefit the patients who are taking the insurances. So I think we can move to the next part. Thank you, Dr. Prakash.
Thank you.
Let's have the next question. Yes. So next question is to my colleague, Dr. Kunal. Dr. Kunal is a medical oncologist at Mumbai, and he had been our colleague at TMH Mumbai as well. And I know that we have worked closely on various aspects. As a clinician, how does your decision making get impacted by recommendation, the needed therapy versus what the patient can afford? So this is I think this is very common problem. Can you give some percentage where we are not able to provide guideline-based treatment to our patients? What will be the rough percentage in your practice? Dr. Kunal, you can unmute yourself.
On any of the sides, even from the hospital side, also from the patient's family side, then this percentage it's around 20 to 30% also. So it depends on the region and the place of practice. So while recommending a treatment, it becomes very imperative for the clinician to let the family know what are the expected benefits and what are the outcomes. Sometimes while recommending a costly treatment or the latest treatment, which might be the best suitable in terms of data and oncological outcomes, patients and the families and the caregivers usually think that the costliest treatment would mean cure of the disease, even if that is given in a palliative setting, or they aim for a longer control. For there also needs to be clarification on the meaning of long-term control. For example, for oncologists, long-term control for targeted therapies or immunotherapies usually mean anywhere beyond 2 years. But for patients and the families, if the discussion is not made properly or in much detail, then they think that long-term control would be beyond a decade. So all these things becomes very important to discuss, to discuss the exact quantum of benefit approximate according to the data available. What are the expected side effects? What are the out-of-pocket expenditure which can occur in between the therapies, which we are because of side effects or because of intolerance? And what are the financial toxicity risk? What are the time toxicity? And this all needs to be discussed. And because of this, we many a times are not able to follow the right clinical guidelines, and we have to make the most practical decision in deciding the treatment of the patient.
So I think you were trying to highlight about something like ESMO MCBS score, magnitude of clinical benefit score. Something like that can be much more useful in Indian settings as well. And we can understand the cost benefit of the treatment so that it can be easy to convey to the insurers and various people who are involved in the treatment and policy making, so that we can, the patient and the insurers and the various, everyone is aware what is the quantum benefit we are dealing with.
So just adding to that, in those efforts, we should do a lot more. Like, for example, probably next week, we have a meeting at Tata also about health technology assessment. So this kind of meetings are important to, first of all, give an idea, give an economic and the social idea behind framing guidelines for the recommendations, so that these recommendations can then be percolated to the patient, to the insurance companies, to the hospital administration, and also this can be followed uniformly without creating a confusion, with knowing the Indian aspects of the repercussions in the Indian scenario of offering the treatment, which usually is written in NCCN, but we should also have our own guidelines pertinent to the social scenario.
Thank you, Dr. Kunal. So these are actually very relevant from both patient point of view, physician point of view, and the insurers and policymakers. So let's proceed to the next question. Next question is to Mr. James Rajkumar, who is the VP and head of NATCO India. So NATCO India is doing a fabulous job in terms of making various generic drugs available. So I request Mr. Rajkumar, can we change the slide? I request Mr. Rajkumar to highlight the important perspectives on generics versus innovator drugs, and how in various pharmaceutical companies are trying to collaborate with Indian government to improve the access to the treatment for a vast majority of our patients. Yes, Mr.
Good evening.
Good evening. Good evening.
Coming to the point of affordability or access, I think we have come a long way from where we were in early 2000 when the first targeted therapy imatinib was introduced. That was also the point where our company started and many other Indian companies started. And to the point where we are now, I think access has improved a lot, whether it is in terms of physical availability or in terms of the technology, when you talk about CAR-T or the cell and gene therapy, or in terms of the financial access. We have come afar. I think that's a tremendous job done by the pharmaceutical industry. Anywhere in the world, if you travel, you don't get this kind of an support anywhere else in the world.
Completely agree. So India is one of the generic producer of the maximum generic producer of the entire world, actually. So that is a commendable work from our pharmaceutical industry.
Thank you, Dr. Akhil. And one thing which we would like the policymakers to look at when we are expanding access through the central government funding or through the state government funding. It's very good. I think the percentage of patients getting treated probably in the early 2000s, maybe in a palpable tumor, the percentage was good, but in non-palpable tumors, it was very less. But today, even 40% of patients in some of the tumors are getting treated, or even higher. That's as good as some of the developed countries. I think we are definitely in the right direction in terms of diagnosis, treatment, infra, training, and the specialists, and the dispersion of specialists into different interiors. Everything is fine. But when it comes to policy making of selection of drugs, it is always better to consider few more technical criterias, because if L1 is going to be the only criteria on which a class of people is going to have access to the drug, are we denying them the quality or the effectiveness or the efficacy? That's a question which we have to ask ourselves. Can we not include few more criterias in selection? Can we balance it out? Some of the teaching institutions balance this very well. When they have a technical bit and a commercial bit, I think it's balanced very well. Sometimes the commercial bit takes precedence over everything. That's exactly where can we have bioequivalent studies in some of the therapies, or can we have 3 years market standing, the volume of production, or do they have an FDA approved factories, or do they supply to some of the best regulatories in the world? If this can also be incorporated, I think we are perfectly in the right direction. This is one area which we would like to point out. When you asked about the collaboration, I think irrespective of whether you are a multinational or an Indian company, I think everybody has collaborated with government when it comes to awareness through the digital, through the in-person, various ways. We have created a lot of awareness. I think the medical community will certainly acknowledge how the pharmaceutical company has also been part of busting out the stigma of treating cancer, which was there a few years before. It still exists, but then with the digital media, I think we are all penetrating deeper with the popularity of YouTube videos and various social platforms. I think slowly we are getting rid of all those age-old myths about the cancer treatment. That's very important, because when you really talk about the cancer control program, then definitely you need to have the right awareness. And then you also need to have the right kind of patient education as well. In these areas, I think the companies and the government has definitely collaborated well. Probably we can explore more. And we also want to thank government for really focusing on the cell and gene therapy and the newer technologies. Definitely, there's a lot of support from the government in bringing a proper framework, and also looking into the statutory things. And also somebody was telling I think in one of the panels, they were telling about the funding from the government. These programs outside the pharmaceutical industries are also well funded by the government, especially the cell and gene therapies and the biological therapies. So we also appreciate the government and its efforts, not only in early detection and the awareness and the infra, but we also acknowledge and support the government for taking up the cost of cell and gene therapy.
Thank you, Mr. James, for this very important and relevant comments. I completely agree about technical and commercial bit. As a part of a government institution, I always try to get technical bits first and then go towards commercial bit. That makes it more relevant. Otherwise, the quality of the product cannot be mandated, and it becomes just cost and nothing else. So we cannot sell a drug which is not proven to be useful, which is made very cheap, but we know it might not be useful, but only because it is very cheap to the entire population, to all the government institutions. So I completely agree with your comment. Thank you, Mr. James. So in the interest of time, I would like to proceed further. Dr. Chitra is there? Yes. Yeah. So Dr. Chitra, she is the head of Government Affairs and Policy Advocacy Group. And this is a very important and relevant question of adult vaccination, especially in the field of cancer. So we know that cancer is mainly focused on the therapeutic perspective, not about vaccination. HPV vaccine is now being coming up rapidly, and hopefully it will be mandated throughout the country. And how do you see, Dr. Chitra, that vaccination is being taken up by the government and other cancer stakeholders? And also we see various vaccinations for the prevention of infection while the patient is on cancer treatment. So how do you see these to be incorporated into the various guidelines and incorporated into the government policies?
Thank you, Dr. Akhil, and thank you, Vivek and Uhapo, for giving us this opportunity. So, as you have highlighted, that we can categorize vaccines into two different buckets. One is the therapeutic, where means they are aimed to treat the cancer when it occurs, and it is designed to cure or reduce the size of the tumor, stop a tumor from growing, or destroy the cancer cells which are still in the body after the therapy. They're under development. But there is another class of vaccines, which is preventive vaccines, which I would like to touch upon more in detail. So one is the preventive vaccines for infection, to prevent infections. And you have highlighted the HPV, which is the infection which can cause many types of cancers, including cervical, head and neck, anal, penile, vaginal, many different kind of cancers. And a shot, getting a vaccine reduces the risk of cancer. And the another we all know very well is a hepatitis B, which is a liver disease, and an infection of hepatitis B virus may lead to a mild illness, but in a chronic long-term serious illnesses, it may also lead to the cancer. And again, a shot of a vaccine is something which can reduce the risk of getting the cancer. And the another category of preventive vaccines which you have highlighted is about the preventing the infections for patients who are dealing with the cancer. So it's not the vaccines which are not preventing or treating cancer, but they are supporting cancer patients to prevent their various different vaccine preventable infections and the complications attached with them. And by the nature of the disease and treatment, mostly cancer patients are have a compromised immune system, and which makes them vulnerable to catch infections, if I might say, much faster and much easier than a normal person. Means I can quote the example, very recent example of my own very close family member, where we saw the kind of isolation we had to maintain throughout the chemotherapy to protect the patient from catching up the infections. And that leads to the not only the immunizing the patient, vaccinating the patient for various vaccine preventable diseases, but also the caregivers. And that's the kind of isolation and a lot of vulnerabilities that we may prevent through these vaccines or vaccinations. I'll give you the example of shingles, which is caused by herpes zoster virus. The same virus we all know is, as medical, at least all of you know, that it caused the chickenpox also in mostly in the childhood. And as per the published data, 90% of us are exposed by this virus. Either we have the symptoms or not, but most of us are exposed in our childhood or adulthood. And once exposed, this virus stays in our nervous system in a dormant stage. And once the immunity is weakened.
I completely understand your point.
So I'm just coming to that, sir. So thus we have several vaccines. We have several guidelines available in the country by various clinical associations, but there is still a gap in terms of vaccine and vaccination. And that's where these guidelines and the partnerships between industry and the government and guidelines by the organizations like TMH are very important. And apart from the guidelines, I think one more important aspect is the touch points. In the case of adult immunization, I think this is a gap where we don't know where to go for the immunization of adults and these patients. And that's where I think there is one more important aspect that, for example, these cancer care centers announced by the government. Can we also look with the guidelines and with the guidelines from institutions like yours, can they also serve as a vaccination centers? So there are many ways where we can together conduct awareness, capability building of healthcare practitioners who are not aware of these things, as well as the overall ecosystem. So these are the few things which I thought I'll share with you. And means there are various ways we can collaborate and make these vaccines and vaccines to vaccination journey possible for the cancer patient and protect them from various infections.
Thank you, Dr. Chitra. So these are very relevant and important points from the perspective not only as a doctor but as so that we can mainstream these vaccines into the system, and there should be some proper guidelines as well from the apex institutions, cancer institutions in the country, and how we can incorporate directly these vaccines into the daily routine practice, and they can be utilized, and the cancer centers can be one of the part of adult vaccination centers as well. So thank you for bringing.
So there are just one line to add. So there are many vaccine guidelines available by clinical professional organizations. There's recently 14 clinical associations came together, and oncology was one of them, the association, and they developed guidelines for various risk groups, and cancer is one of the risk groups. So I think we need more, plus the vaccination, from the guidelines and vaccines to the journey of vaccination, more vaccinations. So that's something which I wanted to elaborate and highlight.
Thank you, Dr. Chitra. So this is a never-ending part, and I think in the interest of time, I should stop here. I can see my seniors and colleagues waiting for the same. So back to Mr. Vivek for taking it forward. Thank you.
Thank you so much, Dr. Saab. It was a very well moderated session, and it was quite an insightful session. I could see that almost 85,000 people were watching this session, which talks volume about the content, the kind of discussions that we are moderating over here. Let me welcome Dr. Urvashi Prasad, who has been director at Niti Aayog, now is going to take over the next session and moderate it in the interest of the community. Dr. Saab, please welcome.
Thank you, Vivek ji. Can we just confirm the panelists we have here for this session?
Yeah, we have Dr. Amit Kumar, we have Dr. Trinanjan Basu, we have Dr. Venkata Pradeep.
Okay.
Yeah,
There.
and we have, just a sec.
Is Dr. Priya here?
Dr. Priya is also there. Yes.
Yes, she's there. Okay. All right. And Dr. Gunjesh is not here, right?
He's not able to join, I guess.
Okay.
Yeah.
Okay. So we'll start in the interest of time. We have a hard stop in half an hour. So firstly, thank you so much, Vivek ji, for organizing this whole conclave and taking up very important topics for discussion. And like you mentioned, there's lots of people watching and tuning in today. So that is very encouraging. The session that you've given me to moderate is on improving cancer care access through government schemes. And we have with us some very eminent doctors, oncologists. We have Dr. Basu, who's a radiation oncologist from Mumbai. We have Dr. Venkata Pradeep, who is a medical oncologist from Assam, Dr. Priya, a thoracic surgeon from Mumbai, and Dr. Amit Kumar, who's a medical oncologist from Patna. And so I think we have a very nice diversity here as well from different parts of the country. Before I go to each of the panelists, which I'll do in a minute, I have this for this particular session. I thought that that is what I proposed to Vivek ji, that instead of having specific different questions for each of you, I think because the theme is government schemes, what would be really helpful to get from each one of you is, where do you see the successes of government schemes? And this could be anything from screening, detection to treatment and rehabilitation. And where do you see the gaps? Where do you see that we need to do much better? Because I think each of you will bring your own unique perspective. I'll just give a very brief introduction because I am myself a public health professional. I've also worked in the policy space in Niti Aayog. for 8 years. And so I've been involved with a lot of the flagship schemes and programs. And I'm also a cancer patient myself. I'm still living with cancer. So I think I have a very unique perspective, given that, I wear all these three different hats. So from my point of view, I think the way I see government schemes, yes, we have made some amount of progress. Whether it's Ayushman Bharat, where we are supposed to be doing screenings for cancer at the primary care level at the Ayushman Arogya Mandirs. We also have the PMJ, which is supposed to provide health insurance for hospitalization, inpatient expenses. We have, now certain amounts of, concessions being made on certain drugs for cancer to make them more affordable. We have this latest announcement in the budget to say that, cancer care centers should be expanded. So I think there's a lot that has been announced. But in a country like India, as I know very well, the challenge is implementation. Implementation in different states, different districts is very variable. And how much are these schemes really reaching and impacting the last mile? The patient who is maybe, say, in a remote rural area, or is from a very economically weak background. How are these schemes really changing his or her life? I think that is what we really need to try and understand in today's session. Because in my mind, there are still a lot of gaps between the policies as they are written on paper, as they are conceptualized in theory, and when we actually get them to the ground. So it would be wonderful to hear from each of the panelists in their experience, in their context, in their geography. How do they really see these schemes having performed? And where do we believe are the real areas for improvement? So maybe we could start with Dr. Basu, and I'll come to each of you one by one.
Hi, Vivek. Thank you for the invitation. Sorry, I'm traveling back from work, so maybe some voice disturbance will be there. So you rightly said, Urvashi, there are a lot of challenge from what we see and what we get to hear. I work in a private hospital with having schemes, and our hospital is spanning across two different parts of Mumbai, in Borivali, in Kolaba. There are very, very different socioeconomic status patients we see. So having a scheme and even realizing that you can afford a scheme also is the first challenge. Many times the population we want to address, maybe they don't have the basic ability uh, to even do documents what require and to apply for a scheme. So the awareness first is not there. Second, they are not aware what are the steps to be done for that. That's where the role of NGOs and lot of a very honestly, there's a lot of a skewed approach. Many a times people who are affording have their own personal insurance, because India is a country where out of pocket expenditure is, we don't have a national health scheme like UK or US. So people who can afford also take the benefit of schemes where they can pretty well do it. And because they have connections, India is a country, and now I with age I've started willing it is same for every country in the world, where you apply your connections to the higher authority and get a lot of privileges. So this also happens with cancer patients. Many times people who actually need it are doesn't have the reach to the right people, and people have money and they take a lot of advantage. So there's a lot of exploitation of the government schemes as well. I'll tell you a real scenario. I'm working 8 years in this center in HCG. So we many times see people applying for scheme where they could have afforded, and someone else who really deserve could have taken that benefit. Now you tell me, how do we run? Because the schemes what government promised that to run you get certain amount back from the scheme, that average time, because they have some software update and other things, we currently face a challenge with PMJ for 6 to 8 months of waiting to get that much of money, which already is a subsidized rate. So as a private hospital, the existence also becomes a challenge, that if you have to run all of these. So these are basic few challenges. Then, of course, a treatment related challenge, I'm sure my colleagues would agree also. Many times, from a government, I would say, a clerk would appreciate that, okay, you need a scheme, you need to do a certain treatment, that's it. Now, treatment has ramifications, treatments have evolved over the ages. So many times they feel, no, you don't need these advancements, it's okay. But that's not the case. That's not a justice. Just because I'm treating someone maybe under some government scheme, I just can't do anything which is backdated, which is a decade old. So I would say these are a very, very tricky challenges. So, like you said, you are one of the person who has experienced both the sides. So we need more people to come out and speak that what's the real challenge in it.
Yeah, thank you. Thank you so much. And you rightly pointed out various issues with respect to even awareness of the schemes, then making sure that the right people get it, they are utilized, the benefits are utilized in the right way. So I think there's a lot of those implementation, monitoring, payment related issues. But I think also the fact that you spoke about the treatments, and I think even in Ayushman Bharat, if I look at my type of cancer, which is ALK positive lung cancer, we have very outdated treatments which are covered in Ayushman Bharat. You have an outdated chemotherapy. They don't even cover a first generation ALK inhibitor like crizotinib. Whereas now the world is kind of saying, first line, we should be moving even to lorlatinib, so which is a third generation inhibitor. So now when I think of it, then it almost feels like we are saying that some lives are less valuable than others. And I've been really advocating against this, that, this cannot be the case. So we need to figure out that why do these innovative clinical trials not come to India? A lot of companies will take the trials to Singapore, but they won't come to India, which has the largest patient population in the world. And so the government needs to work with the pharma companies also to see how do we, address these barriers, how do we address these regulatory challenges, so that our population, whether it's rich, whether it's poor, we can all have access, to the best possible treatments. I mean, after that, of course, it's our individual destinies, but to even deny somebody access to the best medication and give them some old chemotherapy feels like a huge injustice. So I think that's a very, very important point that, you have very rightly raised there. If I can bring in Dr. Priya, also similar sort of question. You're again Mumbai based, I understand. So would be great to hear your perspective on where do you think, we are really lacking? Where should we be going from a policy point of view?
Hi. Thank you, Urvashi, and thank you, Vivek. I am from Mumbai, and because I talk a lot, so I have limited myself to a sheet of policies. I am from Mumbai, but I'll talk about Durgapur. Recently, I was called to Durgapur, which is a small place in West Bengal. To one of my juniors called me to operate on a patient who had a tumor in the trachea. Okay, trachea. It was a palliative surgery, a big tumor which was blocking almost the entire of trachea, causing a lot of respiratory problem to the lady. And now he said that, madam, this lady is actually a part of a government scheme of the West Bengal, but the patient cannot travel anywhere. They are really unaffording. They are illiterate. I said that this is a borderline resectable tumor. It's actually a palliative surgery. It's a very borderline. I may not be able to join the trachea. Best would be to stent the patient and radiate maybe. Ideal candidate for surgery, but borderline. I may not be able to get the patient back, and it's a very small town. The hospital is not even a very big hospital. He said, madam, issues. That's not a big setup. Patient is not going to afford stenting. The scheme does not afford a stent. The scheme does not cover a stent. Patient is not able to go up outside the town. They don't understand anything. They have said, जो होगा patient का इधर होगा, जिंदा रहेगी तो रहेगी, मरेगी तो मरेगी. She was just 45. So we all pooled in money, got help from another hospital I go to. He flew me out. He operated the patient. We formed a WhatsApp group, me and the junior doctor of the colleague of mine, 4 ICU technicians. The anesthetist was a general surgery anesthesia, general anesthetist. We formed a WhatsApp group. The patient is due for discharge tomorrow. Okay. She was lucky. We managed to get a 5 centimeter. We removed the trachea. We managed to get it somehow together. It's a palliative surgery, and she'll get radiation probably under the scheme. But it highlighted a few issues. One, the policies have to include things like stenting for issues like this, because everything is not surgery, medical oncology, or radiation oncology. We have to include things which are beyond that also in terms of oncology, because it's rapidly evolving, like you yourself said, ALK. Right. So along with targeted therapies, there are also interventionals which are coming in as the quality of life and the duration of life is increasing. Similarly, these things are coming in. Second, Tata Hospital cannot be everywhere. So I think the government has to stop looking at cancer is equal to TMH. We all are TMH products here and there, but it cannot be like a horse which thinks like this, like TMH is like the goal. But TMH has got such fantastic doctors, but if you're going to pull the entire infrastructure of the country in only TMH and put crores and hundreds of crores only in TMH, it's not going to burn the horse. You have to put infrastructure in all the periphery hospitals which are existing. They may be government hospitals, but they need the infrastructure in those hospitals, because a TMH cannot be built in every place. And people of the town cannot go to TMH, even if they can, because TMH cannot accommodate. It's just the crowd is too much. The population is ever expanding. But a same place, if we don't put 10 OTs and there are 14 OTs and there are 20 operation theaters, but they will still not accommodate. Rather, if they can put those resources in the peripheral hospitals and make those people more trained, and the resources to go to the more peripheral, probably the government will spend less money and make those people more trained to deal with these things at peripheral levels. Tata also will breathe one less, they'll breathe easier, and things will be able to reach at peripheral level, because there are people who are interested to do it, but they don't have the resources to do it. The third thing is that the targeted therapy, which you've already mentioned. So my 2 cents is that one is that the resources have to reach the periphery. They have to include things beyond surgery, medicine, medical oncology, and radiation. And like what Dr. Basu has said very rightly, that the money which is spending to private hospitals has to start coming in, because I don't think private hospitals can sort of go through the schemes unless they start getting paid for the previous ones. That's, I think, what I can think of, what we can do. Thank you.
Thank you so much. Thank you so much, Dr. Priya. And I think you've made such an important point with respect to, we can't burden certain centers of excellence. They will remain, yes, our centers of excellence, no doubt, whether it's TMH or, we find like AIMS in Delhi, we still find people coming from all over the country. And it's too much, yes, it's an excellent place, but it is too much to burden, one place. And it is so much of expense and inconvenience for people as well, right? Who are coming from all over the country. And yes, exactly. And as you said, most schemes don't cover that. Yeah, please.
If I may add also, if you imagine the patient from Durgapur is already not affording, if they shift base to Mumbai for next 3 months for the ladies' surgery, the entire family shift. So they are going to be just more poor at the end of 3 months. So they cannot
Absolutely.
afford. So
yeah. Yeah, absolutely. No, that's a very, very important point. And so I think it's a great point to bring in Dr. Amit Kumar, who I understand is based in Patna. And we know that, the health infrastructure, of course, in states like UP, Bihar has been particularly challenging, even though there have been advancements in recent years. But where do you really see the, government schemes placed there in terms of implementation? And what do you really think is lacking in terms of, what we need to do better for patients, as well as make things easier for, healthcare providers to be able to do their jobs more efficiently? So, Dr. Amit Kumar.
So definitely government schemes has got a more impact. So you have to first think which cadre of society you are dealing with. The major thing happens, I will say, if you are dealing with a BPL patient that is a below poverty line. So those patients are still getting the schemes. The major sufferers are the lower middle class. That is the group which doesn't get anything from anywhere, and those need the most, I will say. The lower society, they got all that, they have been enrolled in the Ayushman schemes and the other schemes, they get easily funding, I'll say. So I'll just say I have got an experience of working at AIMS Delhi. AIMS Delhi has got that model that everything is free. So if a patient comes to an AIMS Delhi, so no chemotherapy he has to buy from outside. They give, though they doesn't get the expensive medicines, but all medicines for the baseline they get it free. So, but the problem is beds are limited. So only few patients get treatment at there. TMH, the best model in the country, which shows that the cost of the treatment cuts down and therefore many people are able to afford. So that's the place where the lower middle class even gets afforded if they go enroll because the cost is really less. So that happens. But I have an experience of working even at Mahavir Cancer Sansthan from Patna, which is, I'll say, has also the, at one time it is second to TMH in the enrollment. They enroll something around 20 to 22,000 patients a year. But they have got a good setup. I'll say 95% of these patients are treated due to the government schemes only. And those government schemes are that mostly are the CM Relief Fund, that is the Chief Minister Relief Fund, though they get 80,000 to 1,60,000 only. But the initial treatment is started with this treatment for this group of patients. The problem comes initially at the time of diagnosis. So the diagnostic money the patient doesn't have, because any government scheme requires a diagnostic biopsy or a diagnostic CT scan, which nobody is ready to pay. So the Center Mahavir Cancer, they have got that system that they pay from their own pocket from the Mahavir Cancer Trust 10,000 rupees to the patient. And this 10,000 initially helps in the diagnosis. The diagnosis report comes, initial treatment starts. But what is the problem with even with this trust or any other? The medicine comes at an MRP, which is a TMH model, which is not being followed at any other place. So the whole money gets expended in the next 3 to 6 cycles of chemotherapy. Thereafter, you have nothing left for the patient to further treatment. So the government schemes, the amount which they prescribe is just for the initial 3 to 6 months of therapy. And it cannot be reimbursed at least a year if even with Ayushman or other things. So most patients start suffering from that point of time. But definitely they have got a major role. The other class of the patient, that is the lower middle class, I would say they are the major sufferers. They really don't get any support from anywhere. Even for CM Relief Fund, they have to need a income certificate of less than 2 or 3 lakhs, which is not at all possible for anybody. So they are only somehow dependent on the PM Relief Fund. And that PM Relief Fund is very hard to get, only few patients in country able to get. And it's also center-wise, more people might be getting in Varanasi, less in Patna or in Bombay, it is something like that. But still, I'll say the Ayushman has added many things. So in Bihar, the system is different. Many people are poor. So their whole treatment depends on this Ayushman and the CM Relief Fund. And so few centers are doing. But even the private hospitals don't take because the cost cover is very less. And it is not, for to survive them with these cost of Ayushman or is really tough for those subset. But still, people are getting something, I'll say, with this schemes. It is the most important thing is the navigation part. Still, many patients doesn't know where to go the treatment, and it happens that the patient spends their whole money in a initial private setup or somewhere, and thereafter they comes to another setup where the exact treatment need to be started. So the navigation and the awareness about where to get the cancer treatment started and to go to the right place so that the money can be saved from the very beginning is also one thing which we have to start. So though there are many platforms now gaining a picture, so that has to be promoted more. So the patient comes day one at the right place and get the treatment best. So that's from my side.
Yeah. Thank you so much, Dr. Kumar. You made some very pertinent points. I think one on the lower middle class. I think in general, even in health insurance, we talk about this missing middle concept, where you yes, you are trying to do things for the poorer sections, and then the absolute top of the pyramid can take care of itself. But what happens to a large sort of middle chunk of that pyramid. And a lot of these people might not even have access to private health insurance. And even private health insurance, has its own set of challenges. Like I have access to it, but there's a lot of challenges in terms of them understanding the disease, the advancements in treatment, claims constantly being rejected for very valid things. Even though my oncologist is saying this is related to my treatment, but somebody sitting in that insurance company will still reject that claim. So these are very, very real issues, even I think for the middle class. And a lot of drugs are very expensive, even for people like us. Lorlatinib, for instance, from Pfizer is so expensive, even for people like us. So, for the poor, of course, it feels completely out of reach. But even for us, it's a huge burden. So I think that point you made is very, very valid about the middle, sort of segment as well. And I think the diagnostic part is also very critical because, like you said, if in my case, it was quite a journey to even arrive at an ALK diagnosis, and I was just thinking how many people can even go through that, either they have the awareness or the access or the, affordability, because you not only have to do, of course, your scan, your biopsy, then you have to do the molecular testing. So how many people really, would even be able to reach that level? So that is a question that, constantly comes up, and we should have provisions in the government schemes and policies that we make this diagnosis more easier and accessible for more people, because that's the very first step. And like you said, if people are taking long amounts of time and long journeys going from here to there, even trying to get a diagnosis, then they've of course spent money, they've spent time, but most importantly, probably their disease has worsened. If it was maybe an early stage, it might have reached a very advanced stage by the time they come to a proper diagnosis and to a proper oncologist. So I think very, very important points. And I'll now take the discussion to a very different geography. I believe Dr. Venkata Pradeep is based in Assam, the northeast. It's such a important geography, and I know that in the policy circles, it has become more important in recent years. There are more conversations, about what we want to do in the northeast. But I really want to understand from you, on the ground, do you see those changes coming in, and where do we still need to work much harder as far as especially a geography like the northeast is concerned?
Dr. Ushi, good evening. Thank you for having me. We have a team, Vivekji. Urushi, I work in Tejpur. It's 4.5 to 5 hours away from Guwahati. It's called Middle Assam. It's in between Upper Assam called Dibrugarh and Lower Assam Guwahati. So in between Dibrugarh and Guwahati, there is no other medical oncologist. So such is the crisis, which I would say, because people travel very long distance. As soon as they hear the diagnosis or suspicion of cancer, they travel all the way to south most of the times, either to TMH Mumbai or to Apollo Chennai or CMC Vellore. These three institutes are, these are like Gar Gar Ka Naam Hai. And whenever they have gastric problem, they go to AG. I don't know what is the trend, but this is for generations together. Even if you ask a small kid, he will say where to go for cancer. But then Assam government has come up with these 7 centers along with Tata Trust called Assam Cancer Care Foundation. And a lot of work is being done there. But as you ask for the government schemes, yes, I would say these are the lifeline for most of the patients here. And I would quote an instance just a few days ago when I went to one of the restaurant along with my wife. The hotel owner, the one who is serving me, and the one who is taking the order, all are the attendants of the cancer patients who are coming to the hospital. And such is the Tejpur is such a small place, and the incidence is so high. We don't know the reasons for high incidence of cancer here, but there's need for a lot of research of why there is an unusually high incidence of cancer occurs. And if you see, for example, breast cancer cases, they occur at unusually lower age, 16 years, 26 years, 32 years, who are all below the screening age. It's quite common here, and very aggressive cancers. and most of them are surviving on salaries anywhere ranging from 15 to 30,000, I would say. And when I went to my tailor, he is taking like 500 rupees for stitching a pant, and he's chewing this tobacco, this tamul, very voraciously. And I'm saying to my wife, if he gets head and neck cancer, the way his oral cavity is, without Ayushman, that he would not survive only. So government schemes definitely are the lifeline, without which many of would not be able to access even cisplatin or paclitaxel carboplatin as well. And but paradoxically, in Assam, from August 2024, Ayushman has been withdrawn in almost all private hospitals, quoting some instance. But then it has been the patients have gone haywire and where to go, because they are dependent a lot on private hospitals, particularly in cities like Guwahati and Dibrugarh, where there are a lot of cancer hospitals. And even now, they are not reinstituted, and patients have to travel quite a long distance. When I say long distance, it's quite long. And alternate week, I go to Nagaland, Dimapur, and Arunachal Pradesh, Itanagar, and sometimes Bomdila to work in hospitals with government schemes to provide chemotherapy. So I travel 5 to 6 hours, but the patient travels 10 to 15 hours. So there are areas like Mokokchung, Jubenboto in Nagaland, where they have to travel by chopper, or they have to travel like 10 to 15 hours via road. And so they come with a lot of hope, and almost all of them hold some of the government schemes. If you ask me specifically which government scheme is better in these three states, I think Nagaland has one of the best state government schemes, which actually allows the physician also to give some of the targeted therapies and immunotherapies. I am not aware of any other state government scheme which allows such treatment. For example, as you quoted, for ALK positive cancers, for EGFR positive cancers, best of the target therapies can be utilized. However, I also feel that there should be a committee to determine, or there should be ESMO-based MCBS guidelines should be before approval, because there is a chance that, because everywhere the funds are limited, we cannot go on forever giving immunotherapy. So there comes the role of these low-dose protocols by TMH, which are actually lifeline for most of these patients, particularly the head and neck cancer patients. And because the cost comes down to 1/6 of the original price, most of the instances, the metronomic therapies and all these things. So Nagaland has one of the best schemes, I would say, and Arunachal to some extent has also very good schemes. And if you ask me whether they are really success or failure, it would be very hard to say, but there are so many barriers to overcome. One important barrier is, I think we need to monitor the quality of the care provided under these schemes, because just a few days ago, there was a patient with lung cancer who presented with a low saturation, and when I'm going through the reports, she had this ALK positive report, and she was started on erlotinib 150 mg. And I was so much disheartened to see an ALK positive patient being missed under targeted therapy, because she is the patient who is a professor in one of the colleges, and she is very much affordable to at least first generation or second generation ALK inhibitor. So while we are trying to create more and more centers, the emphasis will be on government as well as the higher institute like TMH and AIIMS to monitor or guide the government in a proper way, because as Dr. Priya rightly said, government is mostly dependent on TMH and AIIMS for the guidance on which protocols to follow. So while in cities the scenario is different, in the towns, or I would say in very rural areas, they are very, very challenging. Yeah. So for example, I would say there have been this screening project initiated by Honorable Himanta Biswa Sharma for screening 1 crore people. But then there's a lot of hesitancy. Last year, when I was in Assam Cancer Care Foundation, we initiated a project for 1,000 women screening, and we hardly were able to screen 400 women. The reason is hesitancy. And while we are able to, people are able to know about the Russian vaccine, which is not at all in India, and through WhatsApp and this thing. Are we not utilizing social media sufficiently to create awareness? Because if government says that mammogram, or if a TMH releases a video, that mammogram will help, particularly to penetrate to the rural areas, so many people will undergo screening. And as far as the quality of life, most of the emphasis is on treatment, but the end of life care is not properly attended by these schemes, I would definitely say, because although there are packages for palliative care, for aesthetic tapping, for pleural tapping, for giving some of the medication for pain, most of these patients, when in the terminal stage, because there are no hospices, there are no proper palliative care centers, most of them go to the normal hospitals and land in ICUs, which should not be the scenario. They should not die in ICUs.
Yeah.
But this is not well addressed. The end of life care is not addressed. Although there is lot of emphasis on target therapies, immunotherapies to get more and more access, I think that's slightly overkill. While we are neglecting most of these patients who at stage 4 patients who ultimately at some point of time will require some amount of palliative care and supportive care or hospice care. So they should be with their family. They should have quality of death as well, like all of us. And rehabilitation, I don't think there's something called a rehabilitation in government schemes, but although everything should not be covered under government schemes, there should be a provision to guide them properly. So this is from my side. Thank you so much.
Perfect. Thank you so much. You covered a very wide array, but very important points. I also on the human resources that we have this huge shortage still of our specialists, and especially in certain areas, it's even worse. Like you pointed out, the issue of the trainings and the protocols. And then, of course, palliation, which I think still a lot of people understand palliation as only end of life. But actually, palliation, should start right from pretty much when your treatment starts. And that is something that I think we're very far from, getting there. End of life, similarly, like you said, highly neglected area in many, many parts, because it almost feels like a luxury. We're not able to get even the basics. Then anything else feels like, this is something extra, but it's not. It's something very, very fundamental. So thank you for pointing that out. Before we close, I'll just ask Dr. Priya and then Dr. Amit for their closing remarks, please. So Dr. Priya.
I do hope that this cancer conclave gets to more policymakers, and we are able to see a lot of positive changes which happen, and we see more and more good outcomes. I am sure that the entire government is working towards goodness, and the positive intent will lead to positive actions, and we are leading towards better times ahead. So crossing our fingers, and we all are doing our best, I'm sure. So we'll see good things in the future. We all are working towards it.
Thank
so,
you.
Amen.
Thank you, Dr. Priya. Yeah, thank you so much. Dr. Amit, anything you'd like to say in closing?
So I think so there should be a health insurance type thing for everybody. So it should be equality, not only poor, middle class, upper class. So everybody should have some policy from the government. Either you take an insurance or either a government scheme. So nobody should be denied from treatment. So we find it hard for the middle class really to arrange the treatments. Others, we have got policies, but we have to think over for others also. Thank you.
Perfect. So, Dr. Pradeep, anything last words? You've already said a lot for us to chew on.
Yeah, government have to collect compulsory tax for the health insurance, just like for vehicle, for the scooty to bench car, if they can collect the insurance, make it compulsory. So why not 100 rupees per month or something like that from the salaries? They should make it compulsory.
Yeah.
And yeah.
No, I really hope that some of these suggestions actually get implemented. Certainly I will try, and I'm sure Vivek will also try through his platform to make sure it reaches the right audiences also in the policy space, in the government space. And thank you very much to the incredible panelists, Dr. Kumar, Dr. Priya, and Dr. Pradeep. We also had Dr. Basu, but I think he's dropped off. So I think we've had a very, very rich discussion and a lot of takeaways. So over to you, Vivek.
Thank you so much, Roshiji. And because I believe that the time has come for towards the evening, wherein we are all eagerly waiting for the last session. Dr. Kumar is here. Sir, I welcome you, and maybe you can introduce your panelist, and we can get started. And in your panelist, if I have the permission, Mr. Kishore is there from Tata Memorial Hospital. He is the medical social worker head. Dr. Amol Patel is there from Army Hospital. Dr. Akash is there from AIMS Shajjar, NCI. And Sanjeev Sharma is there from Lung Connect and UTSA Foundation. Yeah.
Thank you.
Sir, over to you, sir.
Hi, good evening. Good evening, everyone. Can you hear me?
Yes, sir. Yes, sir.
So, good evening, everyone, and maybe we can start the session. So, starting with Mr. Kishore, and we know that patient advocacy is in infancy in India, but slowly picking up well. And there are now group of people interested, getting together, doing things to see that patient advocacy improves. So we can request Kishore ji, because I think so he handles one of the center and one of the social work department, which is actively participating, and they can take pride in the kind of goodwill they have. So how TMH can leverage the community support to enhance cancer care in the society, Kishore ji? And can you share some of your examples, some of the practices, what you focus upon and your advice?
Yeah, sure. Thank you, sir. Thank you so much. First of all, for giving me an opportunity. Am I audible?
Yes.
Okay. So before, we start upon what are the leverages which we can influence on the others, let us first of all see what actually the programs we can plan and what are those programs which we can execute. First of all, we have very good number of people's been, as a donors stepping in hospital, as our hospital has a very good will. So one is walk-in donors, and secondly, the programs which we have planned is one is emotional support. Second is, as I said, financial support. And for financial support, walk-in donors are there. Plus, there are certain NGOs to whom we have collaborated, plus TMH, CSR companies, government schemes. And in addition to that, in-house funding is also very important. Apart from that, we also take care of accommodation, railway concession, medicine waivership, patient support group we do execute, entertainment programs we do job, rehabilitation services, whichever NGOs are doing for that, we act as referral agents for them. We do conduct educational support or sponsorship program. We have certain NGOs being tapped where we can take care of out-of-pocket expenditures. And there are, as I said, in-house funding. In in-house funding, there are seed money, supplementary money, and SIF. Now, seed money is something where at an initial stage where investigation is required and nobody like government schemes or no other things which step into to provide certain type of helps, especially for investigation, there TMH has in-house funding where we give seed money as a 15,000 at initial stage, and later on, whenever he is required, 10,000 plus. And apart from that, whenever he is admitted as a supplementary, we do provide 10,000 rupees at an initial stage, and then thereafter again 10,000 rupees. So totally up to 45,000 from in-house we do get to support these patients. Plus these funds like government scheme funds are there, NJPJY state funds, and center fund like Ayushman is also there. Now the basic thing is when we start something like this, we are very eager to reach out to those patients who actually are in need of, and for that purpose we do see the corroborating evidence or documents such as income certificate from the competent authority. One, and secondly, the what spending capacity he has, or what actually he has spent. As you said, to share some of the examples. Day before yesterday, there was a patient who was planned for surgery, and Mahatma Phule, MJPJY, said that they will provide 1 lakh rupees, but they have to come at least 2 days prior to the surgery. And at that moment, they understood that MJPJY is not providing 1 lakh rupees, but only 25,000 rupees will be, issued to that patient. And that was a period where she was very much stressed, was not understanding what to do at the last moment, because there wasn't anybody who can come and help at this point. So in this sense, we were there and we tried to accommodate something from SIF. SIF is something which we approach to the companies to get some CSR funds as a SIF. So in this fund, we generate fund through various donors, through companies, and through the walk-in donors. So from that donation, from that pool, we were able to manage somehow, and that surgery took place. So these are some challenges which we are facing day to day. Sir, over to you.
Thank you, Mr. Kishore. And in fact, I'll request anyone interested in doing these kind of activities to spend some time with Mr. Kishore and his team. Absolutely wonderful, the kind of innovative things they do, kind of the hard work they do, the way maintain the data set, the kind of goodwill they have, absolutely phenomenal. I've learned a lot interacting with you and your team, Mr. Kishore.
Thank you, sir.
Maybe we'll go to the next question, and next question is to Dr. Amol. Dr. Amol, armed forces are very well known to have people-centric initiatives. How is the any patient advocacy programs for patients in armed forces, and if they have any support group, and how they operate there? Dr. Amol?
Yeah. Hello, sir. Good to see you.
Hi.
So, in armed forces, everything is quite structured, and there is a beautiful organization is known as AWA, is the Army Wives Welfare Association. So basically, there are two aspects in this question. One is the patient advocacy, and another one is the support. So for supporting these patient almost in all command hospitals, and in fact the zonal hospitals also, there are activities going on. Like there is a order, we call it as part 1 order or part 2 orders. In that, the particular activities are taken place every week, and in a week, twice or thrice, these ladies will come to the hospital. They will interact with the patients, their relatives, and there will be some activity for 2 hours, like sometimes the games, sometime is about nutrition, and some dignities coming every month or 2 months, and some basically multiple aspects of human life, they are all covered. During this time also, they come to know with some kind of problems in the issues with the family, what is they are suffering, as any posting related or money related, or maybe something else. Sometimes there is a husband-wife conflicts are there. So such things are brought to the notice to the hierarchical system, to the commanding officers, and we try to solve their personal problems also. So for supporting, as such, the medicine is all 100% taken care by the hospital as such. But the other aspects of human life, including their personal, social life, and there are extended areas where they're looking after the children, and where they are going to stay in the because everybody travels from far places to the command hospitals. So where are they going to stay? So all these things are looked after by the hospital. The other things, we have the structured organization under that the organization known as Prerna. So this Prerna works for these cancer patients in all the 7 command hospitals. We took a further lead at INHS Ashwini in the last year, along with Sharma ji, and we form under one head, that is IKEM. You are not alone in your journey, and we celebrated the patient's journey. We try to interact with them, and then, sir, after that or the event, we try to build a group, a separate group for the like breast cancer, lung cancer, and there are interactions are happening among patients. But to take it to the next level of advocacy, somehow this part is missing. I would say that, because the advocacy part in terms of the patients, because the empowerment of this patient clientele themselves is not yet there. What they want, what their needs are there. So to address this systematically, there is a core concept, and the core unit has been established at Army Hospital R&R, and a separate unit is now functioning for looking after their palliative care to multiple aspects of whatever the patient advocacies are there. Rest of the things about the clinical trials, then the drug availability, new drugs, these kind of knowledge to our all patients and their relative, I think there is these things are lacking. Everything is put on the head of the doctor and the treating team, and aap hi kar lo jo karna hai. So the part of the patient advocacy somehow is not building up it. I believe that there is a lot of scope in making that and taking that forward. Yeah.
Thank you, Dr. Amol, and that's beauty about Army, that you learn many aspects apart from the government, the structures it provides, and Army itself builds a structure, and also how the family members can take initiatives to have support system in the society. So that is very unique, and many of us can learn from it to see that if you want to implement certain things. Maybe we go to Dr. Akash. And Dr. Akash works in a very unique center, and absolutely center of excellence. We all know about it. So, Dr. Akash, what kind of patient-centric initiatives you want to share from AIMS, and which people can emulate or can get inspired by?
Good evening, sir. Sir, when we started the center, there are few things that we tried to adopt, and after having some experience at main aims, few things that those we wanted to adopt were the patient inconvenience that they are facing at various cancer centers, the rush and all. So when we started our center, the first thing what we did was shift all those patients who were waiting at main aims, emergency, or new patients who are waiting for we shifted all the patients to NCI, and we started treating. At least we should start somewhere, because we always knew once the people get mouth to mouth publicity that there is a new center come up and their facilities are better, the word will be, everyone will know very soon that we are there to take care of them. So the first thing what we did was that everyone who were waiting at main aims, we took them there. Another thing was, sir, as you know, it is little bit far off from the city. The most important thing was the convenience, the transport, the stay, that was to be taken care of, because they come from far off. The treatment is very intensive. They have to stay for long. Then toxicity part. In that situation, sir, in that sense, we were very lucky that Infosys gave us a 500-bedded guest house, and we are really indebted to those people. I think they have done a remarkable job at Tata also. That has been a really game changer. So people come there. The costs are very nominal. They stay here for long, children and everyone. So that has really helped us a lot. Another thing, sir, that we tried to do was, we kept more patient coordinators in between. There have been times that somehow patients are not reaching the doctors, not because that doctors they don't want it, because they are too busy. So for those tumors and those malignancies where there is MDT is involved, they don't know where to go, where the samples have to be given, where radiation is there, where surgery is there. So we try to have an interface between doctors and patients. These patient coordinators helped a lot. So this convenience part we could take care of. Besides, we immediately went for this Jan Aushadhi Kendra, Amrit Pharmacy, along with all the schemes that we started, so that they should not have any problem with the drug procurement and the economy part. Whatever we can provide, the rules are the same as main aims. So we got Ayushman and everything there. Besides, sir, we also contacted the peripheral centers, medical colleges. We contacted GV Pant, we contacted LH, we contacted RML, PGI Rohtak, SMS Jaipur, all our colleagues, that if you get a new diagnosis of malignancy, acute leukemia or time sensitive, you should talk to us rather than sending them to AIMS emergency and then they keep waiting for bed and someone to take care of. So some personal touch we also gave, that spread by word of mouth. And it is just an inertia. Once it starts, then it never stops. So thankfully, now we have reached a stage that we are now getting completely full. But this, and then the talent pool, the team that we had to choose, the radiation oncologists, surgical oncologists, we are still lacking on that part. Because some good people are leaving, because recruitment part is a big problem at main aims. But still, we could keep some, and this work is ongoing. So that's every day we have to keep looking for good nursing staff, any MTS from the lowest level to the highest level. We need good people who have empathy and they can behave properly to patients and all. So that part is ongoing. So that is the thing.
Thank you, Dr. Akash. And AIMS is again one of the place we all get inspired and learn every time there are initiatives, which is always very inspiring. So I move on to the next question to Sanjeev. Sanjeev, I know that you have been actively involved in the patient advocacy for a long time, from your pediatric days to subsequently many adult groups, and now you also have actively made Lung Connect. So do you want to talk about how one can have this overall advocacy program in India, how one can encourage people, how one can have more and more people getting part of it, and that to ensure that the voice of the patient and the caregiver, that is louder than the voice of the clinician and other people.
Yeah. Okay. Thank you, sir. Yes, sir. Yeah. Thank you, sir. So, सर अगर 1 साल पहले आप मुझे ये बात पूछते तो शायद मैं सोचता हूँ कि एडवोकेसी क्या है, कुछ नया चीज है, और मैं उस पर उतनी अच्छे तरह से बात नहीं कर पाता. लेकिन अभी जब मैं बाहर जाके देख के आया तो सब लोग वही कर रहे हैं जो हमारे देश में सालों से हो रहा है, जो लोग कर रहे हैं. फर्क इतना है सर कि वहां पे लोगों को फंडिंग मिल जाते हैं इंश्योरेंस कंपनी से या बाकी जगह से. हमारे यहाँ सबसे ज्यादा जो प्रॉब्लम है पेशेंट को, तो सारे जो एडवोकेट हैं, जब से एग्जांपल किशोर सर या बाकी लोग हैं, सब एफर्ट उनके फंडिंग में लग जाते हैं, उनको कि कहाँ से सबसे पहले उनको ट्रीटमेंट कराएं, ये जरूरी हो जाता है. इस वजह से सोच नहीं पाए कि और आगे क्या करना चाहिए नहीं. बट डेफिनेटली एडवोकेसी, सब एडवोकेसी के पार्ट है. फंडिंग हो या नेविगेशन हो या एकोमोडेशन देना, किसी भी पेशेंट को अगर हम कोई हेल्प करते हैं, दैट इज कम अंडर एडवोकेसी. लेकिन अभी टाइम आ गया है कि हम लोगों को इससे बाहर निकलना चाहिए. जो हो रहा है वो तो होते ही रहेगा, ये चलते रहेगा, लेकिन इसका सॉल्यूशन क्या हो सकता है? तो हमें पॉलिसी मेकर, क्योंकि अनफॉर्चुनेटली यहाँ पे जितने लोग बैठे हैं सर, हम लोगों में से कोई पॉलिसी बना नहीं सकते चीजों को. पॉलिसी मेकर कोई और है, और इसका अगर सॉल्यूशन कहीं से निकलेगा तो वहां से निकलेगा. तो हम लगता है कि एडवोकेसी वहां पे करने की जरूरत है, लाइक आयुष्मान भारत. सो वी आर प्राउड एज ए इंडियन कि पूरे वर्ल्ड का सबसे बड़ा लार्जेस्ट इंश्योरेंस है. लेकिन वहीं पे अनफॉर्चुनेट भी है, खास के वो पेशेंट जिनको की टारगेटेड थेरेपी लेना पड़ता है, जो कि इसमें इंक्लूड नहीं है. अब जैसे किशोर सर बात कर रहे थे डायग्नोस्टिक का, तो कोई भी इंश्योरेंस में डायग्नोस्टिक कवर नहीं है. और जब तक अगर डायग्नोस्टिक नहीं किसी व्यक्ति का होगा, तो उसके ट्रीटमेंट के बारे में क्या सोच सकते हैं? तो एक गवर्नमेंट को आना चाहिए, इससे पहले के पैनल में भी बात कर रहे थे इंश्योरेंस का, या सरकार के आयुष्मान भारत में भी आना चाहिए कि इंश्योरेंस आयुष्मान भारत लाए किसके लिए? गरीब लोगों के लिए। आज के तारीख में एडवांस डायग्नोस्टिक करने के लिए कम से कम 30 से 40 हजार रुपए खर्चे होते हैं। जो हर दिन कमा के खाने वाले लोग हैं, उनके पास ये फंडिंग मुश्किल है, मुश्किल नहीं बहुत मुश्किल है कि वो कहां से कर पाए। तो एक तो डायग्नोस्टिक करना चाहिए, दूसरा आयुष्मान भारत में टारगेटेड थेरेपी करना चाहिए, और सेकंड क्वेश्चन था आपका सर कि कैसे हम लोगों को इसमें इन्वॉल्व करें, ज्यादा से ज्यादा पेशेंट को लाएं, केयर गिवर को लाएं ये चीजों में। सो एक तो मुझे लगता है कि मैं इतने सालों में देखा, जो भी लोग मिलते हैं, चाहे वो पेशेंट हैं, केयर गिवर हैं, या नॉर्मल कोई भी व्यक्ति हैं, जब वो बात करते हैं क्या काम करते हो, और जब बताते हैं तो बोलते हैं वाह क्या काम कर रहे हो, बहुत अच्छा, हमें भी करना चाहिए, हम भी गांव जाके करेंगे चीजों को, लेकिन नहीं कर पाते हैं। मैं ये नहीं बोल रहूंगा कि वो क्यों नहीं कर पाते हैं, हो सकता है कि वो करना चाहते हो, लेकिन साथ में उनकी अपनी भी जीवन है। क्योंकि एक अगर हम देखते हैं, सोचते हैं, एक पेशेंट को यहाँ पे रह के 6 महीना 1 साल पूरा ट्रीटमेंट करा के जाता है, तो जो उनका जमा हुआ पूंजी है वो भी खत्म होते हैं, जो कमाने वाले थे वो भी खत्म होते हैं, और जो उनका फ्यूचर है डेफिनेटली वो कई साल पीछे चले जाते हैं। तो जब यहाँ पे वो रहते हैं और हम सबका काम देखते हैं तो उनको बहुत अच्छा लगता है, लेकिन वो जैसे ही घर जाते हैं और जब अपने रोजमर्रा की जिंदगी में जब वो ब्रेड विनिंग है कि अपने फैमिली का, तो उनको वो भी सोचना पड़ता है कि हम कहाँ से अपने फैमिली के लिए ये चीज करें। तो इस वजह से नहीं हो पाता है। हमें लास्ट मीटिंग में भी हमें पूछा गया था कि लोग क्यों नहीं आ पाते हैं, उससे मुझे लगता है कि एक बड़ा कारण ये है। तो अगर हमें जो भी फार्मा कंपनी या इंडस्ट्री या जो भी लोग बोलते हैं कि हमें और एडवोकेट करना है, बहुत सारे लोग करना है, तो हमें लगता है कि उसके लिए हमें उनका जो जीविका है, उनके लिए सैलरी है, वो हमें इंतजाम करना पड़ेगा। अदरवाइज इतने साल 20 साल से ऊपर मुझे हो गया टाटा हॉस्पिटल में, जो देख रहे हैं इतने दिन वॉलेंट्री में, कितने लोग हाथ पे गिन के देखेंगे सर तो एडवोकेट मिलेंगे पूरे देश में। हम एक टाटा का बात नहीं करते, और मुझे लगता है रीजन यही है, बाहर का देश में वो पैड होते हैं, वो उनको सैलरी मिलती है, उस तरह से वो काम करते हैं। हमारे देश में इसका जरूरत है, और ये भी साथ में कि जितने ज्यादा एडवोकेट होंगे उतने हम पॉलिसी मेकर से या बाकी के फोरम पे हम बात अच्छे तरह से रख सकते हैं और स्ट्रक्चर वे में और काम कर सकते हैं। जी सर।
थैंक यू संजीव जी। ऑलवेज बहुत आपका आपको सुनना हमेशा बहुत अच्छा लगता है, क्योंकि मेरे ख्याल से अपार्ट फ्रॉम किशोर जी, इस ग्रुप में आपने इस एरिया में मैक्सिमम देखा हुआ है, समझा हुआ है, बहुत जगहों पे किया हुआ है, एंड यू हैव शोन कि नहीं, सोसाइटी के साथ बात करके, सोसाइटी के साथ मिल करके, सोसाइटी के साथ इनिशिएटिव लेके पेशेंट की सहायता की जा सकती है। तो ये एक बड़ी रिमार्केबल चीज है, इसलिए आपके साथ इंटरेक्शन हमेशा ही बड़ा फ्रूटफुल रहता है, एंड आई ऑलवेज एंजॉय इंटरेक्टिंग विथ यू। तो दीज वेर जो वेरियस पर्सपेक्टिव जो कि हमने सुने, डिफरेंट ग्रुप ऑफ पीपल, जो they are all very successful, or their organizations are very successful in many patient centric initiative, and I'm sure audience will be enriched with listening to them, and hopefully some of them will get inspired to take up this patient advocacy work. What Mr. Sanjeev said was important. Ultimately resources are required, whatever we want to do, and we need to see that society understands that investing in these kind of initiative is ultimately very useful for society. The return back to society is huge, but initially as it is not seen that what the society gets, usually people are not interested in investing. But I know I've seen it happening. I know this was the something about unique about Tata Hospital, which I learned that once you invest in these things, the return is very huge and very sustainable. So if this any panelist has any last word to say? I know Dr. Amol, Dr. Akash, or Mr. Sanjeev, anything?
What I need to say here is the empowerment of the patient. Somewhere, I believe it is missing at multiple levels. So many of the patients, what TMH or the other institute where the quite a bit of experience is around 70 years now. But the empowerment, rest of the country, there is no talk about it. And in a busy schedule of busy OPDs, even at my command hospital, almost 90 patients I have to see in 6 to 8 hours. It becomes quite, only the work which is best, dawai lo, aao jao. There is no time, there is no discussions on empowerment of the patient. So somewhere the advocacy groups, these the conferences, they should be represented in each and every aspect of small or little conference are happening. This is my suggestion. So wherever the academic conferences are happening, I suggest that by law or by somewhere as a you are the secretary for the ISMPO, and there should be a one topic for the patient empowerment or some patient related whatever, like manogat, whatever we call it in Marathi or in Hindi, that's ki man ki baat. So let them speak about their journey. एक या दो patient के लिए mandatory कर दो. They let them that कि भाई सिर्फ doctor आते और खाना खा के चले जाते. Shouldn't be happening that. It is for them. We are working, we are learning from them. So our life is for them actually. So कहीं ना कहीं एक empowerment वाली बात शुरू होनी चाहिए. That's what I want to insist here.
Thank you, Dr. Amol. Anyone else has? Yeah.
Sir, sorry, I would just like to conclude with one thing. What I feel is that now that there are so many aims coming up at different centers, so many Tata centers are coming at different centers. There's no way we can blame everyone. I think we need to strengthen those centers so that patient can get treated, evaluated, and everything at those centers. This is the only way forward because we cannot compete with private sector any day. And there can be no scheme that can provide, government can't provide immunotherapy for because it is unending. So the only way is to have a judicious use of funds, judicious use of the best services. When these government centers and the peripheral medical colleges, center medical colleges, I mean state medical colleges, they come up, they're good people, they have a SOP, and then we can help these patients substantially. Thank you, sir.
So, Dr. Amol and and Akash made a very important point, and just emphasizing what Dr. Amol suggested that, and Amol, we where I have some active involvement, that is one lung year-end review and lung master class we do. Both of them we have a social worker session which is separate and also integral part of it, because I have two people here who can vouch for it. Not only that, Lung Connect we actively initiated, and and we also ensured that there's a distance maintained from the doctors. So doctors are not the people who establish it, who are not the key member who runs it. And they have a full session and also they are part of main session. So we do it, but I agree with you, more needs to be done. That they have many more platforms and many more places.
Yeah, I'm aware of that. So what I'm trying to say is it should be expanded now. It should be happening.
I agree with you. We need to have many more places where, once the patient and caregiver voice are heard, automatically we become more sensitive, and that is always.
Yeah. Yes, sir. Amol sir, मैं दो शब्द ऐड करना चाहता हूँ कि we are just launched buddy program. लिखा एक इन लंग कैंसर लंग कनेक्ट बड़ी प्रोग्राम। क्योंकि बहुत कम हमें नेविगेटर, बहुत कम जगह पे हमारे नेविगेटर हैं। मतलब वो भी अनफॉर्चुनेट ही मैं बोल सकता हूँ, जैसे टारगेटेड थेरेपी अनफॉर्चुनेट है, वैसे ही लोग काम इतना ज्यादा करते हैं नेविगेशन। लाइक अगर हम उदाहरण दें कि अगर मुझे टाटा हॉस्पिटल जाना है, गूगल हमें टाटा हॉस्पिटल तक पहुंचा देगा, लेकिन अंदर कौन से डिपार्टमेंट में कहाँ जाना है वो गूगल हमें नहीं पहुंचा सकता। वो गूगल नेविगेटर होते हैं कि जिनको कोई जरूरत है वो। अनफॉर्चुनेट हमारा सिस्टम ऐसे है कि उसको सैलरी देने के लिए हमारे को कोई तैयार नहीं होते। आज अगर हमें कोई बोले एक पेशेंट है, इसका बोन मैरो ट्रांसप्लांट करना है, टाटा मेमोरियल या तो दूसरे जगह पे कहां से फंडिंग होंगे, हम गाइड कर देंगे। एंड मोस्टली हमारे टाटा में वो 20 या 30 लाख का भी फंडिंग हो जाएगा, लेकिन अगर एक नेविगेटर के लिए तो नहीं होगा। तो इसके अल्टरनेटिव हम लोग ने सोचे कि जो हमारे पुराने पेशेंट हैं या केयर गिवर हैं, उनके थ्रू ही हमें पूरे पैन इंडिया में बड़ी प्रोग्राम करें, ताकि उनको टाइमिंग दे सकें कि वो जितने भी है वीक में 2 दिन या आधे, सॉरी 2 दिन नहीं, हाफ एन आवर का 2 टाइम्स, ये चीजें हैं। तो ये चीजें हैं हमारे यहाँ, कुछ ऐसे चीजें हैं कि बहुत अच्छे काम कर सकते हैं, चाह के भी लोग नहीं कर पाता है, क्योंकि लैक ऑफ बोल सकते हैं फाइनेंस और लैक ऑफ इंफ्रास्ट्रक्चर चीजों। जी सर। एंड सर लास्ट ये है कि 3 चीज हम लोग एडवोकेसी में आगे करना चाहिए। एक तो बहुत दिन से हो रहा है अवेयरनेस अवेयरनेस अवेयरनेस। जब से मैं ये क्षेत्र में आया हूं तब से अवेयरनेस के बारे में सुन रहा हूं, लेकिन जो इतने दिन में देखा हूं, आई थिंक हमारे जो प्राइमरी हेल्थ केयर है वहां पे अवेयरनेस की बहुत ज्यादा जरूरत है, ताकि वहां से लोग डिटेक्ट जल्दी कर सकते हैं या कैंसर को। और दूसरा कि अगर हमारे एमबीबीएस जहाँ पे हमारा पढ़ाई जाता है वहां पे कैंसर के बारे में कुछ पाठ शुरू हो, ताकि वहां से ही लोगों को पता हो कि कैंसर क्या होता है। आई थिंक अनफॉर्चुनेट नहीं है वहां पे, शायद आप लोग बेहतर बता सकते हैं, एमबीबीएस में नहीं है चीजों को। दूसरा कि इक्वलिटी ऑफ ट्रीटमेंट हमारा सब जगह बात होता है, सबको मिलना चाहिए। ये तभी हो सकता है जब हमारे देश में रिसर्च का इन्वायरमेंट हो, हमारे देश में मेडिसिन बने, हमारे देश में नए नए रिसर्च हो, ताकि मेडिसिन सस्ता मिले तो सबको मिलेगा। जब तक मेडिसिन सस्ता नहीं होगा सबको ट्रीटमेंट नहीं होना। तो एक रिसर्च होना चाहिए। और तीसरा, एडवोकेसी में हमें गवर्नमेंट से बात करना चाहिए। जब तक गवर्नमेंट बहुत सारे अच्छे काम कर रहे हैं, लेकिन और भी करने की जरूरत है, और जितने एडवोकेट है सबको मिलकर करना चाहिए। थैंक यू सर।
So thank you everyone. It was very inspiring. Everybody having different initiative, different ways of functioning, and hopefully we'll all pick up from each other, and also from people, audience will pick up some of them. Thank you so much. Thank you so much. Back to Mr. Vivek. Vivek again is a good initiative. Vivek, again these are topics which gets missed, and as highlighted by Dr. Amol, these are those kind of topics which needs to have a discussion. So this is a good forum we have made where people can express and have a discussion on these kind of topics. Thank you. Thank you so much.
Thank you so much, sir. And with this session, we have come to the conclusion of the discussion or the panel discussions. Now we are moving towards a person who has been quite patient before the conclave started, and is equally partner in all the initiatives that Uhapo takes. He is none other than Mr. Umesh Nath Sharma. He is my co-founder. And Umesh comes from a very rich background, more than 2 decades, 2.5 decades. He has worked in oncology industry, and that's how his connects and his insights have been invaluable to all of us. And because of that only, it acts as a gate opener at many places. And we are grateful to have him today. And I would request Umesh to go for the vote of thanks.
Thank you very much, Vivek. In fact, it's been a pleasure as always listening to you all. Thank you, dear faculty members and viewers of Cancer Conclave 2025. I believe we touched somewhere around 1 lakh views at certain time. That's an amazing number to have. This is our third annual Cancer Conclave. We started this with our objective to bring all the stakeholders on one platform and have an unbiased discussion that leads to some tangible outputs. The number of viewers that I was mentioning virtually who connect probably shows that we are in the right direction. Before I sign off, I would like to thank our mentors. Especially here, I would like to mention Dr. Kumar Prabhas sir, Dr. Vijay Patil, Ms. Urvashi Prasad, and there are many others also who have always guided and supported us in being at the right path and giving us the right direction. Our sponsors for this year, NATCO, in fact, NATCO has been with us for all 3 years. Thank you very much. And also AstraZeneca, who got associated this year. Our technical partners, VC Now, and our dear Uhapo team. We look forward to see you again next year and wish you all the best for 2025. Thank you once again. Thank you very much.
Thank you so much, everyone. With this, we conclude the Cancer Conclave 2025 today. And this is actually not the ending, but just the start. As you all are aware that this conclave is, it's kind of a brainstorming session for us that sets the path for the rest of the year. And as Mr. Swasti Charan was speaking about, we will be making a report out of this conclave and we'll be submitting in all the government and government offices, and we'll be sharing with all of you as well. And from here, a different journey starts for this year. Thank you so much. So grateful to you for being with us today. Thank you so much.
Thank you. Thank you.